Kozhikode. Now we begin our first scientific session on Nipah epidemiology and transmission. The invited speakers for the session are Dr. Emily Gurle and Dr. Vidya Arankale. To chair the scientific session, we have Dr. Mohanan Veliyavital and Dr. Anish T.S. Now introducing the chairs of the session, Dr. Anish T.S., Professor and Nodal Officer at the Kerala One Health Center for Nipah Research and Resilience at Kozhikode. He is the convener of the State Expert Committee for COVID-19 and Public Health Consultant to the Kerala State Disaster Management Authority. Dr. Anish is a leading voice in public health, disease surveillance, and disaster preparedness. We are honored to have him here to moderate the session. Dr. Mohan Veliyavital, it's my privilege to invite Dr. Mohan Veliyavital, scientist at Institute of Advanced Virology. He has served as an assistant professor and associate member of the School of Graduate and Postdoctoral Studies in the Department of Microbiology and Immunology at Chicago Medical School, Rosalind Franklin University of Medicine and Science, USA, and as a faculty at Cochin University of Science and Technology, Kochi. His research interests focus on the interaction of viral proteins with host cellular molecules and the development of monoclonal antibodies. We are honored to have you, sir, here to moderate the session. Let us begin this scientific session. We have Dr. Emily Gurle online for her invited talk. Dr. Emily Gurle is a distinguished professor of practice in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. Her interests include development of novel surveillance strategies for the prevention of emerging diseases such as Nipah virus. She has served as a director of ICDDRB's Emerging Infection Program. Dr. Gurle is lead for the bat virus spillovers evidence compendium, which is building a publicly accessible summary of all existing evidence about bat virus spillovers. She also serves on the board of directors for the American Society for Tropical Medicine and Hygiene and as a commissioner for the Lancet Commission on Prevention of Viral Spillovers. I kindly request the chairs to take over the session. The timing of the talk for each speaker may not exceed 30 minutes. The speakers can have a 25-minute talk followed by a 5-minute discussion and Q&A session. Over to the moderators.
Welcome to the first session of our conference today. I welcome Dr. Gurle to deliver her talk on the topic, One Health Approaches to Investigating Spillovers from Cause to Prevention. So there are 2 speakers in this session. Each speaker will have 25 minutes for their presentation, followed by 5 minutes question and answer. Dr. Emily Gurle, I welcome you to this conference.
Thank you so much, and good morning to all of you. It's a bit late here on the East Coast of the United States, but I still agreed to come and join all of you because the topic is so interesting, and I'm really so happy to have the
Hello,
chance
Dr. Emily.
to... Yes, can you hear me? Can you hear me?
Yes, yes. Please go ahead.
So I guess you didn't hear me before.
Yes, now it's audible.
Great.
Yeah.
Thank you so much to the organizers for the kind invitation to join you, and good morning to you all. It's a little bit late here in the United States, but I'm happy to be up so that I can join this interesting session. Today, as they've mentioned, I'm going to talk a bit about Nipah virus transmission and One Health approaches to investigating spillover events. So we know that bats carry Nipah virus, Pteropus medius in South Asia, and we know that bats transmit the virus to each other. Obviously, the reproductive number is greater than 1 in transmission between bats because they're the reservoir species. But actually, we understand little about how transmission occurs and how bats' immune systems function when they're infected with Nipah virus. This is an ongoing area of study. We've done cross-sectional and longitudinal studies in our work in Bangladesh, and this figure is from a paper written by John Epstein. You'll hear from him later today in your session. But it's easy to find bats with antibodies usually, and the seroprevalence can vary quite a bit from 20% or less, even up to sometimes 80%. But finding bats shedding Nipah virus is actually very rare. There are no clear seasonal patterns that we've been able to see in Bangladesh regarding seroprevalence, although we do see some shedding patterns. If you'll notice on this figure in gray, you can see human infections of Nipah virus and when those were detected over time. In orange, you can see when we detected bats shedding Nipah virus. So typically, in these kinds of longitudinal studies, we find bats shedding more in the spring and summer, but the human cases we find more in the winter. This is an interesting contrast that you should keep in mind as I continue my talk. So as you probably know, ephrin B2 and B3 are the receptors for Nipah virus, and these receptors are highly conserved across mammals. So in theory, this means that all mammals with these receptors are susceptible to Nipah virus. And this also, of course, is linked to the pathology that we see in humans. If we consider where bats are transmitting and likely shedding, at least sometimes, this virus across the world, we see that it's really a wide geographic area. And I've estimated that about 5 billion people live in this shaded area where bats that carry Nipah viruses also live. That's about half of the world's population. So when we think about why Nipah might be important, this geographic distribution of the reservoir host is one important reason. So bats transmit Nipah virus to each other. They also transmit Nipah virus to other mammals, including pigs. And if you're familiar with the history of Nipah, then you'll know that the first time Nipah was identified was during an outbreak in pig farms in Malaysia, where not only had pigs been infected, but they also infected each other. And again, the reproductive number was greater than 1. This is very concerning for a virus to be able to reach this critical threshold of onward transmission in a new species. But the outbreak propagated through the commercial pig farms, and that's when Nipah was first identified. As you also may know, that outbreak ended when they culled the pigs on those farms. This was a very drastic and devastating control measure, but also very effective. So what other animals have been infected with Nipah? Horses have also been infected with Nipah, and there was an outbreak detected in the Philippines, in fact, that was where humans were infected by sick horses. This is also a similar feature to Hendra virus, which is a kind of sister virus to Nipah. And Hendra virus typically is identified spilling over into horses in Australia. So the viruses are similar in this way. In Bangladesh, we've identified a number of other species that have antibodies against Nipah. So for 7 years, every time we identified a human case or a human spillover of Nipah, we would visit those sites and sample the animals that lived near the human cases. We found cattle, dogs, and cats with IgG antibodies against Nipah at various sites around the country, which suggests that in the areas where humans are being infected, other animals may be infected as well. So, as I just mentioned, we have some evidence that dogs have been infected also in Bangladesh. What about people? And in public health, primarily we're interested in what happens to people. So how do people become infected with Nipah? Well, in Malaysia, they became infected through contact with sick pigs. And most of the cases they identified worked on pig farms. They also identified human infections among abattoir workers in Singapore because they were slaughtering some of the pigs that were infected with Nipah. The outbreak I mentioned to you in the Philippines, humans were infected through contact with sick horses and slaughter of sick horses. So when the horses became ill, their owner slaughtered them to sell the meat. And this is the most likely way that humans were infected through horses. I told you that we have evidence of dogs and other mammals being infected. There were dogs also infected in the Malaysian outbreak, but we don't really know if these animals have transmitted to humans or not. In Bangladesh, we've studied risk factors for Nipah among people for many, many years now, and we've never identified any strong signals through our case control studies to indicate that other animals are related to transmission. But we can't rule it out. Importantly, however, humans can also be infected with Nipah directly from bats. And this is something we know a lot about in Bangladesh. In Bangladesh and also in some of the initial outbreaks of Nipah virus in India, which were in the eastern part of India near the border with Bangladesh, humans were infected with Nipah virus through consuming date palm sap. This is an old photo of a date palm sap tree. You can see the clay pot hanging in the tree here to collect the sap overnight. I took this photo on the first Nipah outbreak I ever attended, which was more than 20 years ago. And at the time, we didn't know how humans were being infected, but we guessed that this could be one very good way where humans might come into contact with bats through this shared food source. As you all know, in Kerala, it's still a bit of a mystery how humans are being infected, but I would guess it's probably some direct pathway from bats to people. And I know that there are scientists there working on this important question. So I would like to make the case to you that, well, in Bangladesh, spillovers happen every year, and they're happening in, more frequently or being detected more frequently in India. And each of those spillovers is an opportunity for the virus. If we think about the question of Nipah from the perspective of the virus itself, those viruses and microorganisms are looking for new ecological niches. And so every time there's a spillover, the virus has another chance to find a new niche. And that's something that we should be actively working to prevent. So I'd like to talk a little bit more now about spillovers. And I'm going to use SARS-CoV-2 as an example. So I'm sure you all recall when we first heard about SARS-CoV-2, what was the first news we heard? First, there was a large cluster of atypical pneumonia cases, right? This photo is from the Spanish flu, but it shows the same concept that the first time we hear about some of these emerging infections is in a large cluster of human cases, something we don't expect to see. And then what happens next? By the time we realize it's happening, usually transmission is already happening way beyond the initial outbreak site. And this is just because we're never as fast as we need to be in finding those outbreaks. Then what's the next step? Well, usually they go and try to figure out, well, where did this virus come from? And here, very quickly, they were able to show that the sequences of this new virus were very similar to bats from, or to viruses found in Rhinolophus bats. And then finally, the last question that is asked is, how did this spillover happen? But by then, the trail is cold. You know, we're already too late often to understand how the spillover happened, and this is really a problem for us. I would say, because unless we understand how the spillover is happening, then it becomes more difficult to prevent it. Now, the same steps were how we discovered Nipah. First, there was a large cluster in humans. Then they realized there were also some cases happening in Singapore. Then they looked for the bats, and they found Nipah virus in Pteropus bats. And then clues about the spillover again came last. And one of the points I would like to make to you in this presentation today is that we need to be looking for the spillovers and not waiting until we see large clusters of cases happening. Because if we find the spillovers, that will give us very important information about how they're happening. We need timely One Health investigations to uncover how they're happening. The other advantage is that, you know, spillovers are much more common than the larger outbreaks. This is a map of Bangladesh, and for 10 years, the first 10 years of our studies there, we identified about 8 outbreaks around the country. But in those 8 outbreaks, there were 50 spillovers. So you can see all the red dots here on the map. Those are all the spillovers we found. And many of them were single, isolated cases. So if you can imagine, if we only waited for the outbreaks, we would have 8 opportunities to learn. But if we find spillovers, then we had 50 opportunities to learn. So our ability to become smarter is much better. And here's something that we learned once we were finding spillovers consistently over time. So this is the number of spillovers that happened each year between 2007 and 2018. And you can see there's a clear increase in some years and then a decrease again. And this was very puzzling and helped us generate some hypotheses about how spillovers may be occurring. I'll just note that we realized that one of the primary drivers of the number of spillovers each year is temperature. So colder winters have more spillovers, and we think this is probably because people drink more sap when it's colder. We used ecological studies to try to understand how bats were contaminating the sap. So you can see here in this photo, so this is a black and white photo of the surface of the date palm tree, and the tap sticking out is where the sap will drip out. You can see the bat's face and the bat's tongue, where the bat is coming down to lick the sap stream. And these studies helped us to understand how the sap might be contaminated with Nipah virus from bats, and helped us to think about how we could keep the bats out. Based on those studies, we then pursued qualitative and anthropological studies to try to design prevention messages. So one of those efforts was to tell people not to drink sap, and we developed some materials like this poster you can see here on the left that explained to people how the sap became contaminated and explained to them why they shouldn't drink the sap. We also developed interventions like this, where we trained people to just cover the top part of the pot and the shade surface of the tree so that bats couldn't get in and contaminate the sap. This was all part of our One Health approach, where we used multiple disciplinary perspectives, ecology, anthropology, as well as virology, veterinary medicine, and epidemiology to understand how spillovers were happening and how we could prevent them. I want to let you know that we've just launched a course on One Health investigations of outbreaks and spillover events. It's on Coursera, and you can join for free. All of the materials are available to download and use in any of your courses if you think it might be useful. So I'll encourage you to check it out if you're interested in One Health. All right, so let's get back to transmission. Now that we know how humans are infected, what about person-to-person transmission of Nipah? Because this is one of the things that makes us worried about pandemics. So far, the reproductive number is much less than 1, and we've estimated it's about 0.3. We've done a number of case contact studies to investigate person-to-person transmission, and I'll just go quickly through and show you that the majority of Nipah patients don't transmit to anyone else. Only about 10% transmit to anyone else. And we saw no relationship between the number of contacts a patient had and whether or not they transmitted to another patient. Most secondary cases were family caregivers and who had contact with body fluids and a long duration of contact with the case. We do, however, observe super spreading events, and you have observed those in India as well. I just want to make one point that although the reproductive number of Nipah is well below 1, for older patients, adult patients with difficulty breathing, it's about 1. So when we think about prevention, especially in healthcare facilities, adults with difficulty breathing should be prioritized for interventions to prevent spread. We reviewed all the evidence about person-to-person transmission in Bangladesh, India, and the Philippines, where this has all been observed. And we saw, despite differences across the contexts and probably some differences in the virus, the epidemiologic characteristics were very similar. So about 1 in 10 patients transmitted in each setting. Most of the patients who transmitted onward were adult males. Almost all of them had respiratory symptoms. And the highest risk group for secondary transmission were family caregivers. Although our understanding of how transmission happens between people, where it's shed, what the viral loads are is very, under-investigated. There are very few published papers with any biological specimens and measurements from humans. I would say the Nipah outbreak in Siliguri in 2001 was one of the scariest outbreaks from a person-to-person transmission perspective. I won't go into too much detail here, but there was transmission across multiple hospitals. It's great that we don't see this kind of transmission today, but it's just a reminder that we have to take this virus seriously. We've done a lot of interventions in Bangladesh to try to improve infection control, including cohorting Nipah patients in special areas where we can provide hand washing stations and masks and gloves. And these interventions showed that people use them. If we provided hand washing stations, people use them. And if we provided masks and gloves to healthcare workers, they also use them. So these are good tools we could use to reduce risk. So I'll end here with some good news about Nipah virus. We've known about this virus for more than 25 years, and so far all of the outbreaks have been contained. R0 in people is much less than 1. And we've learned a lot about transmission. And basic infection control is likely sufficient to stop transmission as it currently happens. Vaccines are under development, which is a really exciting new frontier for Nipah, and I hope we'll get more good news from those areas soon. But I would say there's some bad news. And the first is that the context for transmission of Nipah is dynamic. Let me tell you what I mean. So areas where Nipah outbreaks frequently occur in Bangladesh used to be a long way from the capital, but they have this beautiful new bridge now, so it's less than a 2-hour drive. So this has changed how patients seek care, and more patients come to the capital now, and they seek care in ICUs. So now you have patients coming from endemic areas to areas where Nipah is not endemic, and healthcare workers may not be as aware about Nipah. They're also getting interventions in ICUs that they haven't had access to previously, which can provide some opportunity for transmission. There's also online sale of frozen date palm sap now, which also means that we're delinking where people currently drink sap and where they can drink sap. Freezing date palm sap would be a great way to keep the virus alive and stable and bring it to a new host. So the context for transmission is changing. Rapid field-based diagnostics are rarely used. I think this is also bad news because if we use them, then we could be better with our targeting of infection control. And transmission is highly heterogeneous, as I showed you. Some patients are much more likely to transmit than others. We don't understand why. So this leaves us in the dark about what could change about Nipah or its epidemiology that would increase the risk of larger outbreaks. I would guess that many spillovers and many different species still go undetected. So even though we're building surveillance systems, we still have a long way to go. I would say we should expect the unexpected. They mentioned already in the introduction BATCOM, which is our review of all bat virus spillovers. This review is ongoing, and we hope to be launching our website later this year in 2025. So thank you so much, and I'm happy to take questions.
It was an excellent presentation, Dr. Gurley. And thank you for sharing your insights with us. Now it is time for questions from participants. Participants are requested to ask questions that they would like to.
I see one question in the messages. Can I answer that one?
Yeah, sure.
Let me start my video. Hi. So the question is, in Kerala, Nipah occurs in the summer or the rainy season instead of during cold weather. What's the explanation? The reason that Nipah occurs in the winter in Bangladesh is because of date palm sap consumption. So most people drink date palm sap in the winter. It's a delicacy that's consumed in the winter. So that's when we see spillovers. I would guess that the seasonality of your cases in Kerala is also related to the spillover mechanism somehow.
Thank you, Dr. Gulli. I have one question. So, have you now started to look at co-infections with, different paramyxoviruses in bats, because bats are reservoirs for multiple viruses, right?
Yes, yes, they are. We've done some studies where they're looking at all the different viruses that we've identified in urine. And you could give many talks about all the viruses that we've identified in bat urine. The question is not how many viruses are in bats, but which ones really are a risk for humans, I think. And at least based on the surveillance we have now, the viruses that we're finding in humans are pretty similar. So that could mean that the other viruses really aren't a risk for us, or maybe the interface isn't right for those viruses to transmit. I don't think we know.
Okay, thank you.
There's another question here. Why are outbreaks only found in Kerala and India, even though the bats are distributed throughout the country? You can ask that question for all of South Asia. In my experience, if you don't find spillovers unless you're actively looking. So perhaps other patients with Nipah-like symptoms aren't being tested in other areas as much as they are in Kerala.
Yeah, Dr. Gurley, I'm Dr. Anish. We have met a few times. Yeah.
Yes, sir.
Yeah, one comment is regarding the Nipah spillovers in Kerala, why it is in summer. Some explanations are there. One is it is the breeding season for bats here. And the second one is it is the fruiting season. So there may be spillovers because of that. And nowadays the summers are extremely hot. The climate change may be one of the contributing factors. And so many theories are there. But my question is, what is your opinion about Hendra virus acting as a disease X or something like that? And the Nipah affected area may be affected by Hendra because of these viruses are similar. What is your take on that? When is it possible that these areas can have large outbreaks of Hendra in future?
We haven't found Hendra virus in Pteropus bats in Asia. Just like they haven't found Nipah in Australia, where they have Hendra. So it seems that these viruses have somewhat of a different ecological niche. I mean, you know very well that viruses change over time, so it's possible that Nipah viruses that are circulating in Asia today may become more like the Nipah viruses in Australia in the future. It's possible. I think that any Nipah virus, we should assume or presume it has some risk of transmission to people unless we can show otherwise. I don't know if that answers your question, but.
My question is, there was some partly overlapping area, the Queensland area of Australia, where we have got Pteropus medius. So if Pteropus medius can harbor some of the Hendra virus, so that is a possibility. And another thing is, if you look at the eastern part of Africa, the Madagascar and all these areas are also the home of this Pteropus medius. So this Nipah virus can transmit to Africa. So these kinds of possibilities, so maybe in future we have to think about. Yeah. Thank you.
Of course. And Nipah viruses have been detected in other species of bats as well across the African continent.
Hi, Dr. Gurley. I am Dr. Srikumar. So it was an excellent presentation. So I had one question. So you said that you could detect antibodies in dogs. So at any point, could you see also symptomatic animals, or are there any studies going on those directions?
Yeah, thank you for the question. We have studies going on now looking for symptomatic animals in areas where we know that humans have been infected. So we have surveillance for sick animals, and we also are using serology and trying to track cohorts of animals over time to see if we can identify spillovers.
Thank you, Dr. Gurley, for the excellent lecture. So I'm Dr. Aravind. I am an ID physician. My question is, from your Bangladesh experience, have you been successful in isolating the virus from date palm sap?
No. And I'll tell you why. Millions of people drink date palm sap every year, tens of millions. We see a few spillovers every year. So when you identify someone who has Nipah, you really want to test the sap that they drank a week ago. We tried some studies to look for Nipah virus in random pots of date palm sap, but we didn't find any. But we wouldn't expect to find any because this is a very rare event.
Thank you.
Thank you, Dr. Gurley, for your wonderful presentation and for joining us. Thank you so much. We will now move on to the next speaker. Thank you.
Thank you so much.
That was really a huge information on Nipah outbreak and spillover surveillance. Thank you so much, Dr. Emily. Hoping to meet you at our next event. Now, I request Dr. Mohanan Veliyavital to invite and introduce Dr. Vidya Arankale to the session.
Okay, I will take over. Dr. Vidya Arankale is a pioneering virologist with over 5 decades of research leadership in viral hepatitis, emerging infections, and vaccinology. She served as director grade scientist and group leader of hepatitis at National Institute of Virology, Pune, and later as head of communicable diseases at IRSHA and Akhtar chair at the Akhtar Research Institute. Her career has been defined by translational virology, immunological insights, and public health impact. Dr. Arankale's research spans hepatitis A, B, C, and E viruses, chikungunya, dengue, respiratory syncytial virus, and Nipah virus. She has led a co-lead over 25 major national and international projects funded by ICMR, DBT, BIRAC, and international collaborators including NIH and WHO. Her work has contributed to development of indigenous diagnostic kits, vaccine candidates, and immunological testing platforms. She played a key role in genomic characteristics of Nipah virus during West Bengal outbreak and has contributed to India's preparedness for emerging zoonoses. Dr. Arankale's legacy in Indian virology is unparalleled, and her insight into viral pathogenesis, immune response, and vaccine development continue to shape the field. So I very happily inviting Dr. Arinkale for her talk on the topic, Dynamics of Nipah virus transmission in India. Ma'am, welcome.
Thank you. So good morning to you all. I am also in Seattle currently, speaking from here. First of all, I would like to thank the organizer for inviting me for this symposium. And I'm very happy that IIV is organizing this because of the time and place. Time, because we are in the 25th year after the first outbreak of Nipah happened in India, that is 2001. And secondly, it is Kerala, where the almost yearly outbreaks are currently going on. So the topic for my today's presentation is dynamics of Nipah virus transmission in India. Dr. Emily has made my job very easy, and some of the slides may be overlapping, so I will skip them. Next slide, please. So this is the discovery of the virus. She has told about this. This happened in Malaysia, and the discovery of Nipah virus. So I think I want to skip this slide. Next slide, please. So this I just want to show you 3 different countries with 3 different patterns. Again, she has spoken about this, but Malaysia, it was the infected bats, the virus going to pigs and then to humans. But then there was no human to human transmission in Malaysia. Singapore, it was like a zoonotic disease from infected pigs which were imported from Malaysia to human. Again, there was no human to human transmission. Philippines was different in the sense that the amplifying host was horses and there was also human to human transmission. It is very important for us to also realize that no further outbreaks have been reported from all these 3 countries. Next slide, please. Next slide, please. Now I'll go to India and Bangladesh because they are similar. Both India and Bangladesh, they reported the first outbreak in 2001. India, Jan-Feb, and Bangladesh, April-May. Both the outbreaks, retrospective analysis with the help of CDC, because that time there were no BSL laboratories available. And the NIV publication was delayed 2006, whereas the Bangladesh came up in 2004. Most important is both the studies have shown person-to-person transmission, which was not earlier very well documented. In case of Bangladesh, there was no intermediate host. Such studies were not done during Siliguri outbreak. And importantly, both in India and in Bangladesh, the disease is still continuing till 2024, although the sites are different. Next slide, please. Now, these are the 8 outbreaks of Nipah in India. First 2 in West Bengal, and 6 are in Kerala. The most scary, of course, is the Siliguri outbreak with 66 cases and 74% mortality. And Kerala, of course, this 2018 outbreak also was quite scary with 91% deaths. Next slide, please. So this is the same slide that was shown by Dr. Emily. But what I thought was that I will show you the sequence of events because that is it is easier to understand the transmission. And then we'll go into the bat studies whenever they are done. So this is the first one, the Siliguri outbreak, where of course in most of the cases actually the index case is either not known or the diagnosis is not there. So in this case also the index case is not known, but there were 11 cases in one hospital and then they were admitted to different hospitals. The most important actually you can see is the patient that was admitted in Medino hospital, and he gave disease to 31 people, 23 staff and 8 visitors. So in this case, this was a clear person-to-person transmission and also nosocomial transmission because even the visitors also were infected. Next slide, please. This is the Nadia outbreak, the typical intrafamilial spread. This is the only outbreak where we can say that we are very close to the spillover event. None of the other outbreaks we can actually identify a spillover event. In this case, the index case actually was addicted to country liquor and which was derived from palm juice. And we saw a lot of hundreds of bats actually were hanging from the trees around his residence. So this is one clear evidence of spillover in case of this Nadia outbreak. And 4 of his family members and 1 caregiver, all people died. So this is another scary outbreak. Next slide, please. So naturally, after these 2 outbreaks, the scientists started looking for the virus source. And because of the because of the Malaysia experience, bats and pigs were the likely animals to be tested. Next slide, please. So these are surveys among bats that I'm telling. This is the first survey actually that was taken up. This was in 2009, 2010. So at least 3 years after the last outbreak of West Bengal, and 3 different species of bats were tested. And what we can see is that one liver homogenate from the gingivitis species was positive for Nipah virus RNA. And again, the sequencing was done, and of course it was matching to the earlier sequences from India and very close to the Bangladesh sequences. So this is the first time that we have seen that the Pterovus bats could be the reservoir of for NIV in case of India, and if spillover event occurs, we can have an outbreak. As rightly pointed out by Dr. Emily, it is very hard to get these spillover events, and we come to know about the outbreak only after a few cases have actually arisen. Next slide, please. Now, actually, a large number of pig samples have been tested from different parts of India, and they all are negative for antibodies. Therefore, it seems that pigs don't play any role in, or not an important role in transmission of Nipah virus. As told by Dr. Emily, even cats, dogs, and in one case, a cow have been shown to be infected with Nipah virus. In fact, cow, they were telling sick cow, and she also is having virus also. But these are supposed to be the dead hosts, and they do not play important role in transmission of the virus, and such animals have not been really tested in India. Next slide, please. So in West Bengal, basically no outbreaks since 2007. Now we have seen that the bats were carrying the virus after 2007, but why there is no Nipah case, we do not know. Whether it is rare infection of bats, or it is awareness, or it is both. We do not know the reason. That's why Nipah is, means we are fortunate, of course, that why Nipah is quiet in Bangladesh. Another thing that is very clear is there is no intermediate host. It is directly from bats to humans. There is nothing intermediate involved in case of, so far in case of Indian outbreaks. Then the other important things are actually about these infection control practices which are there in our hospital settings. And except in few ICUs, the control practices are not being followed. And you never know when a Nipah patient is going to come to your hospital, and then who is going to be infected, and only after that person dies or gets diagnosed, you are going to know that yes, there are Nipah infections in particular area. So this is one problem. And patients did not use masks. Neither the caregiving people or family contacts, they use the mask, and that is how maybe the number of cases have increased. As rightly pointed out by Dr. Emily, in Bangladesh, they have taken appropriate measures uh, so that the outbreak was curtailed. I am also going to come to Kerala outbreaks and what precautions they have taken now. So that story I'm going to tell about Kerala in some time from now. Next. Now let us go to Kerala. Next slide. This, of course, I need not tell you people actually, but these are some of the slides that I have made. This is 2018 outbreak. So again, the first patient was remained undiagnosed. The source is also not known. This patient was admitted in 2 hospitals. One hospital for 2 days and second hospital for just 9 hours. And in that much time, 10 people were infected, of 9 died. And in first case, 9 primary cases all died. And there were also secondary cases, and they all died. So this was a highly infectious and a highly transmittable virus, and it has killed almost 90% of the people who got infected with the virus. So I'm going to talk about the bats and everything in the next part. Now I'm just telling only about the events. Next slide, please. 2019, there is a single case, and that patient recovered. Of course, there was a diagnosis, and this was done at NIV. Subsequently, there was a laboratory in Kerala that was providing diagnosis, which is very important. But all these initial diagnosis was all made at NIV. Next slide, please. Now, this particular outbreak happened during COVID time. So, this is a boy, 12-year-old, and he got infected, developed encephalitis. And again, this was a Nipah outbreak, but there was no further transmission. From this point onwards, actually, they started tracing the contacts and testing the contacts. And they have shown that so far, none of the contacts have come positive for either for viral RNA or antibodies at the local lab. Because of the local lab, such studies were possible, and they were very nicely done in this case. Next slide, please. This is 23 outbreak. In this case, there were 6 cases, 6 total patients. Again, the first patient was undiagnosed. It was not Nipah as such, but after the spread was done to 5 more people, it was supposed to be a Nipah outbreak, and 1 person died. In this case, again, so many symptomatic and asymptomatic contacts were tested for the virus and for antibodies, and all were negative. So there was no subsequent transmission to the family members or the caregivers in this case. Next slide, please. So there were 2 outbreaks in 2024, one in July and one in September. Next slide, please. And large number of contacts were actually tested, and they all were found to be negative. So these are the single cases, but I do not know why for these 2 cases the diagnosis was done at NIV and not at the lab at Kerala. Actually, I'm not aware of as to why this has happened. Next slide, please. Next slide, please. So remember this about these 23 cases, the first outbreak. During this, initially Dr. Arun Kumar was investigating this outbreak, and he had studied 60 environmental samples. Actually, this included the samples from bats, the fruits, and other droppings, all were negative. Also, he tested pet rabbits and ducks of 1 case, and they also were negative. Then later on, NIV came in about 3 to 4 weeks after the first case, and a number of bats were collected and tested, and 25% of the Pteropus bats were found to be RNA positive. So again, the role of this Pteropus species has been highlighted by this study. And out of the positive bats, actually, even the liver and spleen also were positive. Next slide, please. This is same actually, but here again, the presence of virus was shown in the same species of the bat. Next slide, please. This is a single case. Again, in this case, actually, PRNT was done. This is important actually. 2 different types of bats were actually investigated, and antibodies were seen in both cases. But when PRNT was done, the neutralizing antibodies were present only in P. medicus and not in the other species. This again explains the role of this particular species in Nipah virus transmission, and also tells us that we should not be believing too much on ELISA positivity, because the other species, all the antibody positives by ELISA were negative in PRNT. So they were not actually Nipah antibodies. So one has to take care in taking sense from the ELISA results, basically. Next slide, please. I'm sorry for this. This is a little bit dark slide, but this I thought was very important because this was a planned study in bats. So February, July, and September, these are the 3 months where bat samples were to be collected. Of these, February and July are before outbreak. They happen to be before outbreak, and then there was outbreak in September. So you can see that in July itself, they have found out the virus in the bat samples. So this is first time this has happened, that before the outbreak, because of the continuous screening of bats, they could find the presence of the virus in the bat samples in July. And actually the outbreak happened in September. Of course, in September's collection also, the bats were positive for Nipah virus RNA. But important point is that if you start looking for the virus pre-outbreak, you can get the virus. Next slide, please. Then during these outbreaks, actually, again, environmental samples were collected. Even bad droppings were also tested. Unfortunately, none of these samples have turned out to be Nipah virus RNA positive. So there is no way to find out as to where are the positive samples, uh, droppings. So whatever we say that from where they are getting Nipah virus infection, but actually in field we are not able to show the actual presence of the virus in such samples, including except for bats, we are not able to show the samples, and how the spillovers are happening, that is really not clear. It has not been shown. So overall, during all these outbreaks, we can see that the role of bats is strongly suggested as spillover events. However, so far, except for Nadia outbreaks, no definite epidemiological link between bats and humans has been demonstrated. So this is something which is a challenge and which has to be taken up by the scientist. Next slide, please. Next slide, please. So these are because to find out whether Nipah viruses are present in the other areas of our country, surveys were conducted in different different states. This slide is for West Bengal and Assam, which was done in 2015. And 2015 also you can see that in West Bengal, Nipah virus was still present. But after 2007, we have not got any outbreak of Nipah in Bangladesh, in West Bengal. So the reason for having Nipah virus in the bats but no spillover events, whether it is that our lack of testing and there is a single case, or there are no actually spillover events, we need to find out. Next slide, please. Now, these are the studies done in South Indian states. So from Telangana, Karnataka, Tamil Nadu, Kerala, Orissa, and Pondicherry, bat samples were collected. All samples, of course, they were negative for the viral RNA, but antibodies were seen in different proportions in the bat samples. And what we can see is that bats from Karnataka, Tamil Nadu, and Pondicherry, where there are no reported Nipah cases, they are having I say about the 30%, 20%, 26% positivity for antibody to Nipah. So this is something very important to find out as to what did antibody positivity means. Now, number one, I think that they should be studied for neutralizing antibodies, which has not been done so far. And if they are actually Nipah antibody positives, then we have to really look for the spillover events in the other states as well. Next slide, please. This was one survey in Maharashtra. It was done because maybe NIV, because NIV is in Maharashtra. And again, but in this case, actually, the virus was found in non-pteropus species. So the importance of this particular observation, we do not know, as there is no disease, there is no Nipah virus infection in Maharashtra reported so far. Next slide, please. No, this is the most recent survey in 3 states, 22, 23. This is in Bengal, Meghalaya, and Assam. These are the bordering states with Bangladesh. And Bihar they have taken as an additional state. And what they have found out, that one sample each from West Bengal and Bihar was viral RNA positive, the Nipah virus. So the detection of viral RNA in a bat from Bihar is really alarming. So we have to look for whether there are any Nipah cases in Bihar. That has to be looked into. And all these sequences are similar to India and Bangladesh sequences. In fact, it has been suggested that all Indian sequences should be grouped as genotype I. I stands for India. Next slide, please. Now, this is the Kerala story I wanted to say. Actually, I was so happy to see that paper, that state ICMR and the state government, they came together. Then they had a facility for immediate diagnosis. Then there was an isolation facility for keeping the contacts till they come negative. So when all these things were done, the outbreak was curtailed. So this is something which Kerala people have shown that when they come together, they can really curtail the outbreak. But this on-site field diagnostic laboratory, I am not aware whether it is still working, because 24 outbreak, why the samples went to NIV is really not clear to me. But for Kerala, because there are cases, there has to be a laboratory very well equipped where immediate diagnosis can be done and a large number of samples can be tested. it could be expensive, but I think this is very much required for Kerala, because they have to have such facilities. Next slide, please. Now, the conclusions basically. So what I feel is that based on the, actually lot of studies have been done basically with 8 outbreaks and other studies. These are some of the key findings. The bats are most important transmitters, and not you do not require any amplifying host. That is very clear as far as India is concerned. And the initial case, actually, we attribute it to bat, but there is no spillover event that is strongly proven except for the Nadia outbreak. So that remains to be established. How the spillover events happen, that is a problem. And then the person-to-person transmission. This is playing the important role in for giving disease to caregiving family contacts as well as health personnel. Another question that I am feeling is that why, because Nipah viruses from Malaysia, it is M genotype. Why Nipah viruses from Malaysia infect pigs and Indian strains are not infecting is another important question, because pigs are also in plenty and there are bats also, but still we are not able to get even antibodies in pigs. So what is the reason for that? We have to understand. And although expensive, we have to have surveillance in bats, at least in areas where the outbreak prone areas basically. And also, as earlier I have mentioned, at least Kerala and maybe West Bengal now they don't have cases, but Kerala must have a very well equipped laboratory, or maybe 1 or 2 more laboratories where they can give this diagnosis absolutely within 24 hours. This is a requirement of the day. Next slide, please. No, and this is another one actually, importance of biosafety considerations in hospital settings, because hospitals work at zero biosafety basically, and they are the ones I know who are suffering with Nipah virus. Then another important factor is that people that has been shown in case of Indian patients, that whenever patients have predominant respiratory symptoms, they are high transmitters. Whenever they are having encephalitis, the transmission rate is low. So if somebody is interested, actually, that R values for such kind of patients may be found out from the published literature. And so unless you understand what is the transmission cycle or transmission level, you cannot plan a control strategies. And for us, because of these studies, at least in Kerala, appropriate steps have been taken and the outbreak is maybe under control. And I really wish that 2025, because we are already now in July. So July, August, September, these are the dangerous months for Kerala as far as Nipah is concerned. And I wish, and we all should wish, that 2025 should be a non-epidemic year and this should continue forever. Kerala should be free of Nipah and of course India as such. Thank you.
ఇదెప్పుడెళ్ళే పైన పెట్టం కుదరదే, అక్కడ మైక్రోబాలజీకి తీసుకెళ్ళిందేమో.
I think we will cut short the discussion part and we may allow 1 or 2 questions because we have got a time pressure and we have to quickly move to the inaugural function. Maybe 1 or 2 quick questions can be made. Over to the audience.
It was a very informative presentation, Dr. Arangale. I have a question. Some individuals in close contact with the infected patients do not get the virus or do not contract the virus. So I will give you an example. During the 2018 outbreak in Kerala, the index cases mother was affected, but other family members and hospital staff were infected. So what could be the possible reason for this? Despite close contact and potential exposure, the mother was not affected.
Yeah, this is very difficult to explain. probably the exposure was when exposure was not to that extent where they could get virus, or their immune system was very good. Antibodies were present or not?
Thank you.
As we have to move to the inaugural function, we will stop discussion now. If there are further questions, we will collect them and mail to Dr. Arankale. Thank you very much for your wonderful talk.
Thank you, Dr. Anish and Dr. Mohan, for hosting this session. Now we move on to the much awaited event of the day. For the official inauguration ceremony, I cordially invite Dr. Rajan N. Kobragate, Additional Chief Secretary, Health and Family Welfare, Government of Kerala, Dr. Simi Tiwari, Joint Director and Head for One Health, National Center for Disease Control, Government of India, Dr. E. Srikumar, Director, Institute of Advanced Virology, to please come to the dais. Now I invite Dr. E. Srikumar, Director, Institute of Advanced Virology, to welcome and address the gathering.
So good morning one and all. Welcome to the Institute of Advanced Virology and the one-day seminar on Nipah and other spillover infections. The concept of one medicine proposed in 1964 in a book by Dr. Calvin Schwei, where he mentioned about the one medicine concept. And I think it took almost or maybe more than 60 years for us to make that into a reality or as a serious a topic of a very serious concern. So it took a number of spillover infections, pandemics, and other emerging viruses which had a broad focus into this on health. So at the Institute of Advanced Virology, so even when this on health paradigm started, many governments and many nations started giving more focus into this on health as a major issue. And the very institute where we are sitting now is also a dramatic will of the state of Kerala to establish a center for virology research, an advanced center for virology research to focus on health. So we are extremely thankful to the government and to take such an initiative in a time where most of these emerging infections, like more than 60 to 80% of the emerging infections are caused by viruses. And we are happy that we are contributing in our own way and supporting the state public health system in taking care or controlling these emerging infections. And fortunately, we have been focusing on this on health for the last few years, and we have been conducting a series of seminars on health, and this is second in the series. The first one was a very resounding success, and we had lots of eminent speakers. And I'm sure that the second one, which we have started today with two wonderful speeches in the morning, online sessions. Unfortunately, they could not come in person and join, but they delivered extremely good speeches on the relevant topics. And I'm sure that this is also going to follow the same success that we could get in the first symposium. And the most importantly, we have very eminent personalities who have been agreed as speakers. And the last one, I remember the first meeting was also inaugurated by our chief guest of the day, Dr. Rajan Kobragade, who is the Additional Chief Secretary of Health and Family Welfare in Government of Kerala. We have a very long association with him, and he has been extremely supportive to the activities of the Institute. And as he always says, he's a person who is not focused on showing his face in many forums, but he wants to remain behind the screen in doing the services. But his commitment, and maybe I would also think that he will be one Secretary of Health who would have seen or dealt with most of the spillover incidents of Nipah in the state. And I think maybe all of them, not most, maybe I think one incident, I think he was on duty with some other division, but all the others spillover. And the willpower that he exercised during these kind of crisis situations is commendable. And I am sure that the ministers and all other people who rely on his service, they are very confident that he can deal with any situation. And we are fortunate that he could come over in person and address us and also inaugurate this today's program. And I am extremely thankful that he could make it possible. Welcome you, sir, for this event. Secondly, we have Dr. Simi Tiwari, who has also, we called her over the phone and she immediately agreed, but she was too busy to confirm the final itinerary and all that. So she very coolly said, "Don't worry, I will be there." So she was very reassuring in that okay, I will come and see. And she visits Kerala. I understand that she visits Kerala quite often. Especially, so she is also heading the On Health Center of the National Center for Communicable Diseases and in the ICMR. And this On Health Center, as I said, is taking a very prominent place in the country. And so she has also very gratefully accepted our offer, and she is also here to give a keynote address. So I welcome you also to the program. And most importantly, we appreciate the acceptance of our invitation by all the eminent speakers, including Dr. Guru Prasad and also Dr. Biju Soman and all the other people. Some of them, Dr. Shobha Maman, and she is here from Vellore. So all of them have agreed, and I am very happy that the moment we talk about On Health and we call them, we are conducting a meeting, they don't hesitate. They are just willing to come and give a speech. And those who cannot come in person, they have agreed that they will join online. And so I am sure that this is and all the people take this very seriously and as a major public health concern. And we are also happy that we could organize this symposium in a befitting way. So I thank all of them and welcome Dr. Guru Prasad, Dr. Biju Soman, and also Dr. Aravind and Dr. Anish. They also collaborated with us in organizing this. So we are extremely happy, and also we welcome all of you to this symposium. And I take this opportunity to once again welcome you, and we will start the function. Thank you.
Now I request Dr. Rajan Kobragade and Dr. Simi Tiwari to release the souvenir. May I please have you on the stage to release the souvenir? Thank you, Dr. Rajan Kobragade and Dr. Simi Tiwari. Now I invite Dr. Rajan Kobragade to officially inaugurate the function.
See, this in absentia, Sudhir sir, I will remember our principal secretary, science and technology. He is a very esteemed colleagues of ours, because in secretariat, Sudhir sir comes and what is the agenda of our government and honorable CM in science and technology, he takes it forward, and he is always supportive. He is somewhere, therefore he is not amongst us, but our Professor Shri Sudhir in absentia, our esteemed guest from NCDC, Dr. Simi Tiwari, and my good friend Dr. Shri Kumar, because whenever any issue is there in the field, we first call goes to him that whether IAV can support us for doing further investigation related to some of the spillovers which we are experiencing in our state. And all the distinguished guests, faculties, Dr. Guru Prasad, my colleague from Achyut Menon Center, Biju Soman, and also various distinguished speakers who are here, Dr. Shobha Maman, and all my colleagues, Dr. Arvind, Anish, and all the students who have out of interest came here, registered themselves, maybe by missing their classes in the colleges, but this is a nice environment and also a very important subject. So that shows your interest in the subject. And others who are interested in this, it is indeed a pleasure for me to come here. As Shri Kumar has said, that last time I could not come, and I had a, I think, online discussion with some of you who would be present in that meeting as well. But this time I told that I'll come here because it is very satisfying for the government, and I think what our Honorable CM has given, some of the initiatives of developing Center of Excellence. One of the initiative is IAV, which we should develop. Now that has also happened through a lot of discussion at an international level and also at a national level. Now as Dr. Simi is here, we can also mention that in terms of the viral and viral research, there are a lot of restrictive practices which are there at the policy level, and it is very unfortunate because the strengths are everywhere. What we should have is an enabling environment, how we will support the strengths what states are having. And therefore, we have gone ahead, established our laboratory setup and such a beautiful campus, which perhaps I think in no other part is also available. So what we need to do is a hub and spoke model by which we encourage the states and union territories, wherever there is a strength, we need to do it. I was traveling, from Coimbatore to other parts. On the highway, in fact, on the left side, I have seen there is an institution of, research in rare diseases. And that is something very good, because I think it was acknowledged that there is some kind of a need, and Tamil Nadu government, along with, I think, again, a science and technology, or also our health ministry, might have taken. I am yet to get into the details. In fact, I have requested my colleague in Tamil Nadu to tell us that what is this institution and what all things you do, so that we need not replicate here, and then we can collaborate for certain things, because rare disease is also a problem in health science. So in generally, what I would like to use this opportunity is, as our esteemed colleague from NCDC is there, and by her presence itself, it reflects that now the approach is to see that whatever the strengths which I think at the field level which are there, we need to have a collaboration. And we look forward to whatever initiatives in One Health, are taking at a national level, that will have a component to have that continued support, not only in terms of technical support, but also, the some much needed supports which are required to facilitate some of the growth of such center. The centers which are already existing and going forward, there we should pitch in more so that they can be developed as a center of excellence, and perhaps we can have a model that, in a regional level, that center can be a hub and go ahead, because there is one, national level committee. In that committee, 8 people were there. I also was fortunate to be a part of that committee to have a future agenda for NCDC per se. So there we have proposed that the state's strength should be capitalized rather than going for the regional kind of arms of the NCDC, because at the end of the day you require the human resource, and if the human resource is not there, there will be the structures, but the activity will not be there. So my request is whatever maximum possible we should have that kind of approach so that we can develop. Second thing is, when we are talking about One Health cannot be only pivoted around the human health, and that realization, as Dr. Shri Kumar has said, it took pretty long years to understand that if we focus only on one particular species, but we will not be able to tackle the problem. And therefore also at a national level, unless and until there are very strong partnership and we will develop the enabling environment, that each of our colleagues in those verticals, they also equally feel that we are also equal partners in that, we will not succeed. Even in the context of Kerala, if we say that the One Health approach is only piloted through health department, we will not be reaching to the level of excellence. We will have to do all the processes and also all our actions in such a way that animal husbandry department also should equally feel that we are also in a part of this whole schema, and we are also equal partners in this. Forest department should feel the same way. Soil conservation department should feel the same way. Water resources department should feel the same way. So whatever is a living species and also inanimate things dealing the department, they should also feel that we are also equally part of this whole system. Then only we will be able to protect it in a very sustainable way. And that is what in the state of Kerala we are very emphatically trying to do. There are few points. What Shri Kumar has said, unfortunately, in fact, year on year, other than the disasters like landslides and all, that was always happening, but less in number. But because of the climate change, which started, and it is very much evident, the number of landslides, etc., were happening. But 2018 onwards, in fact, this novel virus, the outbreaks, that first experience of Nipah outbreak in Kozhikode, that was a wake-up call to all of us. And therefore, I think I would say that even though we were knowing some of these names of these very dreaded viruses, but the way we need to respond to that kind of outbreak was, a little bit missing, in fact, I would say. Based on whatever knowledge one was having, one had tried to do that. Now, we could fortunately, other than that particular, zone, it did not spread to other areas, but still I think in the first outbreak, the fatality rate was very high. And that is very obvious because the knowledge was, the knowledge in the system and the book was there, but the practically how to put to use, that was, not up to the level of expectation. But at the same time, in fact, when second time it happened, and as Shri Kumar has said, that outbreak after outbreak, it had happened to be, I was there in charge. That was my third day of taking charge. And then I went to meet Secretary Government of India, and I learned there without meeting her. She called me early in the morning that there is an outbreak, and then I said that I will not come to your office, I will go to Ernakulam. So I landed up in Ernakulam, and we have, to a great extent, we have managed that. But during that time, it was realized that, there are certain things which has to be in place. So in medical science, whatever we do, especially the management of the patient, if it is a medicine side or a surgery side, there is a particular method by which we go forward. In case of surgery in particular, the moment we, even before entering into the OT, there are certain things. We enter into the pre-OT area, there are certain things. We enter into OT, there are certain things done by our team. And we do that particular operation in a step-by-step manner. Surgeon does not look here and there. He just keep his right hand, or if he is a lefty, left hand backward. And that head nurse who is in charge of that, she keeps giving in a sequentially those instruments which are required. So what is that? That is a SOP. So our realization that what we practice in the medical science has to be there in the place when there are any outbreaks. That was actually while dealing it, because we did not do as a shotgun approach, something is in front of us and start developing this. That consumes a lot of time, and capacity building is also takes the beating. So after that instance, in fact, there was a first, very comprehensive booklet, etc., how to deal with the Nipah outbreak, that was published with the involvement of every, faculty. Some of them are also present here. Dr. Suma was there at that point of time also. Now she is superannuated. So some of these colleagues, in fact, collated, and we have built that system. Why I am narrating this experience is, after that, that was the 3rd June 2019, and then we started thinking that what need to be done. In August, September, in fact, we started giving training to all my colleagues on an online platform, because that time the Zoom was introduced. That was the first few months of Zoom platform. And my colleagues complained to minister that the secretary does not call any meeting, and he takes all meetings online, and we don't get opportunity to come to Trivandrum and to do our some other follow-up. But why I'm saying this also, because we went ahead, we did some of the excellent program of awareness on 6th of December 2019. And then that was the time our colleagues were reading what is happening in Wuhan. And then 2020, Wuhan, and all of us, we know that the whole world entered into COVID pandemic. Now when we are in COVID pandemic, Kerala was the only geography that it was not only fighting COVID virus, there was a Nipah outbreak in Kozhikode, there was a Zika outbreak in Thiruvananthapuram, Kollam. So this was the area where there were 3 viruses, and therefore he said that perhaps this may be the only secretary, and I do feel that there should not be any other secretary in future who will be so friendly with the viruses that we will keep on getting viruses here, and then we have to deal with that. So why Kerala could succeed? Because for each of this there were separate management units, and there were correct SOPs which were in place, and there was a capacity, and therefore without mixing what actually is going to happen to COVID program in Trivandrum, there were the management team working on a COVID, there were separate individuals which were working on Zika virus and Zika virus related activity. We always say that it should not happen in any other state, because if it is not contained and controlled, the outcomes will be very, very drastic, and therefore that preparedness is required. Now this experience told us that we have to have some different approaches, because only after any event is happening, post-event, one has developed the system. Now what is that approach? So as we were going, and as you have all seen, what is getting read or also published, World Bank Rebuild Kerala initiative was there. Looking at, and in that Rebuild Kerala initiative, health component was not there. So World Bank told to the government that there is such a huge work is happening, and there has to be a health component in Rebuild Kerala initiative. And as that initiative, they came and then they said that these are the interventions. So we told them very well that what you are mentioning, those interventions are already done. So if at all there is a financing required, it requires for a bigger challenge. And from that thought process, we have done the presentation before them, and we said that we will have a One Health program. Now, there is some kind of information which will be saying that One Health was always there. But if that is the case, then it should be shown where was it in practice, in the geography, where were the SOPs, where were the capacity building, etc. So if we take a look at it, it is like a shotgun approach. Something happens, then we try to do and run and do it. With that initiative, in fact, we have gone ahead with this One Health program in 21 onwards. This one, they call it deliverables. So there are numbers, and then the 6th program got introduced in World Bank project, and we started this whole structuring of One Health concept and imbibing not only within the health department, but also all our sister departments. So that was the beginning with which we have gone ahead. And now the line departments, like I said, the departments which are dealing with the environment and this inanimate things like water, hills, forest, other thing, and also with the wild animals and also domestic animals. So all this animal husbandry and dairy development department, then our other colleagues in all these other line department, we started series of taking meetings, and after that capacity building program, and then very beautiful SOPs have been developed to do the capacity building of all this fraternity, and also what should be the joint outbreak investigation, and what should be the content of that, and how the reportage should be. That also is conducted, and this program is now getting consolidated in 4 districts of Pamba Basin, that is Idiki, Kottayam, Pathanamthitta and Alapi. But then in 2021, when successive government formed, our honorable CM has given direction and the approval that it should be expanded in all other 10 districts. So we went ahead, and there is some kind of a initial thing what is happening in other 10 districts, but this 4 district is having a fantastic, at the bottom of pyramid, the volunteers, and then the Panchayati Raj institution, their capacity. Now today if you go to any panchayat, any one of you, you belong to some or the other place other than the urban people. In fact, if you go in this 4 district, you should have an interaction with those panchayat member, and they will be also aware related to the One Health related concept and what is that they need to do and what role they can play. That capacity is there. So what we are trying to do is that from the lay person, by building the capacity, what actually is happening in environment, that community surveillance should happen, and that community surveillance will be early warning sign. So if there are any red flag sign, then the system should respond, and then the joint outbreak investigation, etc. should happen quickly, and then we can mitigate certain things which will escalate at a higher level. So from both the sides, in fact, if we work on this, then only we will be able to do the forecasting what actually is happening. At the end of the day, in fact, we do talk about all this technological led thing. In fact, that will also give us pointers. I am not denying, but the subjective interface is non-negotiable. What I mean by subjective interface is whether individual is there realizing that there is some kind of early warning sign and take a mitigation action. Till that point of time, I don't think that the things are going to change, because that particular subject is responsible for the changes which are happening around us and in that environment. So we have to have that community engagement, and then only that community will realize that there are certain things we should do and there are certain things we should not do. And if we succeed in that, then only long-term thing, what we are talking about, climatic change and then sustainable development and a circular economy, and therefore as the outcome of that, there will not be any kind of such spillovers happening over a period of time. That will get achieved over a period of time, but there has to be a conscious effort to do that investment. And this program, in fact, thrives, or this program intended precisely for this, that how we can do the community engagement and build that capacity. So One Health program should not restrict only into such a premier institutions and also the intelligentsia who is working into this particular sector, and also our colleagues in the other sector. But we need to take effort and have that chain reaction to reach to the masses and make them understand that there are certain actions which are resulting into some kind of adverse reactions, which is again hitting back to us only, and we will be definitely succeeding. So there are 2 parts which I will mention, and then I will, I think, stop my the talk on this. One is, when anything happens, then in what way we will be tackling that particular thing. That is one set of thing which is always a classical approach. So we do that kind of investment in the infrastructure and also the capacity building and other thing. Second thing is, what is that we need to do thereby that particular thing will not happen at all. So if these 2 constant things are there in each one of our mind, then only in fact we will be able to succeed in achieving the results what we always intend. So and I would say that whatever efforts what one is taking to tell the colleague and have the multiplier, and then the team which is working on these particular areas, they have been taking a lot of effort at the field level. Our field functionaries are phenomenal strength, and their functioning is very evident by the fact that 1.5 month, 2 months back, there was an outbreak in Malappuram. Everything was controlled. Fortunately, there was no spillover from the index case. We landed up in, after a gap of 2 months, another 2 simultaneous outbreaks. One is in Palagat and second is in Malappuram. Palagat is the case, patient came and therefore doctor and investigation it detected. But the interesting part and most important part, the second case was a postmortem case. In any other place, one will think that, okay, the patient died. No, okay, we don't know the cause, or somebody will write, we used to, in olden days, we used to say PEO, pyrexia of unknown origin, and we ended there. But these doctor teams, they said that what is the cause? They went into the details and they understood that it is because of Nipah. Now, had we not gone into this, the immediate contact and all were extremely vulnerable. No knowledge what is the cause of the death and whether there was a spillover from the index case and all, they also don't know. So that is the strength of the system. Over a period of time, there is a realization among the fraternity, and therefore we could do very successfully. That is one area. Second area, there is a one unit, small unit. They are in a budding stage. That is what we call it a Nipah management unit in Kozhikode. They have taken last year good initiative. There is a good calendar which is prepared. I am having my own views related to this that I will not mention here, but there is a beautiful SOP that is there for anybody to work on and see that in future the event will not happen. And third important thing is the institution which all of you are sitting. It was from the basic idea that this Kerala is having, because there is a very good spirit of inquiry among majority of people at the field level, and there is a conscious effort of the government that, why can't we do it, whatever is happening, somewhere else. So we are also equally capable of. This is the fundamental principle with which in the state of Kerala we all work. That whatever is able to be done on this planet Earth is also, we are also having that capability to do it in the state of Kerala. And that is a matter of pride. And from that, in fact, the IAV, the way it has been grown, is a phenomenal stuff. In fact, what I have seen right from the planning stage at a zero level to this level, structuring some of the courses, not only such seminars, but also cutting edge research and attracting some of the scientific minds to come and a part of this IAV is a phenomenal growth what we have done in last 4 years. The small management unit which is there in Kozhikode also like that with the same kind of a speed and sense of urgency should be working now going forward, and hopefully in fact we will have a, like what we have heard in Bangladesh, they have developed a very good Nipah management center. So, we can also have some kind of a benchmarking, and we should be able to do something not only related to Nipah, but also related to the virus and many other pathogens which may pop up at any point of time. So we look up to IAV with a lot of hope, and also all of you who are interested into the such kind of a scientific approach. And we will firmly, whatever we do is based on science, no matter what kind of a, noise which is around, but we will not leave the base which has to be evidence based, and that evidence will generate from the science which is at present known to us. There are certain futuristic things which we would like to do, and that will eventually come, and we will definitely give some kind of a best practices at a national level to take a look at it. And I am very eagerly looking forward to what kind of a support which will come from the Ministry of Health and Family Welfare and also ICMR for our initiatives in one of these difficult area. I thank Dr. Shri Kumar for giving this opportunity for all of us to participate in such an important seminar. And the personal level, our association with IAV, in fact, we are committed to strengthen it further and take it to the new heights. Thank you very much.
Thank you, Dr. Rajan Kobrate, for officially inaugurating this function and for such an enlightening talk. Before you leave, sir, we would like to join. Okay. Okay. Yes. Let me now invite Dr. Ajish to introduce Dr. Simi Tiwari for the keynote address.
It's my absolute pleasure and honor to introduce the keynote speaker for today's session, Dr. Simi Tiwari, a medical doctor with MBBS and DNB, and also holds an MBA in Healthcare Administration, currently serves as the Joint Director Public Health and Head of the Center for One Health at the National Center for Disease Control, Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. With over 2 decades of experience, Dr. Simi brings a robust combination of clinical and administrative expertise to her role, with extensive experience spanning key national health programs, including the Integrated Disease Surveillance Program, Pediatric HIV Care under NACO, under the national programs for TB, reproductive child and health, polio, and mental health. A recipient of the prestigious 2022 Sir Louis Pasteur Oration Award for her contributions in the field of rabies. She has recently been awarded the Young Epidemiologist with significant contribution in the field of One Health and Zoonosis by Indian Association of Epidemiologists. Dr. Simi has also contributed to several publications and national guidelines. She currently oversees several critical national programs focused on zoonotic diseases, including the National One Health Initiative, National Rabies Control Program, and the prevention of leptospirosis and snake bite in Wyoming. As a representative of the Ministry of Health and Family Welfare on various international platforms, Dr. Simi plays a pivotal role in outbreak investigations, research, and the development of national guidelines. Her leadership in the COVID response and her commitment to teaching and training medical professionals further underscore her significant contributions to public health in India. With all these remarkable credentials and her alignment with the theme of our conference, I truly believe we couldn't have found a more fitting and inspiring keynote speaker. Please join me in welcoming Dr. Simi Tiwari to deliver the keynote address. Over to you, madam.
Thank you, Dr. Agish, for a kind introduction. Respected Dr. Rajan Khobragare, sir, Additional Chief Secretary, Health and Family Welfare, Kerala Government. Respected Dr. Sri Kumar, Director, Institute of Advanced Virology. Dr. Emily Gurule, who has joined for a very good speech, good technical content on the Nipah outbreak. Respected dignitaries and eminent scientists and faculty of the dais. It is my proud privilege for me to stand before you to reflect on a transformation that is reshaping the way we tackle the health threats, the journey from silos to synergy, and how One Health is becoming central to building the global resilience. The topic for this particular seminar or symposium which has been chosen, the Nipah, and currently also Kerala Nipah outbreak is already going on, that shows that how concerned state government Kerala is reshaping its whole healthcare structure for keeping One Health at its center. Since century, we understand that the entire globe has experienced great pandemics, and most of which these have been originated from animals. We know that the Black Death, the famous plague outbreak way back in 13th century, Spanish flu, HIV AIDS, Asian flu, and then followed by Hong Kong flu, swine flu, and most recently COVID-19 pandemic, and now ongoing the Nipah outbreak. And in the central of Africa, we know that Ebola is keep on emerging at times. So these all great pandemics, they have shown that how the emergence of a virus from the animal world could bring the world to a standstill, like COVID did. The COVID, which we have experienced, was not just a health crisis, but also a wake-up call. But as Sir has already told that before COVID, there was an outbreak which was going on in the Kerala state, that is of Nipah, and which was having a more than 80% fatality. So National Center for Disease Control being as a apex public health institute in the country, they were looking at a very critically with the ongoing COVID-19 at that pandemic, that is during 2018 and 2019 period, but immediately the COVID knocked at our door. So that reminded us that our health system, food system, ecosystem, they are deeply interconnected. For decades, our health system, including human veterinary services, wildlife services, and environmental protections, they operated in silos. Each sector did its job, but often without coordination, without shared intelligence, and without a common mission. The result, we ended up delayed responses, duplicated efforts, and missed opportunities for prevention of emerging health threats at the source. In an increasingly interconnected world, we deeply understand that the boundaries between human health, animal health, and environment, they are no longer just the academic divisions. They are fault lines where new global threats emerge. COVID-19 was a stark reminder, and other great pandemics that has tormented the entire mankind, that they reminded us that whenever we fail to see the big picture, the consequences are global, profound, and devastating. But the paradigm is shifting, as it is very much pertinent here to see the growth of this great Institute of Advanced Virology in Kerala. Other states, including the entire India, has embraced the One Health approach not just as a strategy, but as a necessity. We now recognize that diseases do not respect sectoral boundaries, neither should our solutions do. At the heart of this transmission, I would proudly say that the Apex Institute, National Center for Disease Control, in the India's public health architecture has taken great strides in breaking the sectoral silos. NCDC, with its uniquely placed zoonosis division, which was started way back in 1960s only, which has now expanded to encompass the entire One Health principle with several other technical divisions, is undertaking many more initiatives in this direction. NCDC, we understand that NCDC has undertaken many significant milestones, starting from smallpox eradication, yaws, guinea worm eradication, potentially responding to several outbreaks, including plague, Kyasanur forest disease, Crimean-Congo hemorrhagic fever, influenza, then Nipah in 2080. And NCDC that has been initiative and a national lead for carrying out public health surveillance through IDSP and IHIP platform. This IDSP IHIP platform, we understand that it is one of its unique real-time surveillance of more than 50 disease entities and pathogens through well-established Public Health Emergency Operations Center, Central Surveillance Unit at headquarters, State Surveillance Unit network, all across the states of the country, District Surveillance Unit, Block Surveillance Unit, and now uniquely upcoming with a network of Metropolitan Surveillance Units. We also are going to have 5 regional centers for National Center for Disease Control, state NCDC branches, and it is going to have a network of 10 BSL-3 laboratories at a strategic locations in the country. Most recently, the establishment of National One Health Mission, which is led by Principal Scientific Advisor to Honorable Prime Minister of India, has given a more strategic direction to entire One Health agenda in the country. By bringing all the ministries on a common platform and breaking the institutional silos and further bringing a collaborative ecosystem to work together. NCDC is one of the strongest pillars for the National One Health Mission, as it is a leading key national health programs established since 2012. One of important program is National One Health Program for Prevention and Control of Zoonosis, which is establishing real-time surveillance and public health response for endemic zoonosis and zoonosis of pandemic potential through its strategic 6 components. The program has established systemic collaboration, communication, and coordination mechanism with all sectors such as Department of Animal Husbandry, Indian Council of Agricultural Research, Ministry of Environment, Forest and Climate Change, Wildlife, Ministry of Tribal Affairs is one of the important partner with us, several other institutes across the country, including All India Institute of Medical Sciences. Now we have built a network of approximately 112 institutes all across the countries which are under Center for One Health. Other program is National Rabies Control Program, and we are taking many initiatives in this. Rabies is a classical example of One Health in action, and we understand that there has been significant media reports, especially with the Kerala, about the rabies incidences. And in 2022, I myself had an opportunity to investigate the 22 death cases of rabies in the state of Kerala, and we come up with some recommendations for the state of Kerala, but and we are also looking the finalization of state action plan for Kerala, which I am now hoping that this Institute of Advanced Virology can take a lead to finalize that action plan for rabies, dog-mediated rabies elimination. Other program, there are many other programs, so I will not be taking much time. That another important One Health core domain is antimicrobial resistance, wherein NCDC is playing a leadership role. Other programs, biosafety, biosecurity, National Program for Climate Change and Human Health, biomonitoring, biosafety and biosecurity, all these programs are basically built on One Health principle. Now we understand that as an aftermath of Nipah outbreak in Kerala, and with the simultaneously upfront COVID-19 pandemic, the state government Kerala, they have recognized establishment of this unique institute wherein we are standing here, Institute of Advanced Virology, to give a further momentum to One Health agenda. And we are taking an immense pride, and it is my privilege to be here in this premier institute which is going to shape the One Health agenda not only for the government of Kerala but the entire South India as a regional center, and also the global South on an international platform. I see a great potential for this institute to become an entire training hub for the South Asia and the entire global South on the emerging infections, antimicrobial resistance and viral genomics. We are looking forward to the Institute of Advanced Virology to include a full spectrum on One Health research and policy advocacy, and eventually showcasing Kerala as a One Health success story for the entire India and proudly the global South as well. Institute of Advanced Virology has all potential to become India's flagship institution to champion One Health for the country. But I must say that be it a National Center for Disease Control, ICMR, or Institute of Advanced Virology, the challenges are going to be similar for all of us who are among us the battle of breaking the silos, especially breaking the sectoral silos. The biggest challenge is prevention of loss of biodiversity and protection of wildlife amid this growing need of development in the country. India is signatory to the UN Convention of Biodiversity, and time and again on global platform, and India has time and again re-emphasized on achieving few targets which has been signed on behalf of Indian government to achieve the global biodiversity agenda by 2030. Pertinent to say, I will not going into the detail of a particular target, but target 4, 5, 6, 9 and 12 of UN Biodiversity Convention, these have been very much pertinent to prevention of zoonosis and other emerging threats at human-animal environmental interface. Another challenge wherein we are all in the same boat is to have a culture of data sharing among the sectors. And for this, we need to have a mechanism in place for systematic sharing of essential data parameters between the sectors for timely public health action. This can only be achieved after bridging the gap of sectoral priorities by mutual consensus on shared vision and objectives. By alignment of data parameters and minimizing diversification, by mutually resolving the data sensitivity issues and issues of revenue and trade implications, only we can build a conducive environment, cultural practices for data and information sharing among the sectors in a timely manner. We understand that there is a pressing need to develop the standard ecological niche modeling techniques for generation of early warning signals and timely prediction on impending threats at human-animal interface. And for this, building a conducive environment backed with a strong policy and legislative backup for data information and sharing among the sectors is of utmost importance. Further, we understand that allocation of optimum resources for promotion of research and development on medical countermeasures to address the zoonosis, antimicrobial resistance and food safety, we need to have some strong commitment from our political and our administrative environment. Formulation of standard policy and practices for laboratory quality management system, laboratory biorisk management as per the standards is another requirement and pressing need of today. And I am hopeful and we all understand that these are the challenges, but we are advancing with the right approach and with a greater commitment once we all share the same platform and we are understanding the public health need of the country. So this shift from the silos to synergy, not just in policy, but need to be in the practice. So as we move forward, let us remind that global resilience begins with trust and mutual respect. And One Health is not a concept. It is a commitment for collaboration, for coordination, and for the collective action. With this, I extend my hearty thanks to the organizers for providing me an opportunity to present my thoughts on One Health among this august gathering and among the great scientists of Indian Institute of Advanced Virology. Thanks and Jai Hind. Thank you.
Thank you, Dr. Simi, for the keynote address. May I request Dr. E. Srikumar to hand over a small token of our appreciation to Dr. Simi Tiwari for coming over here and delivering the keynote address.
Sir is very senior.
So since Dr. Rajan has some time restrictions, we would like to have you here for a prize distribution event. To ignite the creativity in young minds, we had conducted a poster presentation competition on the topic zoonotic spillovers. Scholars presented their posters with great excitement. Out of this, we have selected 4 best poster presentations. So we are announcing the winners now. For the benefit of the delegates and all the invitees here, we have displayed the posters outside the seminar hall. As I call out the names, I request the winners to come forward to receive your prize. First prize for the poster presentation held yesterday goes to S. Devanand, Government Medical College, Trivandrum. Second prize goes to Manav Singh, Amrita Institute of Medical Sciences. Third prize to Neha Varki, Pushpagiri College. Neha is not here. Consolation prize goes to Nandita V.S. Amrita Institute of Medical Sciences. Congratulations to all the winners. Now may I request Dr. E. Sri Kumar to hand over a small token of our appreciation to Dr. Rajan N. Kobragadi. Thank you, Dr. Rajan, Dr. Simi Tiwari, for giving away the prizes. Now we are breaking for tea. Before breaking for the tea session, I invite all the delegates and participants who have gathered here and all the invitees for a photo session. The photo session would happen near the place where we have arranged the tea. So please, can you all gather near the venue and be ready for the photo session. And those who have not collected the food coupons, please be reminded to take your food coupons from the registration desk. And a general reminder to the poster participants, please be ready with your posters or arrange your posters during the breaks. And you can contact the registration desk for any help or queries. Thank you. Can we all meet for the photo session near the tea counter? Thank you.
And I'm not a Nipah virus specialist, so we have never really worked on Nipah viruses. My primary expertise and our lab has been focusing on flaviviruses. And in the last 5 years, we spent quite a good amount of time on another respiratory virus, which you all know, which is SARS-CoV-2. And we also had some interest in fundamental aspects of respiratory syncytial virus, which is somewhat related to Nipah viruses, I would say, although not in the paramyxovirus family. So that's how we got interested in Nipah viruses when the outbreaks kept happening here. And as a virologist, it's the fundamental curiosity: what is this virus? Why is this really, just showing up sometimes and disappearing again? What happens at the population level? The same kind of questions that we were asking with flaviviruses, we thought are relevant with Nipah viruses. Of course, with no access to really people who get infected and virus and not having the facility, it's kind of restricting us to really delve deep into the fundamental aspects of virology. So what I will actually discuss today is really our hypothesis that how we really started working on Nipah viruses and what is it that we are planning to do. So it's work in progress. So as you all know, probably most of you know that I was actually at the Translational Health Science and Technology Institute at Faridabad, which is a DBT institute. So I was the first faculty to join there. I worked for about 14 years, set up really pretty good systems for virus research. And then some strange, I would say, mid-career desire to do something bigger. So I thought maybe I should now move into an academic system involving training students and maybe establish a good research infrastructure in an academic institute so that I can contribute at a bigger level in infectious disease research. So last February I moved to IISER Tirupati. So again, it's a very brave move, I would say, because it's a new institute for me, because we just moved into a new campus. And I had to start from scratch, really establishing my lab, because my students thought I'm crazy and they didn't want to come with me to Tirupati. So I'm really again building a new group, setting up my labs, establishing infrastructure for infectious disease research, which did not exist at IISER Tirupati when I joined. So as you know, just a couple of slides on Department of Biology at IISER Tirupati. So it's a pretty diverse department. So unlike research institutes where you have a virology institute where everybody studies viruses, academic institutes actually thrive on diversity. So somebody is interested in plants, somebody is interested in insects, somebody is interested in RNA, somebody wants to work on proteins. So it's a pretty diverse department. So what I did after taking over as head of the department is really consolidate this and really come across 6 thematic areas into which we can actually form as teams. So I'm part of disease biology group, and infectious disease, we are 3 people working on infectious diseases. So it's an exciting journey, I would say. So we are about 150, close to 180 people in the Department of Biology, maybe bigger than Institute of Virology, I would say. So our department has about 21 faculty, 100 PhD students, and about 50 to 60 project staff. So it's almost like an institute. Coming to my lab, so we are interested in both fundamental and applied aspects of virology. So my lab is, as I said, primarily working with flaviviruses. So we are looking at host pathogen interactions where we are interested in micronutrients and how micronutrient homeostasis actually influences viral infection. We are interested in epithelial and endothelial barrier functions, which becomes very crucial when we want to study Nipah viruses, because these viruses are really endotheliotropic and epitheliotropic viruses. The other aspect of our lab again is drug discovery. So we are investing a lot of our efforts into drug repurposing so that we can quickly reach clinical trials if we identify potential molecules that inhibit some of the RNA viruses. And we have good collaboration with a number of chemistry groups in the country. So we are also interested in new chemical entities and trying to identify antivirals for some of the RNA viruses. And as a fundamental virologist, we are always interested in really isolating viruses, characterize these viruses, understand the virulence factors and pathogenicity, and also to look at immune responses and vaccine development. I'm not sure where I can find the timer just to make sure. Is there any? Oh, it's that one. Okay. Thank you. Thank you. Yeah. So basically the outline of the talk will mostly be on Paramyxoviridae, and we're looking at diseases and challenges to human health. I'll briefly talk about Nipah viruses, the disease and challenges, and then I'll introduce you to the concept of aptamers that we have started, and we have our work on RSV, and how did we really come up with an hypothesis to work on Nipah viruses. Then we'll talk about innate immune responses in RNA virus infection, and how we are actually using that as a strategy to screen for antiviral compounds. And I'll just end with the reagents that we have generated and where we are currently with the work that we started just about a year ago. So this Nipah virus project is funded by Open Philanthropy. So I worked for 1 year and then I moved to IISER Tirupati, so there was not much I could do till I start my lab. So it was almost like 1 hour break in our progress. So we have just started again to work on this. So briefly talking about paramyxoviruses, I'm sure most of you know paramyxoviruses. Most of you understand that these are viruses of global concern. For some of these viruses, especially like measles virus, we already have pretty good vaccines, and we know how bad measles can be in people who don't get vaccinated. And Hendra virus, Nipah virus comes under Nipah virus. So the paramyxovirus family is broadly classified into 4 subfamilies. And of all this, I would say the rubella virus, most experts now believe, is probably the subfamily with the largest pandemic potential because of its capacity to spread human to human via respiratory route. Avula virus primarily infects birds, so as of now not a major concern for humans. So basically these are viruses with pandemic potential because they have very broad host range, as you saw in the talks in the first session. They are of zoonotic origin. They have the capacity to transmit from human to human, although not so much for Nipah viruses. Despite seeing human to human transmission, I think that probably is restricted to index cases and around them rather than a community wide spread. And case fatality ratio in some cases is pretty high, and co-infections in animal reservoir is a big problem. So this is one reason why people are worried that newer viruses might emerge from Paramyxoviridae family. And as I said, there are highly efficacious vaccines for some of the Paramyxoviruses, but so far no antivirals, and that's the reason why we are interested in this family. So Nipah viruses, you all know, the representative virus from this family is really Hendra virus and Nipah virus. and they are bat-borne viral zoonoses discovered in the mid to late 1990s. Prototype viruses are what we are interested in. And the genome size is about 18.2 kb here. It's a non-segmented, single-stranded negative sense RNA virus. And it encodes 6 structural proteins, which includes nucleocapsid, phosphoprotein, the viral polymerase, matrix protein, and glycoprotein G, and fusion protein F. You all know now about this. We discussed this, that the geographic spread of these viruses is pretty much really encompasses about half of the global population. So these are the colored regions are the regions from where the sequences have been deposited to NCBI. So as you can see, more than close to 100, more than 100 sequences probably have been deposited from India, making this as one of the hotspots for these viruses. And when you look at the animal reservoir for these viruses, the blue circled area is really the bat distribution, and the green circled area is the shrew distribution, which is another animal reservoir for these viruses. So there is a potential that based on this availability of animal reservoir, these viruses may keep jumping and spreading to newer regions, which only time will tell. So if you look at the life cycle from the fundamental virology perspective, like any other paramyxovirus, the G protein is the viral protein which binds to its receptor. In this case, it's ephrin B2 and B3, which the receptor binding leads to membrane fusion mediated by the F protein of the virus. Fusion of the membrane leads to release of ribonucleoprotein complexes into the cytosol. So the negative strand RNA then makes positive strand RNA, which is used for, is there a pointer somewhere? Or should I use my pointer here? It's fine, I can use this. Yeah. This one. Okay. Yeah, so the negative strand RNA negative strand RNA leads to synthesis of positive strand RNA, which leads to translation of viral proteins, which in turn make more and more negative strand RNA. Then they are all packaged and released from the cell. So for a virologist interested in antiviral discovery, antiviral discovery, so you would say that the receptor binding, replication, membrane fusion, and assembly are the possible steps of viral life cycle which one would like to target. So if we look at some of the at least established inhibitors that have been shown to work with some of the Nipah viruses. Okay, it doesn't go that far, it's green here, yeah. So chloroquine has been shown to inhibit fusion. Then the RDRP, of course, can be inhibited by some of the known inhibitors like ribavirin, remdesivir, favipiravir, ALS8112. So we don't know whether this will actually be useful in an outbreak situation, but these are the inhibitors that people have shown using in vitro models. When it comes to pathogenesis of Nipah virus, most of you know that these viruses enters via respiratory tract or mucous membranes. They target primarily endothelial cells, epithelial cells. In recent cases where you can see encephalitis, even neurons have been shown to be infected. So viral fusion proteins cause infected cells to merge, forming multinucleated syncytia. And then you start seeing infection of blood vessel lining leading to inflammation, vascular leakage, and hemorrhage. When the blood-brain barrier is breached, the virus crosses blood-brain barrier, causing encephalitis and neuronal death. As you can imagine, when there is systemic infection, there is massive cytokine storm. So the dysregulated immune activation contributes to further tissue damage, and eventually it leads to multi-organ dysfunction because of this inflammation, leading in respiratory distress, neurological impairment, and potentially fatal outcomes. So when it comes to common viral sensing pathways, when all this is happening, is the cell really doing nothing at all with the virus? So there are pretty well-established innate immune responses in the cells. So most of you probably know the C-gas-Sting pathway and the NOD2 inflammasome pathway. Mitochondria plays a major role through MAVs in antiviral signaling. The TLRs, which are toll-like receptors, which act as PAMPs recognizing the viral glycoproteins. Then you have the RIG-I and MDA5 pathway through mitochondria. They again, activate the tank binding kinase, and through IRF3, IRF7 lead to really, induction of interferon pathways. So essentially, these interferons again create an antiviral response in the neighboring cells through induction of ISGs. So what happens to all these pathways when Nipah virus or Hendra virus infects cells? So as we all know that most of these innate immune pathways are actually inhibited by Nipah virus proteins. And these proteins, these innate immune sensors have been shown to play a very important role in Nipah virus pathogenesis, because if you knock out any of these innate immune responses, you do see higher viremia or higher tissue viral load, suggesting that these pathways are actually very important for controlling virus. So this is one example here where if you don't have sting pathway, you do see higher viral load as compared to the wild type mice, although the interferon knockout mice always give very high viral load if you don't have interferon pathway, that is in lung, spleen or brain, clearly suggesting that the innate immune responses actually have the ability to control Nipah viruses, but somehow in certain cases these viruses perhaps evade the innate immune response, which is well known from all the studies that have already been reported, that the Nipah virus V protein, M protein, P, V and W, they all actually act in a concerted manner to block the innate immune responses, either MDA5 or RIG-I by ubiquitination, targeting TRIM6 for degradation, again inhibiting STAT1, STAT2 phosphorylation, and Nipah W protein actually reduces phosphorylation of IRF3 in the nucleus. So these non-structural proteins actually orchestrate a pretty good innate immune evasion mechanisms, therefore the virus can establish itself and really cause pathogenesis. And when it comes to structural proteins, Nipah virus G and F are the two primary structural proteins that have been known to actually be involved in antibody responses. So the neutralizing antibodies which people have identified, especially M102.3 and NAH1.3, have been shown to bind the tetrameric complex of G protein, either the head domain or the Stark domain, and completely neutralize the virus. Similarly, the F protein, as we all know, like RSV, F protein actually exists as a trimer, either as a pre-fusion intermediate or as a post-fusion intermediate, and are targets of antibody responses, especially if you are aware of RSV vaccines. Most of the RSV vaccines that are currently licensed are against the trimeric fusion construct of F protein of RSV. So when we think about all this, our question was, can we really use the F and G proteins as baits for identifying entry and fusion inhibitors? And can we establish antiviral state by inducing an innate immune response in cells which make them really resistant to virus infection? When we were thinking about this, the origin of this hypothesis actually came from our SARS-CoV-2 studies, which was our first collaboration between Tarun here and our lab, where we identified a single DNA aptamer which was capable of actually binding the SARS-CoV-2 spike trimer and was not binding any of the other envelope protein, either with related coronaviruses or even HIV or influenza virus. So this gave us confidence that perhaps DNA aptamers can be pretty good platform for identifying either fusion inhibitors or membrane entry inhibitors. So if you are unaware of aptamers, this is an introductory slide showing that aptamers are synthetic single stranded DNA or RNA molecules. They bind really a wide variety of targets with very high affinity and specificity, and they can be developed against a variety of targets. They are low cost and they are actually pretty good tools as diagnostic tools, and they are actually used now in a number of diagnostic kits that are in the market. In addition, for age-related macular degeneration, this is an aptamer which specifically binds VEGF and prevents age-related macular degeneration. So aptamers can also be used as therapeutics, at least from this example. So this is where we thought that perhaps we should start screening for aptamers and see whether we can identify some of the RSV and Nipah virus inhibitors. So just a comparison between aptamers and antibodies. So these are short single-stranded DNA or RNA sequence. When you look at antibodies, they are large multi-chain proteins. These are chemically synthesized. These have to be produced by biological systems. You don't have batch-to-batch variation with aptamers, whereas for antibodies, that's a concern. These are thermostable, these are not, and you can make a lot of modifications to increase affinity, whereas that is not possible with antibodies. Aptamers are pretty low cost, whereas antibodies are high cost, again indicating that this would be an attractive platform. So ourselves, my group and group at NIAB and Tarun's group at GBU at that time really came up with this proposal that we should create multiple platforms for Nipah viruses, where we have a pseudotype virus, we can establish a mini genome replication system, and then membrane fusion assays, and then screen DNA aptamer libraries and innate immune agonists to look at inhibition of replication. So this is the work that I said we just started at THSTI, and this is work in progress. So I don't have really conclusive data to say we have already identified inhibitors or aptamers that can block Nipah virus in replication. But when we started this project, we had nothing in hand. Even getting a plasmid for Nipah virus was impossible unless we got it synthesized. So we thought we'll start really looking at proof of concept data by using aptamer screening for RSV. So what we did was really took up RSV virus because we were working on RSV. We screened for aptamer libraries there, and we were able to actually do multiple rounds of screening to identify very high affinity aptamers for RSV. Yeah, okay. So because it is green light, I cannot see from here. Yeah, so by round 8, we were enriching really RSV binding aptamers that were specifically binding to RSV, and we were able to really sequence some of these aptamers, and we had about 40 aptamers which had very high specificity for RSV. And is this of any use? Do they really inhibit RSV infection? So as you can see here, if you pre-treat RSV aptamers with RSV and then infect cells, we had some of the aptamers which completely inhibited RSV infection, indicating that aptamers can actually act as potent antiviral molecules. So we purified our RSV F and G proteins because we had at least these plasmids in-house, and we showed that these aptamers actually bind RSV F protein. And as I said, that these are supposed to be G quadruplex structures because our aptamers were made for enrichment of G quadruplex structures. Some of you who don't know what are G quadruplexes, these are guanine-rich sequences that actually take this secondary conformation. So these are 4 guanine rings which form a coordination bond with the cation here. So these exist in the cell. So the telomere ends actually are G quadruplex enriched structures. So G quadruplex structures are known to be involved in multiple functions like transcription, regulation, replication, stability of the genome, and epigenetic regulation. And these exist in either parallel structure, anti-parallel structure, or hybrid structure, which is very important when we really think about NMR-based structure identification. So we wanted to know whether we have really G quadruplex structures in our RSV aptamers, and as you can see here, 3 of our RSV aptamers through NMR spectroscopy actually showed G quadruplex structure because the peaks are between 10 to 12 ppm, and this had a partial G quadruplex structures. When we look at really the BRCA19, which has high affinity for quadruplexes, and use that in our NMR analysis, as you can see, RSV3 and RSV31 completely actually broadens the NMR peak, suggesting that these 3 have a pretty good G quadruplex structures as compared to RSV1 and 4. So we had aptamers that was binding RSV and that had G quadruplex structures. Both actually were as per the objectives of the assay. And when we look at the NMR spectra, all of these actually show G quadruplex structures here through CD spectroscopy. And some of them have anti-parallel structures and some of them have parallel structures. Again, indicating that physiologically these have G quadruplex structures and these can be utilized for therapeutic purposes. And we showed that these actually bind both RSV F and G, and surprisingly all of these aptamers had higher affinity for RSV G as compared to RSV F, which we didn't expect actually. We thought we would have aptamers enriched for F, and these were very specific to F and G, and although RSV4 bound to RBD, it preferentially bound to RSV F and G more than RBD of SARS-CoV-2, and these other 3 aptamers were very highly specific to RSV F and G. And we did our docking analysis to show that most of these aptamers, actually we have finished this for F, and we are yet to do this for G. Most of the aptamers that we have found actually have better score for pre-fusion intermediate than the post-fusion intermediate, suggesting that these aptamers actually have a preference for binding the pre-fusion intermediate. Same is true for RSV3 and also for RSV4. We saw that the binding score was pretty much same for both pre-fusion and post-fusion, suggesting that RSV4 may bind both pre-fusion and post-fusion intermediate. RSV31 actually had more preference for post-fusion intermediate as compared to pre-fusion intermediate. So far we are confident that the aptamers that we have identified actually can bind pre-fusion or post-fusion intermediate of RSV and can block virus infection. So this is the confidence we have now in aptamer technology, that if we use this technology, certainly we will be able to actually identify aptamers against RSV F and G, and that's what we did in the ongoing project. So to further show that these aptamers are very specific in terms of whole virus, they again bind only RSV and do not bind to any of the other related RNA viruses. And when we take a virus transport medium from healthy patients and mix it with RSV, spike it with RSV and look for binding, all these aptamers were able to bind RSV in spiked medium, suggesting that even in a clinical setting, this probably can also be used as a diagnostic tool. So finally, to look at the effect of aptamers on RSV infection again, so these are infection studies now. So these aptamers now potently infect in cell culture RSV infection. You can see about 10 to 1,000-fold reduction in RSV titers when you pre-incubate these aptamers with RSV, but they have no effect on dengue or chikungunya virus. And we were able to show that these RSV aptamers were specifically inhibiting entry and not replication, because when you perform entry assays by pre-incubating this RSV, you do see about 100 to 1,000-fold reduction in viral particles that enter the cell. Therefore, RSV aptamers that we have identified are potent viral entry inhibitors. Therefore, anybody who is interested in screening aptamers can actually feel good about identifying entry inhibitors. So that's where we are as of now. So we have finished screening of aptamer libraries against Nipah virus F and Nipah virus G proteins, and this is the stage where we have actually now a group of aptamers that are 21 aptamers that we have now selected, which bind specifically Nipah virus F and G. And we have to sequence these aptamers and then start looking at which epitopes they are binding and perform neutralization studies. Although we don't have virus, we are looking at pseudovirus and VLP based assays. Perhaps we can collaborate with IAV in these aspects. For the innate immune agonists, so again we got the plasmids for interferon stimulated response elements. We generated stable cell line in A549 cells, and we show that this cell line is actually dependent on interferon addition, and it can stimulate ISRE elements in this cell line. So now we have this cell line to screen compounds for interferon pathway stimulation, which is what we actually thought about as innate immune agonists. So we have screened compounds using these cell lines, and we have finished the primary screening of 2,000 compounds using these cell lines. And here again we have about 205 hits now, which are innate immune agonists. So the original idea of stimulating innate immune responses as an antiviral response to prevent virus replication, we are midway there. And the idea of identifying inhibitors for F and G proteins for a related virus, we are pretty much there. And for F and G, we have completed the preliminary studies, and we now will work on the aptamers that we have for further validation. So I'm just concluding this. I'm concluding this. So we have shown through our RSV experience that aptamers for NIV, F and G actually could be isolated, and now we are in the process of validating these NIV, F and G. And we also now feel that innate immune agonists can potentially induce an antiviral response and block virus replication. So we are now going to test this in our in vitro models through the mini genome replication assays. We have to identify the specificity of the aptamers that we have identified by testing with other RNA viruses. And I'm looking for collaboration, either NIV or IAV, where we can actually work together to take some of these potential molecules forward, because essentially it has to really reach people. That's the idea, not really just publish something and forget about it. So essentially, if you look at the big picture, paramyxoviruses are actually a big problem, and spillover, as we have discussed repeatedly, is something which we should focus on. Change in tropism due to recombination and co-infection is a big concern, so we need to worry about that. Surveillance in animal reservoirs is very essential, and fundamental research to understand life cycle is a challenge, because only very few labs can do that kind of research. So hopefully we can do something about that. And we need good animal models. Maybe institutes like IAV, NIV, maybe should act as national resources in animal models and supporting research for other people who cannot afford to work with viruses. So this is our group. So NIAB, this is Hegde and Madhuri, who are PIs at NIAB. Tarun is now at Nipah Mohali. And this is the group at NIAB, my group at THSTI, Rakhi, Riya, Ashish, Kapil, and Alok Kunal. This is my new group at ISA Tirupati, funding from multiple sources, and I thank all of them. And I can take questions. Thank you.
Thank you, Dr. Guruprasad, for that elegant talk. Actually, he made these complex things very simple. I also learned, I'm not a virologist, I learned about aptamers and all. Probably he finished the talk before 30 minutes, so we can have a couple of minutes for questions actually. If you have any question from the audience. Yes, Dr. Anish.
Yeah, in future, can we use it for preventing outbreaks? For example, if it is having some role in innate immunity, then can we use it as a vaccine or something like that in a high-risk area where there is a chance of Nipah spillover or something like that?
So the whole idea was actually to use these molecules maybe in an outbreak situation, perhaps as a prophylactic, so you induce innate immune responses in the community around index cases. Maybe they'll be they will have an innate immune response that can tackle virus infection efficiently, and you may not have really spread of the virus. That was the idea for focusing on innate immune responses. Aptamers essentially would be actually working in people who have viremia. So therefore, if patients come with in the viremic stage, perhaps aptamers can be useful for preventing further spread inside the body as neutralizers.
You mentioned about the role of chloroquine and all other drugs as inducing agent for innate immunity or immunomodulators.
Fusion inhibitors.
Yeah, can we use, for example, in a low-risk secondary cases in contacts list of Nipah, can we, Dr. Aravind, can we use, maybe suggest that maybe as it is rather than using remdesivir for high risk, for low risk people, can we use these kinds of drugs?
So chloroquine essentially lowers the pH, so it actually blocks viral entry. It may be useful in people who have active virus infection. I'm not sure in a community outbreak situation, can you just give chloroquine to people and would that help? That only you may know that. Yeah.
Actually, so why Anish sir asked is that in 2018, only ribavirin was available, and it did not work that well in the ground level, and mortality was around 90%. So in 2021, because of this SARS-CoV-2 outbreak, we got access to remdesivir, which is sort of proven in African green monkeys that is against. And we modified our guidelines. In 2023, we used remdesivir for therapeutic purposes as well as for prophylaxis in the highest risk contacts. And interestingly, in 2023, our mortality was only 33%. That is, out of 6, we were able to save 4 because they were in the we had contact traced them, and we were able to initiate remdesivir for 4 of them at the earliest.
Okay.
And we really don't know whether it was due to remdesivir or because we don't have a control group per se. In 2025, also we did use remdesivir, but the patients are still alive, but the neurocognitive sequelae is a major problem.
Okay.
So SARS question is like in our prophylaxis of high risk and highest risk, we are as of now using remdesivir, which requires hospitalization. And alternative is actually favipiravir, which is also proven in animal models. But as of now, chloroquine, the studies don't support its use in prophylaxis. Studies are there from Malaysia and all. So as of now, it cannot be used in prophylaxis.
See, most of these direct acting antivirals will only work if there is really viral replication happening. So it has to be the viremic stage. If people come with symptoms post viremic stage, it would be very difficult. But I'm assuming in Nipah virus, most of the people still have a lot of virus in them, and you detect virus in probably biopsies or even in the samples that you have obtained. So maybe remdesivir probably has some role to play there.
Okay. Yeah, Dr. Ajish.
For the wonderful talk as always. Actually, you have shown that the aptamers which bind to RSV and not to dengue virus 4. And I was wondering whether any non-canonical DNA that could actually binds to all the 4 serotypes of dengue, because dengue...
We have not done aptamer screening for dengue so far.
Yeah. But for your studies, you have used only dengue virus 4. But in one slide, you have shown 2.
So we have checked against all 4 serotypes
for these aptamers
for specificity for RSV aptamers.
Okay.
So the aptamers that bind RSV do not bind any of the other flaviviruses.
Okay.
So that way, at least I think they are, because they are G quadruplex structures, it's more conformation dependent rather than sequence dependent.
Okay.
So even when you look at pre-fusion, post-fusion, they have preference for pre-fusion. Some of them have preference for post-fusion.
Okay.
So I think they bind the pockets somewhere in the pre-fusion or post-fusion F protein and also G protein, just like antibodies.
Okay.
So I think they are conformation dependent binders rather than sequence specific binders.
Thank you.
Yeah.
Here, that's the last question. Yeah. Can somebody pass the mic, please? There's a hand up there.
Thank you, sir. Very nice talk. Thank you, sir. Very nice talk and presentation. Considering aptamers as chemical antibodies, I want to know how bigger the epitope size is. And second question is, in future, if we use these aptamers as a kind of neutralizing, virus neutralizing chemicals, will it impart some selection pressure, or next is, will the point mutation escape the things? Thanks.
So your first question is whether aptamers are
considered as chemical antibodies that neutralizes the virus.
Yeah. So we are very far from that, because we are probably one of the very few groups which have shown that aptamers can neutralize virus, because most of the field is really looking at aptamers as biosensors. So they are mostly looking at that aptamers as diagnostic tools and not as therapy. So this is something which we are pushing now, that perhaps they should be considered as therapy. When it comes to really resistant mutations, as I said, I think aptamers mostly bind conformation rather than sequence. So as long as the conformation of the protein doesn't change, perhaps aptamer binding will always be intact. So they may not really drive the virus to evolve and become resistant. Again, that only time will tell. We have not done this kind of selection experiments where continuously expose aptamers to virus and see whether it mutates. That we have not done.
Thank you, Dr. Magrish.
Thanks a lot.
Thank you, Dr. Medigishi, for that clear and impactful presentation. I now request Dr. Biju Soman to hand over a memento to Dr. Guru Prasad R. Medigishi as a token of our appreciation.
Before we go to the next invited talk, may I request all the participants of the poster presentation to display the poster in the designated area. Also, all participants of podium presentations, please move out of the seminar hall to the registration desk where you will be directed to submit your presentations so that they can be loaded before the presentations really begins. I now request Dr. Aravind to invite the next speaker to the scientific session.
So the next talk on this session will be by Dr. Shobha Maman, and Madam will be talking on emerging zoonotic diseases, the One Health approach. It's our pleasure to welcome Dr. Shobha Maman, who is a professor in Department of Clinical Virology at CMC Vellore, with over 2 decades of experience in clinical virology, infectious disease diagnostics, and translational research. Her work spans molecular epidemiology, viral diagnostics, and public health surveillance, with a strong focus on arboviruses, HIV, and emerging viral infections in India. Her recent work includes molecular characterization of West Nile virus cases in South India, evaluation of diagnostic platforms for arboviruses, and contributions to understanding severe dengue pathogenesis in pediatric populations. Dr. Maman's research reflects a commitment to strengthening diagnostic capacity and surveillance systems for emerging infections in India. She brings to the Nipah conference a wealth of expertise in viral diagnostics, outbreak response, and translational virology. Over to you, Madam.
Good morning, everybody. Thank you for this opportunity for talking. My topic is emerging zoonotic pathogens, the One Health approach. I would like to thank the organizers of the Indian Institute of Virology for giving this opportunity. So, I am not bringing any diagnostic aspect into it. This is just a little depth into how the emerging spillover, zoonotic spillover works and the One Health approach towards it. Okay. So, as we all know, the emerging human infectious diseases, 60% have a zoonotic origin. And this is usually by a process known as zoonotic spillover. So, the first slide. Okay, so as we know, epidemics and pandemics result from emergence as well as re-emergence of zoonotic disease. First, zoonotic spillover happens, then the localized transmission happens, then the amplification, international spread happens, which result in epidemics and pandemics. So, as we see in the slides, when we look at the history, there are a lot of outbreaks, zoonotic diseases and outbreaks. So, human immunodeficiency virus. Human immunodeficiency virus was introduced and it came to the limelight in 1980s to 1987 from the primates, of human contact with primates, and thus the AIDS pandemic happened. There are a lot of pandemics. I'm focusing only a few. The SARS-CoV-2 virus, the severe acute respiratory syndrome coronavirus emerged in 2002 to 2003. So that also, and the COVID pandemic, 2020 to 2022. So all these we trace back, and we know that the palm civets and the dromedary camels especially in the MERS coronavirus in 2012, which happened in the Gulf countries. It has not been reported in India, but it has high fatality rate, and that happened. So, in late 2019, we had the COVID pandemic. So this also we know. So all these are factors. All these, if we trace back the origin of this pandemic, we can know that this all happened with interaction of humans with animal species, okay, and the jumping of pathogens from a species barrier, a zoonotic barrier. So HIV spillover happened from non-human primates to humans, occurred through manipulation of the meat of primates, probably slaughtered for human consumption. So go up, this one, go up. No. Okay. So the zoonotic disease, from a zoonotic disease to a pandemic. So these are animal viruses. So you can see the picture of the viruses. See, this is not operating properly. This one? No, the slide up and down. The slide up and down. Okay, I cannot tell. No, first slide, second slide, third slide. Which is the one which is finding the slide? Just what? That slide. Slide. Pointer. This is pointer. So then from animal to human spillover of viruses, amplification in the human to human transmission, and global spread. So zoonotic spillover, what is the definition? The transmission of pathogens between different species, the crossing of species barrier is an ecological phenomenon which is known as zoonotic transfer, pathogen spillover, or zoonotic spillover. So the zoonotic spillover happens when these factors are favorable to the pathogen, allowing the crossing of species between barriers. So these are the pandemics resulting from zoonotic spillovers. There's a whole list. 2001, as you can see, if you look at this 2001, Nipah virus, Bangladesh, India, Malaysia, place, reservoir host, bats, outbreak with high mortality rates. Okay? So this is the pandemic resulting from zoonotic spillover. I'm not going into each and every one. We have the SARS, 2003 to 2004 SARS, okay, bats and civets, reservoir. The flu, the Spanish flu, the 2018 Spanish flu, 1957 Asian flu, all influenza A virus, subtypes of influenza A, H1N1, H2N2, so pandemic resulted. Then the other one, the Zika pandemic, 2015 to 2016 Zika, which happened in Brazil. Then the COVID pandemic, 1999, the West Nile pandemic, which happened in West Nile in the US, many outbreaks and deaths. Okay? And then 1970 monkeypox happened. We had recently outbreaks of monkeypox virus 2022, 2023, etc. in Kerala. So the factors underlying zoonotic spillovers. So one is the interaction between the basic condition for the occurrence of a spillover event is the interaction between different species. So how does this happen? So in exposure to wildlife, live and animal markets. So you can see at the extreme end that travel. So the professionally people are exposed, meat industry workers, veterinarians, farmers in close growing contact with livestock animals like poultry, swine, professional meat industry people. So if they are not taking adequate personal protection and if they are not provided with good environment for working with adequate protection, they are exposed to these pathogens. So the livestock animals and the domestic animals which we keep as pets. Rabies also is an example. And interaction of humans with wild species is an example. So the examples are HIV emerged from wild primates, Nipah, Ebola, Hendra, examples of pathogens that cause outbreaks with animal species. Then the phylogenetic distance between host species. Okay? So the interactions between species, factors between wildlife, livestock animal and humans. The phylogenetic distance, the greater the similarity between the species, the high genetic similarity between the source and the recipient host, greater the chance of getting this zoonotic disease. So that is because of the high similarity of cellular receptors between host species, and the risk over of spillover is high. Then the bat-borne viruses. Bats are a major reservoir of many species of pathogens, and characteristics of the pathogens like viruses with an RNA genome have high mutation rate and more frequent gene rearrangement. This increases the chance of adaptation to new host species. So after a spillover event, the ability of the virus to produce long-term chronic infection, the presence of non-segmented genome, absence of viral envelope, infection of the respiratory tract, which can facilitate the spread of viral species, favoring the emergence. Then the other factor, which characteristics of the pathogen, in which the other factor is the stability of this pathogen in the environment. How in the environment this pathogen is able to resist and stay fit in the feces and secretion of animals, especially the non-enveloped viruses. So that is a major important factor. Different taxonomic groups like alpha virus, delta retrovirus, some of the taxonomic groups have a higher proportion or higher chance of producing viruses with a zoonotic spillover, and while family herpes viridae have low zoonotic potential. So, and also the extensive and the inappropriate use of antibiotics in our era, in both in the medical and the veterinary field, has led to selection of microorganisms resistant to very different classes of drugs. Then the animal host associated factors. Few factors I will tell, I'll then come back to this slide. So encroachment into the natural ecosystems. So this is by deforestation, converting the forest land into agriculture and pasture land, so that the contact between the animals and the humans are increased. Okay? The genetic modification of the virus, the migration of birds and animals, livestock handling and sanitation, these are all contributing to the factors responsible for zoonotic spillover. So bats especially have a high body temperature and high metabolism, so that they can host a lot of viruses inside their body, and they are also responsible for Ebola, Nipah, Hendra and SARS. The pig acted as a mixing vessel. The swine acted as a mixing vessel in the 2009 H1N1 pandemic, and cattle to human transmission of avian influenza A virus. So all these factors, some of them act as not as reservoir hosts, but also as bridges and intermediate hosts. So bridges and intermediate hosts like mosquitoes transmit arboviruses from wild primates to humans, especially in case of dengue and yellow fever. So the environmental factors like loss of biodiversity, that already explained, and forest and landscape. The small species like rodents, shrews, they also, if you convert the forest area into pasture, there is emergence and spread of new human diseases through the proliferation of small species through rodents, shrews, etc. The human host associated factors can be
some people are very susceptible by the immunological and genetic factors susceptible to immune infection. Toll-like receptors, Th1 and Th2 cell types dictate the abundance, especially the NLRP3 gene polymorphism, for example, was associated with protection against HTLV1 infection individuals from northeastern Brazil, while a study involving HIV-infected individuals showed that IL-4 gene polymorphism is associated with susceptibility to pneumocystis carinii pneumonia. So models of zoonotic spillover. So there is a source host which transmits the pathogen. There is a recipient host which accepts the pathogen, and a bridge or a intermediate host. So the bridge or intermediate host can be a vertebrate or an invertebrate, or it can be in the environment itself. So this can be invertebrate like a mosquito, or in the environment from the virus, from the source host, this can stay in the environment, okay, in the stool or in the environment for a long time, like hardy viruses, and then can be transmitted to the recipient host. So this is one model of zoonotic spillover. This is another model where in the intermediate host, the pigs, especially, for example, the virus can transmit and can mix with the viruses of the pig and can produce a new virus which can infect the recipient host. So the intermediate host acts as a mixing vessel. So this also from two sources, the intermediate host act as a mixing vessel to the recipient host. Okay? So this also is another model of zoonotic spillover, especially in the arbovirus can be transmitted, or swine species, influenza can be transmitted like this. So what is viral recombination? Viral recombination is a phenomenon that occurs when two viruses co-infect the same cell and interact during replication to generate a new progeny, the genomes of which contain the genetic information obtained from both parental strains. Reassortment is the switching of viral RNA gene segments in cells infected with two different influenza viruses. So this is a picture which shows the unsegmented RNA viruses, what happens, okay? So you can see the red and the blue, the genomes, and the progeny having a new progeny which is having a red and a blue genome. While in the segmented RNA viruses, example influenza, you can see the reassortment taking place, and the progeny is a mix of the red and blue. Okay? So this was the case in new influenza strains which emerged with reassortment of human and avian influenza viruses in pigs. So H1N1 avian and H3N2 human led to reassortance, and that led to a new virus strain which was the 2009 pandemic influenza virus. Okay? So this also is another model of zoonotic spillover. So what is the outcome of a zoonotic spillover? It is not that all the time the spillover results in a transmission from human to human, and all the time it results in epidemics and pandemics. It happens when there is the pathogen that cross the barriers between species can spill over, and then also it can happen into a dead-end spillover in which it stops with the man and there is no continuation from human to human. So that depends on whether the social, biological and environmental conditions are favorable for the adaptation of the pathogen in the human host. There is also something known as reverse zoonosis, in which the pathogen can be transmitted from human to non-human host. Humans can transmit Mycobacterium tuberculosis to cattle. It has been shown that strains of influenza viruses are transmitted from humans to swine, and rotavirus, evidence of transmission of SARS-CoV-2 from humans to dogs. So these cases are known as reverse zoonosis. So this is the outcome of a spillover event. So this is the spillover pathway. So the wildlife distribution, also from the wildlife, the domesticated animal, the animals which we keep as pets like dogs and cattle or hens, the pathogen can come from wildlife to the livestock and then to human. This is a typical example of avian influenza, when the migratory birds come in large groups and settle near our domestic settlement, where they come into contact with our domestic hen and transmit the pathogen. And in the domestic hen or in the pig, that acts as a mixing vessel to convert this pathogen into a new mutated or a new virulent one, to which our human body is not exposed at all. And then it becomes a pathogen for us, and then it spreads. So this is the spillover pathway. So this is another one in which the COVID-19 cluster, okay? So this was the most significant spillback event of SARS-CoV-2 in the WHO European region. This is the wild mink, wild deer mice or so, that. From that to the farmed mink, from that to human, okay? So that can be reverse zoonosis or the other way also. So looking at the Brazilian and Chinese context, I'll have a few words on that. Before we go to the Nipah outbreak, I will say a few words in the Brazilian and Chinese context. Brazil, large forest area, deforestation happened, environmental degradation, loss of biodiversity, all the factors which I mentioned earlier in my talk happened, creating the basic condition which is needed for the zoonotic spillover. Ebola outbreaks in Africa also examples of that, same thing, okay? And disturbance in wildlife and increased bush meat consumption, that happened. In China, what happened? Wet markets. Wet markets are the part of the national culture and demanding large volumes of wild and live animals to supply in the restaurants and family consumption. So they were in very close contact with the humans with poor sanitary conditions. So that created the emergence of COVID-19 emergence, and hunting and commercialization of meat from wild animals in Brazil, all these factors. So our own social cultural factors, maybe we can say that it is man-made only, which contributed to these epidemics. The epidemiological analysis of Nipah outbreaks in Kerala, 2018, 2021, 2023, 2019 in Ernakulam, we have seen the Nipah outbreaks and how the state of Kerala very aptly responded to that and contained the outbreak. So we can see that. So from an epidemiologist's perspective, male preponderance engaged in outdoor activities. All the three spillovers happened in the same Kozhikode district with the same geographical belt, suggesting a common link of environmental, behavioral, or a combination of both. So the affected geographic area in Kozhikode shared common features like presence of plantation areas with fruit trees, exotic fruit trees, natural forest cover, which is home to several bat species. So this confirmed bats as the reservoir for the Nipah outbreak, and the strain was, the Nipah virus strain was sequenced, and that has been considered. So the challenges we face with response to containing the outbreak is the reservoir diversity, the bats, rodents, primates, domesticated livestock, all this come into the picture. The viral adaptation and evolution. Virus itself undergoes recombination, reassortment, all that. Lack of
Excuse me, madam, 5 more minutes.
Yeah. I'll quickly finish. Lack of highly sensitive and robust diagnostics. So coming to the solutions, what are the solutions we have? These were the major findings of Nipah outbreaks in Kerala. So areas to focus on preventing pandemics, proactive surveillance in the geographical areas, diagnostic and therapeutic using artificial intelligence tools, One Health approach, rules and regulations, prevention of zoonosis, understand the infection dynamics in the natural host and environment, integrated surveillance, lab diagnostic, preparedness response, healthcare, preventing spillovers, improving sanitary control of livestock, increasing surveillance, control hunting, reduce deforestation, avoid the construction, control vectors, increase investments in human training and laboratories, identify the biological and social factors, regulate biosafety protocol for professional working with wildlife and livestock, sterilization of wildlife population, vaccination campaign, mandated separation of wildlife and livestock, vaccination of livestock, limits on live animal market size, animal quarantine, disinfection of livestock, mandated rest days in live animal markets, targeted vaccination, post-exposure prophylaxis, guidelines. All this contribute to the rationale for One Health. Okay, so all this, whatever factors, all the 70 to 80% of emerging infectious diseases are known to be of zoonotic origin. And what is the One Health approach? It is an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animal, and ecosystems. So there are from tripartite to quadripartite, they have strengthened the partnership, and MOU is there with all these 4 organizations, and enhancing the joint One Health action plan, enhancing One Health capacities, reducing the risk, controlling the eliminated zoonotic and neglected tropical vector-borne, strengthening the assessment, curbing the silent pandemic of antimicrobial resistance, integrating the environment into One Health. So that is the end of my talk. I hope it is clear. Thank you.
Thank you, Madam, for that excellent session on highlighting that the pathobiology behind these zoonotic spillovers and why we should be on the lookout for these spillover events. Now the session is open for discussion. 2 questions, please. Yeah, please.
Thank you, ma'am, for the thought-provoking talk. Ma'am, I have a question. This is just out of curiosity. Like we use genetically modified mosquitoes for several diseases like chikungunya, dengue, malaria, Zika. Can we use something similar to use like in bats, which can stop the transmission for Nipah, like particularly Nipah, something like that, like just as...
We can, it's a very difficult question to answer, but we can investigate something like that. Okay, I don't know how much practical it is, because bats themselves are reservoirs for so many pathogens. Okay, so it is not one pathogen, it is so many pathogens. So we can investigate, but I don't know how much practical
I'm happy to collaborate with on that with anyone. Thank you, ma'am.
Very nice talk, madam.
Thank you.
So, this is a kind of general question. Historical data shows that pandemics and epidemics were very frequent in the past. So, is it accurate to say that viral outbreaks have increased now than in the past? This might be due to increased global travel,
yes,
increased awareness, and most importantly, better diagnostic facilities.
Yes.
What is your opinion about that?
Yes, I wholeheartedly agree with you that viral outbreaks were there early in the past, but it is more increased because of globalization, travel, And we have one Ebola outbreak in Africa. After that, we hear of that same outbreak in US. Or we have a monkeypox only restricted to Africa. Now we have it in Kerala also. So definitely it is more travel and climate change. All that has contributed. All the factors have contributed.
Thank you, ma'am, for the talk. I just want to respond to that friend who was asking for genetically modified bats. And be a bit careful, like mosquitoes, they are low down in the evolution. Bats are flying mammals. So they share quite a lot of DNA material, genetic material with us. Actually, playing around with the genetic mutation in bats and all will be very risky affair. So keep that in mind. Okay. Thank you.
Another thing to add to that is actually the flying bats will come under the purview of forest department, and you try playing with forest department, they won't allow you to even to collect the sample of this bat feces, okay? Yeah, it has come to schedule 2 as well. They won't allow you to go near the bats. Madam, I think we'll end this session.
Yes.
One doubt from my side, you said that unenveloped viruses, there is more risk of spillover. Why is it so?
The envelope actually is made up of lipid and protein. So envelope, lipid dissolving solvents, if you use, the envelope of the viruses is destroyed. That is why we say for rabies, washing with water and soap is very important. In the first, after a bite, no, immediate washing and flushing away of that wound with soap and water is very important, because the envelope in the soap, the soapy part of it, which has lipid solvents, will destroy the lipid of the envelope protein, and it will render the virus ineffective. While the unenveloped viruses are the more hardy viruses. That is an established thing in virology. Unenveloped viruses are the more hardy viruses which are able to be stable in the environment for some more time compared to the enveloped.
Thank you, madam, for the excellent session.
Thank you, Dr. Shobha Maman, for sharing such thought-provoking insights and valuable research. I now request Dr. Arvindar to hand over a memento to Dr. Shobha Maman as a token of her appreciation. Now I request Dr. Biju Soman to invite the next speaker to the scientific session.
Thank you. I'm very happy to introduce Dr. Umar Karadan. Actually, Dr. Umar Karadan is a senior neurologist with over 30 years of clinical and research experience in stroke care, neurointervention, and movement disorders. He leads the Department of Neurology at the Baby Memorial Hospital and co-directs its neurointervention program. He holds multiple fellowships from prestigious bodies including Royal College of Physicians, UK, the American Academy of Neurology, the Indian Academy of Neurology, and the European Academy of Neurology. Recognized by the Government of Kerala and Professional Association for his role in Nipah outbreak detection and containment, he has served as principal investigator in over a dozen of clinical trials and authored several peer-reviewed publications. Dr. Karadan also heads Samarpanam Charitable Trust and contributes actively to academic forums and neurological societies. So over to you. So at the end of 25 minutes, we'll give a warning, sir, so that you can finish.
Thank you very much. First of all, I would like to thank Srikumar sir and Ajajesh for inviting me for this talk. Thank you, Madam Simiti Tiwari, Dr. Guru Prasad, and all the colleagues and friends. So, just before getting into the talk, I would like to take you back to 2018, where after our neuro ICU rounds, we had a call from the medical ICU in 2000, way back 17th May. My colleague, Dr. Jayesh, and me went to the medical intensive care unit, and we had a consultation there. Usually we get 1 or 2 consultations from all the ICUs. So the aim is how we made a diagnosis. That's maybe it's a pointer to you all in making diagnosis in the future. So this patient was admitted at our hospital, Baby Memorial Hospital, early in the morning. He was around 27 years, had fever, altered sensorium, agitation and stupor. And because of the low GCS, Glasgow scale, he was intubated and ventilated. His Glasgow coma scale was just 3 only out of 15. He had a profuse diaphoresis, high-grade fever, tachycardia, high blood pressure. Pupils were small and reacting sluggishly. He had no neck stiffness because already he was intubated and ventilated. All rims were flaccid with the ear reflexia. He had no jaundice, lymphadenopathy, rashes or vesicles, no exanthem or enanthem, no eschar, no bleeding diabetes, conjunctivitis, parotitis, or focal weakness or extrapyramidal syndrome or Gaze palsy. So with that, he was already investigated by the time the blood biochemistry was normal, except for mild thrombocytopenia, liver function tests, blood counts were all fairly normal. He had ARDS, that's hypoxemia, cardiac enzyme showed, echo showed features of myocarditis, some cardiac dysfunction. CSF done were normal except for mild rise in protein, otherwise unremarkable. Viral panel where HSV1 and 2 were negative. Dengue, lepto, scrub types also negative. Malaria was also negative. So with that, we were invited to see this patient. And this is X-ray. You can see there is a ground glassing appearance with some fluffy exudate in the both the lung fields. And the MR shows there is a few hyperintensities in both frontal and parietal lobes. Here, at this location, these are the lung fields. And the patient is already on acyclovir, antidiarrheal measures, and other supportive care. So we were wondering whether it's a common form of encephalitis because of the rapid progression. Many odd points, but we just asked them to continue this acyclovir and steroids. When we were speculating about the diagnosis, we had a call that 2 of his relatives also had a similar episode, similar problem, like and his brother had died at Calicut Medical College. Then, we were a little worried about what could be the relatives, and 2 of his relatives had the similar episode, some sort of illness. So actually what happened was 6 months earlier, we had a case where there's a family poisoning in a family. So we thought that because of some financial issues with and it was poisoned by the mother and something like that. And finally, we found that it's a case of poisoning. So initially we thought that this could be a poisoning because somebody died, then again one member, 2 or 3 members. So there's a first consideration whether it could be a poisoning. And similarly, at the same time, we had another case, because of the cyanide. One case was brought to our medical intensive with some sort of Korea poisoning. And later, after 2-3 years, we knew that it's a case of 6th death. It was killed, murder by this person called cyanide Jolie. We saw the next case, this father, he was around 75 or something like that. He had fever, headache, giddiness, tremor, profuse tremor, myoclonus, incontinence. When we were examining the patient, he was incontinent. But in fact, we were not wearing mask and all at that time. We were just, casually examining because we used to get all these cases frequently. He also had a very high blood pressure of 200 and 200. Tachycardia, drowsiness, but he had bilateral ptosis and action tremor and postural tremor. The hand was shaking like this with incoordination. At the same time, he had a third case of paternal aunt with sweating, altered sensorium, irritability, restlessness, or almost the same features as the other patient. You know that these are the things that was in our mind, starting from the stroke to anything, could be anything. So we had hundreds of things to dissect out. Recently we had, this is for interest to the junior colleagues, we had a couple of cases of primary amoebic meningoencephalitis coming with fever, headache, altered sensorium. Some of them died and we could save some of them. They can also come in a family. So we should be careful of this entity also. So what's an encephalitis? Any person at any age or in time of the year with acute onset of fever and change in mental status, confusion, disorientation, memory impairment, difficulty to walk, aphasia, focal weakness, movement disorders, anything can come into the purview of encephalitis. Just for a differential diagnosis, you can see that the initial consideration could be whether it's a stroke. Well, at the top of basilar syndrome, that the basilar artery occlusion can, or top of basilar ischemia can give us some altered sensorium, irritability, and things like that. Or this could be just like I showed the previous slide, whether it could be some sort of a metabolic, organic, toxic, infectious, inflammatory, demyelinating, trauma, hundreds of causes, whether it could be anything. So this was the first initial consideration, poisoning, whether it could be poisoning, because it must have been poison, because there is a clustering the family. But the odd points where there is fever, headache, multiple systemic symptoms, high blood pressure, and autonomic response, which made us think that very unlikely that is a case of food poisoning, and brainstem symptoms were also there. Or this could be botulism, because in the same family, multiple members affected, but there's no pupillary dilatation, no constipation, and the systemic symptom and the hypertensive response, and the brainstem response were all against the diagnosis of that. So we excluded those two possibilities. Or whether it could be some sort of meningitis, like a fulminant meningitis, like a meningococcal meningitis, but the CS was fairly normal. So that rules out a close family clustering in a case of meningitis. So it is not a meningitis also. So we had a doubt. Then we finally came to the conclusion it could be a viral encephalitis. We didn't know what. There's a host of, I think I'm just a beginner, means I just had a brief glimpse of virology during my MBBS. Afterwards, we never had a chance to learn further. And we were wonderstruck what could be, because of it may be from herpes simplex to many arboviruses. And as you're all aware, there can be a viral neurotropism. Some virus affects the spinal cord, some affect the brain, the temporal lobe, the frontal lobe, the limbic system, peripheral nerves, dorsal root ganglion, anterior horn cell. So many things can, or the Ammon's horn, or the meninges, the vessels, endothelium, thalamus. Many parts of the brain can be affected depending on the neurotropism. Varicella zoster can have the dorsal root ganglion, poliomotor, anterior horn cells, Epstein-Barr virus, cytomegalovirus, so it can affect ventriculitis. So, but this patient, or the other possibility whether it could be rabies, though it's very, very unlikely that a clustering, but the clustering, the sort of rapid progression, and which is unheard of. We never had a chance of having these sort of symptoms in a clustered manner in a family. So just sort of rabies, because that is the picture how this could be. The basal ganglia, the caudate nucleus, the putamen and part of the thalami. But the short incubation period, and all the family members getting at almost the same time. So it is very, very hard to believe that rabies could have behaved in the same way. and never had any hydrophobia or history of bites or aerophobia or other. These are the other manifestation how the MR can look, can be varied. Then we had a thought that it could be Japanese encephalitis because occasionally we get Japanese encephalitis. When I was at Kottayam Medical College, we had a couple of cases from Japanese encephalitis. So this is our case only. I mean, some other case in the past. You can see there are thalamic hypointensities and hyperintensities, and some suggestion of hyperintensity in the basal ganglia. But the thing is, there will be prominent extraviral syndrome. There can be tremor, there can be dystonia, Parkinsonism, myoclonus. They can have, mask-like tremor and bradykinesia. That means patient will have something like a movement disorder, tremor, and Parkinsonism will be a dominant picture. There will be rigidity of limbs and no human-to-human transmission because vector-borne disease and no autonomic symptoms in these cases. So it's very unlikely that we are dealing with a case of Japanese encephalitis because in the Malaysian outbreak, they were all thinking that the initial case could be Japanese encephalitis. And moreover, this Japanese encephalitis usually affects the young kids and with the refractory seizures and movement disorders. So that's also, we've thought that it's very unlikely that the patient had a Japanese encephalitis. The common garden variety of herpes encephalitis is very, very common. Every year we get at least 5 or 10 herpes simplex encephalitis. They can just come to your OP. It's called walking encephalitis. They just come to you, but they will have aphasia, memory impairment, difficulty in speaking, no weakness. Sometimes they can have weakness also. And it can have, from one spectrum, will be mild to the extent of comatose state with the decerebration, and it can have a spectrum. So usually they'll have this fever, system symptoms, headache, altered sensorium, seizures, refractory seizure, focal fit, and confusion, memory impairment, aphasia. That's how they present. And classically they affect this insula, because the insular region, the limbic system, and the cingulate gyrus will be affected. This is our case only in the past. So the limbic system will be affected. This is a viral neurotropism. And very unlikely that we are dealing with a herpes simplex encephalitis also. So we just try to think what all the various possible, because we never had a suspicion of a particular new virus in our state. The other thing, you can see that the shingles or herpes zoster, they usually present with the vasculitis. There is a stenosis of the middle cerebral artery at the origin, and they can have a clustering in a family, but it won't come like that because they can have a varicella, not a herpes zoster, and they won't come with the encephalitis. Very, very rare. Usually they come with a stroke, or this is a case of stroke, or they can have bleed. This is also our case in the past. You can have a bleed in the frontal lobe. And recently in the pediatric ICU, we had a patient with a posterior reversible encephalopathy with a severe hypertension and seizures. These are the way they behave, the herpes zoster virus behave. Recently we had a case of West Nile also. It's a government employee. During the election, he had a fever, headache, and altered sensorium. And the MR shows a classical hyperintensity in the basal ganglia and the caudate. He remained in our hospital for 3 months and later expired. So whether this could be something like the West Nile virus, that's also our consideration. But usually they will have irreflexia, meningitis, encephalitis. But usually the mortality is around 20%, 10 to 20% only. And mostly they'll be asymptomatic or, encephalitis getting into a family clustering is very, very unlikely, and there's no human-to-human transmission. And usually the CSF will be abdominal. Usual viral infection, the CSF shows more lymphocytic pleocytosis. Here in this, the very characteristic that you get CSF will fill with the neutrophils. Don't diagnose pyogenic. I mean, you should diagnose, pyogenic should be in your consideration, but they can present with a neutrophilic leukocytosis. Recently we had one Lyme also with monocytosis. Recently one case. So, or this is not my case, this is my colleague, I asked this. So whether other virus can also present the same way, like dengue encephalitis with hemorrhage, it can be infarction, demyelination, and then also they can have biphasic fever, thrombocytopenia, hemorrhagic tendons because of the low platelet count, and very unlikely that they also transmit from one person to another or clustering the same family. Or chikungunya also another possibility. These are the viruses which came to our mind. Whether it could be this or that, like that, in that order. And chikungunya can also present in this way: seizures, renal failure, behavioral changes, and severe arthralgia. So, and recently we had this case of mumps encephalitis. We treated mumps encephalitis, adenovirus, enterovirus, SARS, COVID virus, and enterovirus also. Recently we had a mumps encephalitis. That comes 1 in a million, something like that, extremely rare. So everything was not fitting with the clinical syndrome of these particular patients. And rarely then we thought of it, are there any viruses causing encephalitis which can spread from human to human? Then the answers could be a Venezuelan equine encephalitis, rarely can transmit. And this is I got from my friend from US. We were collaborating for a chapter on hemorrhagic viral infections. He sent me all this, the St. Louis, Powers and Eastern Equine lacrosse. There were the MR findings of that. So finally, we thought that this could be something like this: an unusual virus with high human-to-human spread, with a rapid progression, multi-system involvement, prominent autonomic symptoms, myoclonus, high fatality, with no features confirmed any of the above mentioned usual encephalitis. That's how the diagnosis of Nipah came to our picture. So we talked to our critical care team, Dr. Anoop and other faculties, and asked to send these samples. And by that time, the fourth case also came with altered sensorium, features of abducens palsy, and ataxia, and other things. A fifth case also came, because they had contact during the hospital, medical in the wards and all. So he also had altered sensorium, irritability, hypertension, tachycardia, autonomic symptoms. Recently, this is the last case. This is I got from my colleague from Perindavanna. I think the patient is still in the Manjeri Medical College now. The patient, you can see there are necrotic lesions in the brainstem as well as lesions in the basal ganglia in the external capsular region. They can have vasculitis. Nipah can also cause. And these are the other pictures. This is from net only. These are the areas. Starry sky pattern. This is the way how they will be seen in case of MRI. You can see that there are infarcts or not infarcts. Yes, it's a micro-infarcts. They are in the middle cerebral peduncle, in the pons, in the basal ganglia, in the thalami, limb of capsule, in the spleen and other regions. This is how the MR pictures of a Nipah looks like. This is the data from Calicut Medical College and our data. You can see that these are our cases. The BMH data, we send all these samples collected, and all of them died. The mortality, except for one, there's, it's all, everyone knows that the mortality is almost 100%, maybe 90% in our this thing. The symptoms in our patients were, they had a fever, sore throat, myalgia, headache, vomiting, altered sensorium. Myoclonus was seen around 60% of the cases. Segmental sweating was also seen. Tachycardia, cerebral ataxia, cranial palsy in 1 or 2, and respiratory distress, ARDS, respiratory problems. So finally, every patient lapsed into multi-organ dysfunction, ARDS, coma, and expired. This is the data from Calicut Medical College. So the presentation could be any of this way. It could be encephalitis with the ARDS, or encephalitis ARDS with the myocarditis, or it can be ARDS alone, or any of this manifestation can occur. So I'll just give a few words like encephalitis, the incubation, because I think you are an expert. I don't have to tell you all this thing, but just for completion's sake, I just put this slide. The initial symptoms of fever, headache, severe headache, myalgia, vomiting, and sore throat. Later, the last case, as reported, the patient later developed respiratory distress, intubated, continuous fits, and patient lapsed into coma. The patient is still in a persistent vegetative state. This is how they behave. And they can like a typical pneumonia, respiratory distress, and coma. What are the salient features you should remember? They have segmental myoclonus, uriflexia, hypotonia, hypertension, tachycardia, and go into this encephalitis septicemia, multi-organ dysfunction with a high mortality, right? And what are our case? What are the distinctive features of our case? You can see that's a clustering of cases in family, very short incubation period, rapid progression, early death with central nervous system involvement with the ARDS, respiratory distress, cardiac involvement, myocarditis, autonomic dysfunction, tachycardia, and hypertension, segmental sweating, segmental myoclonus, ptosis, there's a drooping of eyelids, tremor, ataxia, hypertonia, and uriflexia. Cranial neuropathies were reported in 2. And we thought it was probable human-to-human spread because we were just speculating at the time. And MRI showed starry sky pattern and mild thrombocytopenia. With that, we sent the investigation to Manipal. And these are the team, Dr. Jason, Dr. Arun, Dr. Bhargav sir, Dr. Anoop, Ajit, and Ganga Prasad from our hospital, Baby Memorial Hospital. So I just want to give a brief idea about this. Thank you. Thank you very much.
Thank you, sir, for sharing that concerns and your experience as a clinician, especially for these highly fatal diseases. I request Arvind to comment on the clinical profile because I'm not a clinician.
Thank you, sir, actually for taking us through how you came to the diagnosis of an exotic encephalitis. No, it's not easy at that point of time because we never had any experience with Nipah in the past. But even in 2024 and 2025, still, the recent case, the diagnosis was made from the autopsy findings. No, it's not that all the patients are presenting with encephalitis and all. So what will be your advice to all the clinicians out here, not only to the neurologists, because the current case was admitted in the cardiology, ICU, etc. So how to keep a high index of suspicion is it for all cases of encephalitis or encephalitis plus ARDS or encephalitis plus ARDS plus myocarditis? How should we go forward?
First of all, the history, if it is not conforming to any known encephalitis or, it's a very rapid progression because most of the encephalitis, they'll have some time. You'll have, like 1 week, 2 weeks, because a rapid progression and multi-system like brain involvement, lungs involvement, and the way how the encephalitis behaves, that's very important. And the MR will be non-specific because once if you know there's a Japanese or thing, they'll have particular neurotropism. The MR will show abnormality. Okay, and the CSO also very non-specific changes, just like hardly is normal, just maybe 40 CSO protein is very slightly high. So once you find this sort of abnormal symptomatology or signs, always be careful. You are dealing with something very, very special.
Thank you, sir. So now, yes, please.
Hi, I'm Jishnu from Calicut University. So I had this doubt regarding virulence of this virus. So theoretically, I have read that viruses can, after a period of time, can go down in virulence. So you are mentioning about rapid progression. So would you be expecting this rapid progression symptom coming down, and maybe this virus can show a prolonged progression?
I think I'm not an expert to answer that question, but probably I believe that could be the amount of inoculum that is given to that recipient. Would you please?
I think his question is with regard to like after a period of time, the viruses, it will select between the fitness cost and its virulence, right?
Yeah.
So
Exactly.
as of now, with our experience in Nipah, is not taking that path. As of now, it is still remaining as a very, very virulent virus. Okay.
Thank you.
A couple of more questions more. Okay, so one more question. So yeah, thank you, sir, for the excellent talk. Okay.
Thank you very much.
So that was a highly informative and well articulated presentation. It was truly a privilege to hear from you. And now I request Dr. Biju Soman to hand over a memento to Dr. Umar Karadan as a token of our appreciation. Next. Now I request Dr. Aravind to invite the next speaker to the scientific session.
So the last talk of this session will be on pandemic preparedness, building resilience for the future. So we are delighted to invite the next speaker, Dr. Sheen Job. Colonel Sheen Job is a seasoned public health professional and former military medical officer with over 25 years of diverse experience spanning trauma care, military medicine, global health logistics, and national immunization strategy. He currently serves as lead consultant in the immunization division at the Ministry of Health and Family Welfare, Government of India, where he contributes to the design and implementation of national immunization policies and disease surveillance systems. He has served as a technical specialist for disease surveillance at NCDC and as joint director at the regional headquarters of the ex-servicemen contributory health scheme in Coimbatore. Dr. Job has also completed specialized training in palliative care from AIMS, United Nations Field Hospital Logistics, and Naval Medicine. His unique blend of clinical acumen, operational leadership, and global health experience positions him as a valuable contributor to India's public health preparedness and immunization efforts. Over to you, sir.
Thank you, sir. Thanks for inviting me, first of all, to the organizers in the Institute of Advanced Virology. In fact, I must be making haste now because I'm standing before you and lunch. So I just have 15 minutes to run through the pandemic preparedness. Most of it has been covered by Dr. Shobha Madam, so I think I'll be skipping the ones that she's already mentioned, and I'll go mostly into the global, the interventions that are at the global level. So it's only for your understanding, so the rest of it has been explained already. Next slide, please. Yeah, this story is pandemics new to us? Not at all. You see this diagram here? It goes from 542 AD. This is the World Economic Forum in 2020, which has published this. And this is the status of our the entire thing that has been already described by Dr. Shobha. In fact, the most important thing is, why is preparedness required? Now, if I ask you, you might say, are you expecting a pandemic? Is there something like that? See, nobody expected COVID-19 to come at this scale, did we? We did not. We just heard something is happening in Wuhan in November of 2019, and all of a sudden in 2020, the entire world has collapsed. I mean, that was the story of a pandemic, you can imagine. And nobody even suspected. We'd never had anything, any kind of interventions or checks in place until that time. And that is when we realized this globalization is one of the most important factors for us, wherein there is an increasing spread of diseases all across the borders. So here when you say globalization, it is that countries which are getting interconnected, integrated now, all of them, you know, the information is getting integrated, a lot of services, goods, capital, everything is getting integrated. So now it is like all countries getting integrated into a global system. So when this happens, you know, there is a lot of interconnectedness as it is happening. You might have some pros and you can also have some cons. So these are the issues with globalization. Okay, another thing is we also saw in pandemics in COVID-19, how it was overwhelmed. We had hospitals, all right, we had government setup, we had private setups, everything was there all across. But suddenly what happened was you could see these newspaper reports and TV reports and where long queues on the roads, ambulances standing there with absolutely no beds, almost 100% overwhelmed, and they have absolutely no clue what is to be done. And even there was a huge scenario when countries used to come in, like Germany used to come in at that time, pitched in with all of their LMO, the liquefied medical oxygen supplies from Germany. What an embarrassment for us. We had international support, aid coming to India just because we didn't have it, we didn't expect it, and we never thought about it. So that was the kind of embarrassment we had at that stage. And ever since that, we have tirelessly worked to get into this bit, and tomorrow if something happens, we will have a check first. Now, Nipah also surfaced around after about 5-6 years, after just before around that time. So when we were aware that there needs to be a check on these things, and we had to do it, we do it accordingly. Now, the third part is pandemic preparedness is a huge requirement. Now, we are talking about economic growth all the time. India is currently now the fourth largest economy in the world. Now, you want to establish that as a fourth and maybe the third or second or whatever that is. If you need to do that, you need to keep it sustainable. This particular economic development has to be sustainable. But COVID taught us otherwise. Pandemics can collapse your economy. In no time, the LMIC countries, the low and medium income countries literally collapsed. Even countries like Dubai, which we thought were the most affluent countries in the world, they collapsed. The reason was there is absolutely nothing happening. There's no production, there's no demand. Because everything is it's a lockdown there, anything and everything. And this is what happens when such scenarios come in front of you. So this is for our understanding that why are we, and this particular venue of Institute of Advanced Virology, because 70 to 80% of pandemics or whatever these outbreaks are, which is going across the international borders, are largely viruses. Now, where is the tipping point? It's still a mystery. We still don't know. We have a lot of research going on. We've got so many studies going up and so many interventions coming up. We still don't know where is that limit where this virus goes beyond control and just tips and just falls into a thing which spreads across international borders. So here, can you just change the slide, please? So what do we need in pandemic preparedness? Though things were explained to you, I'll just run you down through these. And the most important of all is surveillance. You need to watch each and everything. There's no doubt about it. You're in an institute of virology or you're in a public health institute, doesn't matter. This watch is a huge requirement. You lose your guard and there we lose it. So this is what COVID has taught us. I'll be coming to those slides again. The healthcare system strengthening. Now this is another important thing. Do you have adequate manpower? Do you have trained manpower? Do you have, like for example, the neurologist, sir has just told us about it. To identify a disease, you need to know about it. You need to know for sure that this is a confirmed case of this particular disease with this kind of risks involved, and this needs to be communicated to the public in time. Are we capable of doing it? Do we have the capacities? This is exactly what we do in HSS. This is healthcare system strengthening. So this is more important for us, where we need manpower, we need infrastructure at all levels, diagnostic, hospital beds, the supplies, the oxygen supplies, or vaccines, or whatever that is. The adequate training for the manpower, and all these are steadily required. Another, most importantly, is the supply chain and logistics. Excellent, the example I can quote you, when I was working in Africa, that is when Ebola struck in West Africa. Nobody knew that this would happen in overnight, and villages were decimated. Villages decimated. That's the word I want to use. You go there, the frontline workers are dead scared to even cross the village boundary because they're so scared that they may not come back alive. Now, when we saw that scene, The first time when we made an effort to get into that, the UN supplies, the UN, every team went inside. We had our PPEs and walking into that. The only thing that old village elder who survived, I do not know how, it's a miracle, but what he said was, the second day, there is some African name for some voodoo something, I don't know, some name he said. And he said, he comes, he strikes the door, and that family is dead. So I was like, what is this? What is this guy speaking? So what I really understood was the signs and symptoms that come up on the day was hemorrhage in the family. They can just bleed through, they just bleed. Fever comes in, swelling and things, they have pain, from, whatever, fatigue, the general viral myalgia and all those things, just the usual symptoms. The third day or the second day, that's it. They bleed profusely through whatever, or mucosal bleed which happens anywhere in the body, and there is death. That was Ebola. And we just stood there, just standing up and doing nothing except we had to carry the dead bodies and dispose them. That was all. We were asked to incinerate the bodies because there was no other mechanism available. There was civil war going on there, with absolute chaos. And UN was the only agency which was the governance there. You see the difficulties in pandemics. I'm talking about African countries, all right? I'm not talking about us. But this is just to give you a comparison. How, like people like us who have gone there, we saw it ourselves. Pandemics can create a real chaos in the entire communities and internationally, also nations. All right, can I go back? And then communication and behavior. This is taken very lightly. And honestly, I can tell you that if you do not communicate to the public about the risks involved, that is called the risk communication as a big entity. If you do not do that in time, you have lost the battle. Because they are the ones who are the victims. The health worker, the frontline health worker who's there in the field, who is the interface for, who's the interface, this particular human, the health worker or the link worker, the frontline worker, he has to be told everything. He has to know it entirely. It's not that something like overnight, come on, chalo yaar, you go there and just do that and come. He has to be informed about what exactly are the risks involved, what are the precautions you need to take, and then you need to go and apply there. But this was not available and was not taught to people, and this was not even considered at levels where the trainings had to happen or informations have to be passed. So communication and behavior change is a huge requirement. It is not just for the public, it's also for the health workers, including the doctors. All right. Now comes the bigger part of it, research and vaccine development. Now, in COVID, what happened was we had something called, the first time it came up was EUL. I mean, that was the emergency user listing. I think it's 6 minutes? Okay, thank you. Emergency user listing. Now, what is this entity? It took, actually, historically, we see every vaccine that is developed, it takes 10 years, 15 years, animal trials, and I don't know what all they do. Human trials, and then the post-market trials and surveillance, and everything happens. But then, what you find in this is, COVID, when it struck, vaccine development had started side by side, but that really took about 6 to 8 months. But within 1 year, the vaccine was launched. Now, was this conventional thing to do? It definitely is not. Is it the right thing to do? At that time, it was do or die situation. Whatever you had, just try it. So the WHO was approached, all the member countries were party to it. It was decided in the WHO Council that we will now approve vaccines that have been developed against COVID only. That was only for COVID at that time, as emergency user approval. That means all you need to show is the evidence of a vaccine in an animal that this virus has been neutralized. All that we need to do was that. Because human trials may be sparsely done, at very AstraZeneca would have done, or one or two of them would have done, but not all of them. Pfizer tried it, and so many other companies did it. So what I was trying to tell you is vaccine research is scaled up, but at the same time, it's fast forward. There is a problem there. I'm not saying it's the safest thing to do, but then we have no other options. You want to neutralize an antigen in your body that's gotten inside already, this is the only option. You have to go for it. Today there's a lot of reviews in your journals, your newspapers, everywhere there is. COVID vaccine does this, COVID vaccine that. But at that time, nobody even was saying anything. Why? Because you survived a pandemic. Delta virus hit us, we never knew what to do. And people all queued up. Until then, no vaccine, no nothing, nobody wanted, even there was something in the press, there's something called infodemic. A lot of nonsense information. Nonsense, worthless, stupid information gets into the public and media where there is no exact channel followed for maybe a governmental channel or whichever is an authentic channel which can tell the information, pass on the information to the public. So people all started on the social media about a lot of things, about infodemics, don't do that, don't do this, so many things. So infodemics is one thing that you need to be careful about. So I'm talking about research, largely would be an EUA, but the risks involved I've already told you. Lastly is the global coordination. Now, I have a lot of slides to show you, but I'm just finishing it up because I've just taken one slide, each for all of these. But then, since there was paucity of time, I'm just, just changing the slides now. Okay, the international coordination, the global coordination and the policy frameworks. This is very important. The reason why I'm saying it is, India is collaborating at different levels. We have Quad countries. Quad is the 4 nations you already know, US, Japan, Australia and us. We have a Quad country and they are focused on Indo-Pacific. Now, India is growing as a power now, a global power. Now, we need to integrate all our resources. We need to come up with international cooperations everywhere. We need to show that India is a country which has come up, grown up, and now we're giving it to the world. So with that in mind, there are a lot of cooperations going on in Quad countries. We have ASEAN, where we are a member, we're not a permanent member, we're like an observership membership is there. A lot of this thing is going on. And South-South cooperation, which is there already, which was already mentioned earlier. These things are already happening. So Niti Aayog is the think tank of the Government of India, and you can go back to the website, niti.gov.in, and there you can get this framework for pandemic preparedness entirely yours. The entire around about, I think it's about 50, 60 pages of it, which starts from governance, legislation, and then whatever which I have detailed here. Next slide, please. So here in surveillance that you already know, that's about early detection, monitoring. This is what we do, and then you have this, the new thing that has come up is genomic surveillance. We had disease surveillance, that was long back there. But then now it's genomic surveillance. Like every country now shares on a common database the variants, the strains, the genomic patterns which are there is straight away shared on the system, and we get access to it. Now when that is there with this system, when it comes into being, as of now, there are still countries which are not into it so far, so that will soon happen. The system is known as PABS, which is basically a pathogen access data system, where everyone posts their variants, the genomic variants which are there, which are coming up in different diseases, is shared in a common platform and you get access to it. So now you know that country, when you see a genomic variant here, you can relate very fast to another, the similar variant happening in another country. So you can see now how fast the responses are going to be. So WHO now has started off something called, there was already there, international health regulations. This spells out all kinds of rules for international travel for everybody. About vaccination, for international travel, you can see. So many of you would have gone abroad and your visits and things like that. So you would have taken vaccinations. These are the IHR that is the international health regulations which are mandatory for all countries now, as decided by the WHO. Now these, every port of entry or port of exit, wherever you go, like for example, we have eliminated polio, is polio free since 2014. It's about 10, 11 years now. Maternal and neonatal tetanus is out, though we have a transmission of less than 1%, but still, it's eliminated. Now, when we have so many those diseases which are eliminated, but our watch is, there's still watch, because Afghanistan, Pakistan, and these neighboring countries still have these viruses transmitting their diseases. So any spillover could happen into India. We are now free for 11 years now. So we are still vaccinating children and adults alike, and those adults who are coming back from countries where polio endemic countries, those who are polio endemic countries, we are doing it. So this is what I want to say. My times is up. I think I have a lot to talk about this, but I don't want to bore you, because I think if the bell comes up now, it will be for the lunch bell, I guess, and not for me. So I guess I will just run to, can you just show me one more slide, please? Maybe. So this is a scenario which we are actually wanting to. If you see an international surveillance network, and I'm talking about the ideal pandemic preparedness which the globe should have. One, an international surveillance network. Once if it happens, data connected to each other, it's so easy that sitting in an advanced virology institute, you can easily see where exactly the problem is and what work should you embark on immediately. And research, like I already said. Can you go to another slide, please? There's one on COVID. These are just, you can skip this, please. Yeah, this one. This is very important. This is what the timeline on the right, 100 days mission timeline, is what we have for our country now. That is, I'm comparing that timeline, which we are actually having it for the preparedness, with what exactly was happening when COVID actually hit us. You see, when on 30th January, WHO declares a public health emergency of international concern. This actually shows that the disease is crossing or is sensitive enough to cross international borders, and all countries must keep a watch on this particular disease. So once if that PHEIC is declared, then all countries start rolling. So from day one, the date it is declared by the WHO, all countries starts to work within that 100 days. Then as is listed there, what do they start on working? So in COVID, if you see, just run it down and you can see this particular COVID vaccine, it came around 200 days, 300 days maybe. That is how the vaccine development has actually started. When we had 64 days, a real PCR test started off. And then we had cases being detected with these diagnostic kits. And then we had the COVAX, is basically a coalition for among countries and other donor partner organizations. And then therapeutic protocols were laid down for COVID, and then the vaccination started. So we can see that these kind of things have evolved only nearly about 300 days later. So that is time enough lost, for loss of lives lost, and not because of our ignorance, but just because we had not prepared at all. So all I can say is, can you just go to the last one, please? Yeah, this is, okay, investment. Investment, again, is very, very important. You can say that, chalo, you do this, you do that, you develop your research and vaccine and whatever. But if you don't have money, no budgeting done for it, you just sitting dogo. You're doing nothing. You can't do anything because money is a requirement. Now, India is now, the GDP investment is 1.9% of our GDP is now investing, but you compare it with US, Germany, and even a country like Nigeria, where the percentage is 2.6 of the GDP goes to health. Germany, USA, imagine what are these? India is just about standing at 1.9. Our economy is right now at $4 trillion US dollars, 4 trillion, and uska 2%. You can imagine what is the money that we are spending now. Yeah, can you skip it, please? This is okay, I'll skip that. Yeah, community engagement, a very important one, but I have to, just a passing mention that these things I already mentioned to you, that knowledge, communication is very, very important. Please don't see it lightly. This is very serious because this is the only point of contact with the public you have. And if you're in the public health domain, you have all this to do. Go to each and every village, to those people where they're the most risky, they are at risk of disease. Can you just, this is already described, I'm not going to that. COVID studies again, you can just read it down because this was an issue. to failures. Yes, and can you? So this is the roadmap for strengthening. This is just about what we need to do, whatever the pandemic drills are, the stockpiling of all the diagnostic kits and the PPEs and the personal protection equipment, the BRICS, G20, Quad, all of which we are concerned now. We're working on it together for pandemic preparedness. These are the international, which I was talking to you about, globally what is happening now and what is India trying to plan and do along with this. Can you just look that? So this is what it is, like I was saying, this is the future pandemic preparedness and emergency response, a framework for action. It's available on the website for students who are PhD, scholars, everyone. You should go through this because this gives you everything about legislation, governance, and what is to be done. Right. Next. So in short, this is what it is. Nobody is safe till everybody is safe. So this one is very important. Keep in mind when you are in a public health domain. And that's it. The last slide, maybe? Yeah, that's it. Thank you very much. Right. Sorry, I've just taken 5 minutes. Yeah.
Thank you, sir. We wish that you could go on and on like that because it was such an enlightening and enriching session on pandemic preparedness.
Thank you, sir.
Now I think we can take a couple of questions.
Yeah, please. I mean, that will be better than just going blah, 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 you know, like you can go for hours, but it doesn't look nice.
Sir, one query, sir. You talked about risk communication, and we need to convey to the public. No,
yes.
Can we use fear as a part of this risk communication? WHO usually says that no, we should not use fear as a as part of risk communication. We should not make the people that much afraid of the disease severity and all. What is your take on that?
See, we are just following what the WHO has told us. I mean, there is nothing like India developing our own. Basically, this is a international decision to make. 194 member countries have signed and ratified that agreement. The pandemic accord is now signed, and it is like India is part of it, and we have to follow it. So, what is at that point of time, the technical committee decides. We have something called SAGE. This is a strategic expert group of on this, whatever that is, emergencies, that is, experts, strategic advisory group of experts. Strategic advisory group of experts, and they are the ones who are actually the technical team who decide on what exactly is to be done. So we follow strictly by what SAGE lays it down. And yeah, we tailor it a little bit for our country. Sometimes we might have to do, little tweaking there, but we generally follow that pandemic accord for what it is.
Yes, sir.
Yes.
So I think one major component you may be expected to speak, but you may because of time. That is equity issues.
Yes.
Because when you are looking at pandemics, it may emerge in some of the backward communities, maybe tribes.
Yeah.
Even in COVID-19, we see that the slums and maybe coastal areas are becoming affected. So that is a very important component, I think, to build a resilience against rapidly spreading infection.
Absolutely, sir. I understand. This is a very important, that he has highlighted, extremely important. The reason why I'm trying to say is equitable access. I was just focusing on the global part of things. But if you see the particular requirements in every section of the society, every category of the society, it's not socio-economic or nothing like it. Vaccines, for example, or treatments, for example, must be given across the board equally to everybody. And deserving, not deserving, nothing of that, no categories per se. And Government of India follows that definitely, but word for word. Definitely, literally follows that. But the problems are that the access to certain, needs to be a political will also. Now, when you see that advocacy is done to certain hard-to-reach areas, we need a political support also. Like, for example, my own personal experience. When I go to promote vaccination in tribal areas, especially those under the universal immunization program which I'm working, so we find most of them telling us, please don't come here, we don't want your stuff. Simple, whatever the local lingo is, the elder, village elder comes and says, no, 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 you are spoiling us. All these things should not go into us. We'll all die. Now, this kind of communication and behavior change is a huge task for us. We are trying every measure, every intervention to get to the last mile, to get to each and every one who is the underserved areas in our society. We already know that. Now we have advanced systems in data systems to even track all these underserved areas. There's something portal you would have read about it. It's called the UWIN. Now this is only for immunization, but now it's going to be taken out by the Niti Aayog. Now is trying to integrate a lot of dashboards into that, so that we have one comprehensive dashboard who can sit in a state level and to see what is the percentage of in which geographic area the vaccine or health services delivery has not occurred or is less. So we have that in mind, sir, and definitely we're working on it. And there are issues on it, but I do not want to get into the parts of it.
Thank you, Dr. Shinjo, for that excellent presentation. I have one thing to add. Thank you that you are bringing in that the draft for that pandemic preparedness for the country. And I'm requesting all of you to go through that and all.
Yes.
Actually, one thing that I have noticed in that document is how to bring in public trust.
Yes.
Although there are a lot of things on communication and how to build public trust, actually that is to be expanded a bit. If you are looking at the experience of Kerala, like in Kerala, after every evening, the chief minister himself used to brief the public about how many cases, which are all the cases, how many beds we have at various levels, actually, tertiary care level or at the primary care level and primary. I mean, what level, how many beds we have, ICU beds we have, what are our capability to handle the patient load and all. That kind of a daily news bulletin given by the chief minister himself. Actually, that built in trust. And as you were mentioning about, Dr. Anish also mentioned about the equity issues and all, tribal areas. And there are many other corners where we have to have specialized activities to build that trust and all. So in the document, I have written to that, actually, we have pointed out that in the document, I know that you are in the drafting group, actually, if you can spend some more time on that building trust component, that will be fine.
Definitely.
Thank you for the excellence.
Thank you, sir. Thank you. Point noted. We'll try and incorporate all those.
Thank you, Dr. Shinjo, for the enlightening presentation.
Thank you very much.
I now request Dr. Biju Soman to hand over a memento to Dr. Shinjo as a token of our appreciation. So thank you to all our speakers for their insightful presentations, and to our moderators, Dr. Biju Soman and Dr. Aravind R, for moderating the session. With that, we draw session 2 to a close.
I request everybody to assemble for lunch near the registration desk. I know the session has got a little bit delayed, so I request all of you to have a quick lunch and be back at 2:15 so that we can start our podium presentations. Please have a quick lunch and come back. We are going to have an excellent podium presentations. Please don't miss that. So see you back at 2:15 p.m. Selected podium presentation by young investigators. I hope the podium presenters are already at the venue. The participants have 7 minutes time for their presentation and an additional 3-minute time for discussion. A single bell will be given after 6 minutes. After that, you get 1 more minute to continue. You are requested to end the presentation by the second bell and wait for the QA session. Once again, The presenters will be given a total time of 7 minutes for their presentations. After 6 minutes, there will be a single bell which is a call to you, and you have 1 more minute to go, and at the second bell, the double bell, you have to stop the presentation and wait for the QA session. We start the podium presentations. First to present, Ashwati Shashikumar, OP1. Ashwati Shashikumar, OP1.
Good afternoon, everyone. I'm Ashwati Shashikumar, PhD scholar from Viral Research and Diagnosis Center, Inter-University Center for Biomedical Research, MG University. I'm honored here to present our recent study, which is published in Scientific Reports Nature, titled Computationally Designed Multi-Epitope Vaccine Construct Targeting the SARS-CoV-2 Spike Protein, which elicits robust immune response in silico. This study potentially emphasized the in silico designed vaccine constructs with computing the viral threats. As we know, COVID-19, which is the the SARS-CoV-2, which is the causative agent of COVID-19, and which continue to pose a global health challenge. So the spike protein, which is crucial for the virus entry, is considered as the primary vaccine target. So here we mainly emphasize on this virus because it has a rapid evolutions and viral emergence which need a next generation sequence strategies which have a long-term immune efficacy. So as a result, a lot of vaccine strategies are emerging. There's a gap is remaining. There is a lack in comprehensive integration of both B cell and T cell responses, and also concerns regarding antibody-dependent enhancement and poor cross-population coverage area is also to be addressed. So our objective is to minimize this lag by integrating a vaccine construct with including both the B cell and T cell responses. For that, our methodology we used are completely in silico methods. First, we retrieve sequences, and then we predicted epitope prediction and screening its antigenicity, allergicity, and toxicity. And then we molecular dock it, dynamic stimulation, immune stimulation, codon optimization, or cloning in silico. And laterally, we want to know the experimental validation. So coming to the B cell prediction, here we use a multi-tool concept method to increase the reliability of the epitope. For B cell epitope prediction, here we know there are two types of B cells, linear and discontinuous. For linear epitope prediction, we are use IEDB, ABC-Pred and B-Pred tools. And for discontinuous epitope, we use Discotope, ELIPRO and SEPA. From the result, we get that we identified 18 conserved linear and 6 discontinuous epitope with surface exposure. So of this two, both type of this, 50 of them are overlapping, which implies high immunogenic potential. Then these structures are structurally exposed on the SARS-CoV-2 spike protein structure, which is PDB6S E1, provide the top candidates are BP E1 to E4. Then we predicted the T cell epitope prediction. Here we are predicted both cytotoxic T lymphocyte and helper T lymphocyte, and we get the result that we selected 9 cytotoxic T lymphocytes and 34 predicted, from 34 predicted HTL, we shortlist 19 based on the IC50 value. Besides of this prediction, we also check whether this T cell epitope have the ability to induce the cytokines. So most of these epitope can induce interleukin 4, interleukin 10 and interferon gamma. So we mainly focused on MHC1 for the docking studies because MHC1 which induces the cytotoxic T lymphocyte and the binding group of MHC1 is more defined. So we considered it's provide more reliability. So here out of the, we know 9 cytotoxicity episodes were predicted. Of this, 5 shows more prediction scores. Of this, T cell epitope 3 and T cell epitope 4 show strong MSC1 binding affinity. And the key role of TEP3, that means T cell epitope 3 shows that its position near the S1 S2 cleavage site, which is very super antigenic position. So this is a docking study. Here we already showed the figures of the MSC1 docking with our epitope, and there is also the predictor score and the binding of by intermolecular interactions of the epitopes. So next our strategy is a subunit consideration. For the subunit production, we integrate both the CTL epitopes, HTL epitopes, and also the B cell epitopes. And with integrating, the strategy is that the optimal immunogenicity and coverage, we selected S1 to S4 epitopes. And this epitope show that they integrate both the B cell and T cell and responses. Okay. The main peculiarity of our MEVC, that is multi-epitope vaccine cancer, is that it produces both the T cell response and B cell responses. These are our subunit and their key features. And this subunit we are checked with the population coverage show that it has 90.74% coverage. That means it has 90% coverage over the world population. This is our multi-epitope vaccine, final vaccine construct. Here we use human beta defensin, which is a natural antimicrobial peptide 2 and 3 as our adjuvant, which is kept on the N and C terminal, which is linked by the linkers EAAK, and we have 4 subunits S1, S2, S3 and F4, which are linked together by the linker GPGPG. And these are the immunogenicity, antigenicity and allergicity of our multi-epitope vaccine construct, which show all the positive things, which they are non-allergic, antigenic, and they have non-toxicity. And when we check the Ramachandran plot where the prediction and validation of design vaccine construct, they show that 90% of this belong to allowed region. This is the MVK the binding with the T cell receptor, toll-like receptors. It's also showing binding immunity. And we also applied the codon optimization using the E. coli subunits. This is our immune stimulation response. It also give positive results. So our discussion is that we predicted the multi-epitope vaccine construct which consists of both B cell and T cell responses. The further validation is we want a experimental validation, which took step we take forward. And this study for that, this is immunoinformatic enabled rapid and rational vaccine design for the next generation vaccine designs. And this is a bibliography I used. And I also thankful my mentors, Deepthi ma'am, Mohan sir and Usha ma'am, and also the funding agency, ICMR and MT University. Thank you.
The floor is now open for a 3-minute QA session.
So, Ashwati, how will you validate this experimentally?
I want to forward, we are not into it, but we want, because we already inserted our construct onto the E. coli, so it provide high expression in silico. So we want to check it for experimental validation.
So your expertise is bioinformatics, or you can also do wet lab work?
Yeah, I'm from microbiology backfield. This is my MSc dissertation topic, and I'm not from the field of bioinformatics. I studied it for my dissertation. I want to do the wet lab seriously, but now I don't have that.
So do you have any speculation that this will be better than the existing vaccines?
Yeah, because most of the subunit vaccines or derived now the peptide vaccines are only provide T cell responses. Here we also used B cells, which we have memory B cells, so which will be reduces the antibody dependent enhancement, and we can use this. Memory cells will be formed. Then exposure, re-exposure will be more quick. The immune response will be more quick and not at all serious. Will be emerging like that.
Are circulating in different part of the world. So we have to move to something like influenza vaccine, like all these vaccine epitopes are collated and combined together in a single vaccine. That may be having a more commercially used. So can be your platform has got that kind of an opportunity, so that for a future vaccine, suppose COVID-19 is becoming endemic, different kinds of strains are circulating in different part, and there are seasonal variation. If the world is emerging to that kind of a situation, we have an answer to a vaccine kind of an answer to this problem.
Yes, sir. By using this method, we can in silico, bioinformatically, we can predict the conserved region, conserved epitopes of almost all the emerging or new emerging viruses. So I think this method is. By using this method, we can construct a vaccine multi-epitope like this multi-epitope vaccine construct for any viruses, but the real thing was the experimental validation. I think so.
Okay, Ashwati, thank you. We move to the next presenter, Jishnu Narayanan, OP number 13. From Center for Research in Emerging Tropical Diseases, University of Calicut. Judges, please note, OP 13, Jishnu Narayanan.
Hi, I'm myself Jishnu Narayanan. Good afternoon to all. So I'm a PhD scholar at Calicut University, and my passion is disease ecology. So today we are talking about a slightly different disease from Nipah. It's Kaisner forest disease. So you may be familiar. Kaisner forest disease is a hemorrhagic fever that is tick-borne, and it spreads primarily from animals to humans via ticks. So this is a cycle of Kaisner forest disease, and it seems to be complete. Like we have a good understanding of how this disease comes from ticks, it goes to an animal, it comes to humans, and humans in this forest habitats get this disease. So I had some questions in this particular picture. So this is a commonly used picture. It is written in literature. Always the overall picture shown in any literature will be this. So I found this picture a little incomplete, so that's where I started my questions. So my first question was the name of the tick. So as I read through tick literature, I found that they mentioned the vector as Haemophilus spinigera, but I found that there are more than one vector, but it is not widely used in literature. Also there are multiple hosts, so they have portrayed monkeys and rodents, but there are multiple hosts. And also how which all ticks can transmit the disease to which all animals, and how the ticks gets the disease or the virus. And these are questions a little vague in literature. So I tried to address these questions. So my questions were, is Haemophilus spinningira the only vector? Definitely not, there are more. So are monkeys and small mammals the only ones to carry the virus? So which all of these animals do get bitten by ticks? And also shouldn't be worried about animals dispersing this virus, because animals can be host, animal can also carry the ticks. Also I had the question of, see, even as a parasite, each tick will have a niche. So if there are multiple vectors, each tick will have a different set of host which it will bite. So my question was, which all are these animals for each of the tick? So I believe I can give a better clarity to the disease ecology picture of Kaisnophorus disease. So I did a literature review and searched through databases, and I found that there are multiple, actually 9 confirmed vectors of Kaisnophorus disease and 9 potential vectors. That means they have only viral isolations or only experimental transmissions. So in that too, the 3 were soft ticks. So ticks are of 2 types, hard ticks and soft ticks. Hard ticks actually mold, fall down, and they only take a blood meal once in one life stage. But soft ticks can, like mosquitoes, it can bite multiple times. So totally different ecology of these vectors. Also, are small mammals and monkeys the only ones to carry the virus? Definitely not. When you remember the last picture where only rodents and primates were there, you can see in this picture that there are confirmed hosts and there are susceptible hosts. So I had defined confirmed hosts as those from which from wild they have viral isolations, or susceptible as which has antibodies or have capacity to transmit this virus. So you can see that among that comes birds, and also among that comes bats, which were totally ignored. So what I did is I clustered this host into different categories. These categories were carrier or susceptible small mammals, domestic animals, humans, birds, other mammals, other wild mammals, and also wild primates. So I grouped them in such a way that each form a ecotype. So how humans can contact to each of these ecotypes. So obviously Haemophilus spinningira, widely mentioned in literature, came out as a very generalist. It was biting left and right, every host. But as I move through each of these ticks, each tick had actually a very specialization and a very specific niche. So which means that some of these doesn't bite humans, some of these doesn't bite primates, but they are vectors. So which points to the fact that, okay, if they are vectors without biting a primate and a human, they have a very specific role in this disease ecology. So, that's the whole idea. So you can see one that doesn't bite small mammals. There is one that doesn't bite birds. So I plotted this polar charts for each of these vectors and potential vectors. So it turned out very interesting that each of these ticks have a very unique niche. And also, shouldn't we be worried about animals that disperse these viral ticks? I would say yes, because each of these ticks had a feeding period that was entirely different, and some were able to latch on to these hosts for a long time, which means it can be spread to longer distances. Also, the location of where KFD is reported, it is widely reported in the red patches, that is Western Ghats, but there are also isolated records all along India, and there is a record, very good number of zero prevalence in Andaman and Nicobar Islands. So that made me again curious. What all could be the animals present in Andaman and Nicobar that could be host, that could be vectors? Again, bats popped up, birds popped up. So it was very interesting. So this is one area where I would recommend research to be happening in Andaman and Nicobar. I would recommend to study bats, because bats actually carry soft ticks, which can do multiple biting, and they are actually more specific towards only bats. So that is one thing. Also, we don't have life history of all the vectorial ticks. We only have about 10 out of 18 vectorial ticks we know about their life history, how long they take to molt, how long their eggs will latch on, and so on. So viremia capacity of host, viral carrying capacity of ticks, a lot of research should happen. So that's all. So I was trying to answer the bigger picture of Kaisnophorus disease, how each vector, each host could have a unique role, can a dispersion happen, and so on. So this is my team, our team. We were generously funded by Government of India and Government of Kerala. And thank you. That's all.
The floor is now open for a Q&A session for 3 minutes.
Sorry for asking questions again and again. You mentioned that heart tick will feed once.
Yeah.
I don't think so, because it will feed once before one metamorphosis.
Exactly, yeah.
So the larvae can feed once,
Yeah.
then the lymph will feed, then the adult will feed.
Yeah, I mean one feeding per life stage.
Yeah.
Okay.
So some of these ticks may be 3-host ticks, just like Haemophilus spinifera.
Yeah.
Some of them may be 2-host.
Yeah.
So those mechanisms are also very important in the ecology. In
Yes.
which phase it is transmitting, what kind of animal is attracted by each phase and all other things. That is
Yeah.
one point.
Yeah.
Second one is regarding the temporality. So the climate, if you just look at the KFD season, it will start maybe with October or November and it will end up by the summer.
Yes.
So summer, maybe some people argue that because of forest fire, the tick population will be just killed or something like that. So many
Yeah.
things are there. So those kinds of temporality and other things may also be bringing to study the ecology completely. That is what I think.
Yeah, definitely. Thank you for the suggestion.
Okay, Jishnu, good presentation. You were using secondary data, literature review for this.
Yes, sir.
You were trying to map. But you see, these biologic systems are not hard and fast. No, actually,
Yes.
it will keep on changing. No.
Yeah.
Now you are seeing the species, the profile can change tomorrow.
Yes, sir.
And the climatic actually, if you are doing such a thing, actually, why don't you take the climatic data also and try to see if there is any correlation between this species will prefer this and this vector-host relationship in this climatic conditions and all.
Yes, sir. Actually,
otherwise it's just an exercise which might, as a researcher, you are done some research, but it will not have that lasting effect. No.
Yes, sir. So this is one of my PhD objectives. So I am trying to do a stacked species distribution model. So what it will do is it will take a species distribution model for each of these vectorial ticks and the KFD locations, and we will stack this all together and we'll get a very fine filter where we can expect this disease in the future, where we can expect in the coming years in different pathways. If we do follow climatic resolutions, if we do not follow climatic resolutions. So I'm actually working on such a model.
Okay, good luck.
Thank you.
So just an extension of that. So are you looking at association of virus circulation when you are doing this?
I am not working with live viruses.
Yeah, but in your model, can you fit like incidences or outbreak
Yes,
data?
yes, I can.
You can do that?
Yes, sir.
Okay.
Thank you very much.
Thank you, Jishnu. Next presenter, Kulesh Bandari from Sido Kanhu Murmu University, Jharkhand. Judges, please note, OP number 2, Kulesh Bandari.
Good afternoon, everyone. I am Kulesh Bhandari from Sido Kanhu Murmu University, Dumka, Jharkhand. Today I will be sharing a ground observations from the tribal upland of Santhal Pargana Kozhikode, where humans, livestock and langurs quietly intersect, often overlooked in India's genetic preparedness stories. The silent age of spillover, the forest margin of Santhal Pargana are alive with daily human life, but also quietly brewing conditions that we rarely discuss. Subtle overlaps of people, livestock, and primates that we could set the next genetic surprises. And the objectives rooted in field reality. We wanted to do more than just map animals. We aim to document exact point of overlap, to listen to what villagers knew for decades, and bring these small tribal stories into the larger One Health dialogue. And mapping the living landscape. This is Kozhikode in our GPS overlaps. Dense salt canopies broken by scattered field and village paths. Every boundary is here porous, letting people, cattle, and langurs share the same soil almost daily. The methods embedded in community memory. Our work combined simple forest walk with deep community listening. It was often the villagers elder who pointed us to tree, langurs, always roast or trials that livestock routinely take under these canopies. Livelihood threats that wave risks. In Kozhikode forest are not fenced forests, they are lived landscape. Peoples enter for daily fuel world or grazing and cutting face trials through the zones that langurs also quietly frequent stitching routes for possible pathogen exchange. Where langurs and livestock meet. These roost trees becomes critical microsites. By day cattle rest under the same branches where langurs sleep at night. It almost textbook ecology of multi-species congregations, a perfect unnoticed spillover stage zoonotic. A visual chronicle of overlaps. This snapshot capture the story better than words. Bent roast, villagers gathering wood, langurs near village edges. Together they form a silent tapestry of overlap, rarely caught in health maps. The border message for One Health, this is not just about Kozhikode. It's a lent into thousands of such tribal uplands across India. If we miss them, we risk being blindsided by outbreaks brewing where surveillance rarely reaches. Recommendation rooted in ground truth. What we need are micro-level participatory models, educating communities, monitoring livestock, health on the ground, and formally including places like Santhal Pragna into India's One Health plans. And the concluding thoughts. Sometimes the quietest forest is hold the biggest One Health lessons. By respecting local voices and documenting these subtle overlaps, we stand a better chance at truly preventing the next zoonotic leap. And the acknowledgement, I am deeply grateful to thanks to the villagers of Kozhikode for sharing their dairy worlds with us, and to the organizers here for giving this small tribal landscape a place on the global zoonotic stage. And thank you for listening, and I look forward to your thoughts.
The floor is open for discussion.
Hi, Kulesh. Just a small question. So, no. Yeah. So, are there any reports of outbreaks in this area in the last 10 years, 20 years? Yes. What was that about?
During our field projects, there was no structured life ecological lineage of the Santhal Pragna villages. We aim to document exact points of overlap where people meet langurs and quite of zoonotic disease.
So was there any report of any zoonotic disease or a spillover in this area? So how is this different from any other, area where there is always a interface between the urbanization and the forest?
There was a small tribal village, sir. They are living landscape of Santhal Pragna near village edges. There was no any structured and any wellness.
Okay, so you are assuming that this may become a spot for
Mixed zoonotic
next
stage.
zoonotic spillover or something.
Okay, sir. Thank you, sir.
Okay, Kulesh, actually, so how big was the area wise?
There was a lagbhag 12 kilometers.
12 square kilometer.
Yes, sir.
And what was the population there?
Population there was a 10 villages, sir. There was 10 villages.
And you use GPS machine to take the
Yes, sir.
geocoordinates.
I use GPS machine, Google Earth,
Are
and
you aware of
GMapper.
the DigiPin initiative of Government of India? The Postal Department has come up with the DigiPin. No, this GPS
Yes, sir.
locations are actually it's a private information.
Yes, sir.
So you should be very careful. And what sort of ethical permission you got?
Yes, sir. I permission Forest Department of Kozhikode.
Department of?
Kozhikode, Santhal Pragna, Jharkhand.
Okay. And you should be very careful. That's why I am suggesting that next time when you are doing such a mapping,
Okay,
please use DigiPin.
DigiPin.
Where any place, whether in rural area, urban area, forest area, we can get a 8-digit number.
Yes, sir.
As in the USA, actually they have the zip code, and this code will give us a area with a resolution of 30 into 30 meters. So that'll be good enough for many of this work and all.
Okay, sir.
Don't go for the exact GPS location, but we can use this DigiPin.
Okay, sir.
Thank you.
Thank you.
Thank you, Kulesh. Next presenter, Anna Kurian, OP number 3. Judges, please note, Anna Kurian, OP number 3, from Amrita Institute of Medical Sciences and Research Center.
Good afternoon. I'm speaking on highly sensitive qPCR-based detection of Angiostrongyllosis cantonensis, eosinophilic meningitis. Human angiostrongylliasis or neuroangiostrongylliasis, it is caused by Angiostrongylus cantonensis. It is commonly called as rat lung worm. It is a nematode. The first human case was reported from Taiwan in 1945. So the definitive hosts are rats and rodents. Then intermediate hosts are the gastropods or mollusk, which includes a giant African snail or slugs. Paratenic host includes crustaceans like crabs, snails, shrimps, shrimps or prawns, amphibians, and reptiles like monitor lizards. Humans are actually accidental hosts, and they get the infection by consumption of contaminated food containing the third stage larvae. So once the third stage larvae enters our body, it reaches the CNS because it is neurotropic. It causes eosinophilic meningitis and ocular angiostrongylliasis. The incubation period is almost 1 week to 1 month. It can exceed more than that. It leads to severe inflammations to the worm, leading to cranial nerve defects, ataxia, radiculitis, encephalitis, coma, and even death. If you look into the epidemiology, the most common hotspots are the Southeast Asian part of the world and also Hawaii. The global incidence is considered to be 2 per 1 lakh individuals. The most of the cases were diagnosed clinically. We need to take an accurate clinical history. So the clinical history should include whether the patient had any consumption of poorly cooked foods, including the paratenic hosts, the crustaceans or monitor lizards, or consumption of any raw vegetables which are contaminated by the slime of slugs or snails, or if there is any snail or slug infestation in and around the house. In all the cases, there was eosinophilia more than 10%. Brain imaging with CT and MRI, it is non-specific and not pathognomic, but it may aid the diagnosis. Laboratory diagnosis, it is by the PCR, that is ACAN R3990Q PCR based upon repetitive sequences for angiostrongylosis cantonensis. So this was developed by NIH Bethesda, and it has better analytical sensitivity than the ITS1 based PCR. So we are moving on to the first case. So this first case was a 10-year-old girl from Lakshadweep Island. She had intermittent fever, headache, body pain, decreased appetite for the past month. There was no risk factors. She had signs of meningeal irritation. MRI was found to be normal, but blood and CSF showed eosinophilia. PCR came as positive, and she was started on steroids and albendazole. This is a second case, a 15-year-old boy from Kochi. He had also similar complaints. He had neck stiffness, but no other CNS symptoms were seen. The risk factor was that there was snail infestation around his house. MRI was found to be normal, and CSF showed eosinophilia. Blood also showed eosinophilia. PCR was positive, and he also was started on steroid and albendazole. This is the third case, that is a 20-year-old lady from Udupi, Karnataka, similar symptoms. There was no significant history except that she had traveled to Kerala 15 days prior to the onset of her symptoms. There were no other risk factors. The fundus examination revealed papilledema. On examination, there was neck stiffness. MRI was normal. Blood and CSF, eosinophilia was there. PCR came as positive. She was started on steroids. Case 4 is a 65-year-old lady from Thrissur, Kerala. She also had similar symptoms, back pain, headache, vomiting. On examination, she had no papilledema or signs of meningeal irritation. MRI was found to be normal. There was no risk factor. Blood and CSF showed eosinophilia. PCR came as positive. She was started with steroids and albendazole. Fifth case, 1-year-old girl from Alappuzha. High-grade fever for 5 days, irritability, inadequate oral intake, and single episode of vomiting. On examination, there were signs of meningeal irritation. The risk factor, parents reported that the child was playing in mud, which was infested with the snail. Blood and CSF showed eosinophilia. She was started on empirical treatment with antibiotics and steroid. Once the PCR came as positive, the antibiotics were stopped and steroid was continued. This is a sixth case, a 11-month-old boy from Angamali, Ernakulam. He presented with excess irritability, which was worsening on sitting and standing, decreased on lying down. Examination showed a bulging anterior fontanella. The blood showed leukocytosis with eosinophilia. CSF was cloudy, and we could detect a live motile worm. CSF showed eosinophilia. The PCR was done with both CSF and the worm, and it came as positive. So this was the So this was a live motile worm. വേറെ ലാപ്പ് നോക്കണോ? ആ വീഡിയോ പ്ലേ ചെയ്യാൻ പറഞ്ഞു രണ്ടും. It's not working, sir. monitor. One second, sir. It's not coming. It's not moving. Can you see the worm? It's in the middle of the. That's the worm. The slide is not moving. Next slide. Oh, okay. This is the worm. This is the worm that was detected. Again, PCR was positive with the worm as well as from the CSF, and the patient was started on steroids and albendazole. So this was the MRI picture of that same patient. It showed increased contrast in the left parietal region. This was the cross-section of histopathological examination of the worm. We can see smooth cuticle and also presence of prominent lateral cords. And this was the PCR image. We can see the elevation of the graph. So this is the 7th case. So 3 patients from the same family came positive. So two boys and a 39-year-old female, which was their paternal aunt. Only history was that they were bathing in the same swimming pool, and they had similar complaints. CSF and blood eosinophilia was found in both the boys, but not the aunt, because CSF lumbar puncture was done a few days after starting of the steroids, because she was on clopidogrel. So if you look at the Indian scenario, there are 44 cases reported till now, which is excluding these 7 cases. Out of that, 37 was eosinophilic meningitis. 2 had brain abscesses, 1 presented late and died, 5 had ocular symptoms. Only 4 cases out of these were found to be confirmed, 3 by PCR and 1 by immunoblot. All the confirmed 3 PCR cases were from Kerala. So out of the 44 cases, there were 30 cases reported from Kerala, most common from being the Kottayam, almost 44%, and the commonest risk factor was the presence of consumption of monitor lizard. All cases were recovered. So conclusion, gastropod intermediate host or the mollusk, that is the giant African snail, they are reservoir for Angiostrongylosis cantonensis, and they are very abundant in Kerala. It should be considered in patients with eosinophilic meningitis, and PCR, that ACAN R3990Q PCR, has excellent analytical activity. Treatment with steroids, with or without albendazole, have showed significant improvement on the patients. Timely diagnosis, increasing awareness of eosinophilic meningitis among clinicians, and engagement with the endemic communities and public health officials is required to manage and prevent this emerging zoonosis. So this was a collaboration study between Amrita and CMC Vellore, and we got the samples from Sri Chitra Thiruvananthapuram, Pushpagiri, and KMC Manipal. Thank you.
The floor is now open for discussion and QA.
No, well done. Good study, actually. So I was wondering, what was the mean time by which a definite diagnosis was made in these 6 cases?
The patients were started on empirical treatment with steroids itself, first of all, within 3 days or 4 days.
But within 3 days or 4 days of reporting to Amrita?
Yeah.
Or reporting to that any tertiary care hospital now?
Yeah, yeah.
But if you have access, actually, if you can do a care pathway analysis of all these 6 cases,
yes,
that'll be good. Actually, that from health system perspective, actually, that'll be very crucial information.
Okay, sir.
Okay, thank you.
So now, if you look at the incidence of this vis-a-vis the numbers that you already mentioned, so it appears to be pretty high in India.
Yeah.
Right? Is that really an anomaly, or we don't have enough data?
I think
this is last 1 year. What is the time period for all these cases?
From 2019, I think.
So this is last 5-6 years. Of
Yeah.
data. Okay.
It's just data from the published article. We don't know which have not been tested.
Okay.
Thank you, Anna.
Thank you.
We move on to the next podium presentation. OP number 9, Dr. Nipah TR from Department of Infectious Diseases, Government Medical College, Trivandrum. Judges, please note, OP number 9, Dr. Nipah TR.
Very good afternoon to everyone. Myself, Dr. Nipah, Assistant Professor in Government Medical College. So I am also going to talk about the same topic only, Angiostrongylosis cantonensis, but it will be an eye-opener because I am going to talk about the One Health approach, how we should prevent, how we should be more careful about the this one. So let me take you to a next slide, please. Can you please play the video? This is actually a case where the patient presented as an adult male presented with floaters headache as well as blurring of vision. You have to click on the video. Okay, it's okay. So this is regarding this patient presented to the OPD with a headache and blurring of vision. So what they could see was it's actually a nice worm which came out of the eye, and initially before they could, during the evaluation process, they could found out only there was multiple investigations were going on. They couldn't arrive at a proper diagnosis. So it could be, they were thinking about a filarial worm. Finally it came on to be after much evaluation through the microbiology department, came out to be a Angiostrongylosis cantonensis larvae. Next slide, please. This was actually a beautiful picture. Next slide. Yeah, so Angiostrongylosis, as she has already mentioned, it's a very, it has a very complex life cycle with a definitive, intermediate, and paratenic host. Paratenic host means it is a transport host. And because of this complex life cycle, it is very difficult to tackle with, and One Health approach, like animal husbandry, forest, as well as the human side also needed to be taken part in a collaborative way to control this infection. So coming to the next slide. The life cycle we already know, the definitive host is obviously the rat, where the worm lives in the lung, the pulmonary arteriole, where it matures, and the L1 larvae will be, after hatching, the L1 larvae will be the infective form to the intermediate host, which is the mollusk. So this will be fine if it has been happening in between both of them. But in between, if someone else comes, that is the accidental host like human, there comes the problem where in the accidental host it can go anywhere. So it is a parasite which has been shown common clinical manifestation where affecting eye as well as the brain. So eosinophilic meningitis and eye manifestations has been seen commonly. So this is the accidental host which we are more worried with. From 2006, more of cases of eosinophilic meningitis has been come into our notice in Kerala. And maximum cases has been reported from Kerala because we are the one who are identifying it. It is not because in other places it's not there. Next slide, please. So as already we have seen in many parts of India, as well as in many parts of Kerala, it is there. So India, in the world highlights it, whichever is seen as gray, doesn't mean that it is not there. It is going underreported because of unawareness. And whereas in India, maximum case reports are from the southern side. The first case was in Delhi, but the other cases was from the southern side, Karnataka, Kerala, and maximum case reports from Kerala. And past, from 2015, the cases has been in a long surge. There is a long surge of that. We will be discussing in the One Health approach. Next slide, please. So first definitive diagnosis was from Kottayam, obviously, and the maximum case reports also, it is ongoing, and they have done a wonderful job in by collaborating with the state by forming a public health initiative. So PCR diagnosis was possible from the Kottayam Medical College, as well as the presence of the parasite in the host was also, that is the mollusk was also possible. Coming to the next slide. What are the changing trends? Are we seeing multiple hotspots in Kerala? Are we seeing a changing trend in the pattern? Are we seeing so much of different climatic change also? We have seen the floods happened in 2018. Post-flood, there was a rapid change in the climate which caused increase in the surge of the snails. Before that, what was happening? In 1955 also snail was there. This African giant snail which came to Kerala, came to India. Especially in Palakkad area, it was more there. So what happened exactly? At that time, more of the adult cases of eosinophilic meningitis was being reported from 2000, 2006. Now that the ingestion of this monitor lizard, which was a parotenic host, was responsible for the increase in number of cases in the adult. Whereas now past floods and more awareness of that, monitor lizards, they are not being considered as a, because of increased awareness, they are not many people are taking it as a food item. But because of the floods, there have been more increase in the host habitat of this mollusk, this African giant snails. Because of that, contact with the host as well as increase in their secretions, which is present overall near the habitat of the human area, there it has an increase in the parasitic load has caused more of a eosinophilic meningitis cases in the state. So as you can see, these are the cases. So next, coming to the next slide. So this all we have already discussed. Coming to the next slide, please. Diagnosis part we already know. Coming to the next slide. So children were already, now for the past from 2015 onwards, maximum number of cases are seen in the children. It is because of contact with the giant snails. So that is present in the household area, which is causing even minute, if it is present, by touching the snail secretion also itself can cause increase in the number of, increase in the acquisition of infection. Next slide, please. So these are the 4 pillars of control in case of public health initiative. Next slide. So this is the mixture of tobacco leaf mixture which we are using in case of as a public health initiative. The last slide. The Kottayam in August 2022 has come up with this giant snail menace. Oru Padam, Oru Uch. That is the one initiative which they have taken up for controlling this menace by educating the farmers, by bringing up with solutions which they can, by this tobacco spraying over the snail, as well as increasing awareness among the household that snails should be eradicated, and so many people have come up with that. They are actually getting more, their plantains have been saved by using this initiative. So this is one of the better method if we go for a collaborative way, like how it can be removed. It has less predators, that is why the giant snail has been increased in the setting, as well as one more reason is because of the unawareness of many of the conditions where proper dumpage of the garbage is not happening, these snails will be increased in the locality. So 14 districts in Kerala, among that 13 of them have been infested with giant snails. Idukki, there have been much less reports, but other than that everywhere these snails are there. Who are presenting with the history of headache and mild blurring of vision may be having this eosinophilic meningitis. Diagnosis, since PCR has come up, it has been little more easier from 2020 onwards. But other than that, from 2015, it has been a problem. Yes, thank you.
The floor is now open for the discussion.
Hi. So nice presentation. Is this a problem only in this part of the country? How are they dealing with this in other parts of, in other countries, for example?
Sir, actually, in many countries like Europe, Africa and all, it is underreported, but there are cases in Europe as well. Its infestation with giant snails are there also, and in Thailand also. But there, they are more using this natural practices with something similar to sugar, jaggery and wheat. They have mentioned some local culinary practices they have avoided, but it is very difficult to control the local tribe population to avoid such things for eating giant snails. So that is still considered as an edible item now also. But here, because so making awareness among the public, they have been trying, but it has been more easily when the literacy is much more better. So in Kerala, it is still more applicable. So we can set an example to the whole world. So local practices only will help. One is this Pugaila Kashayam, which they are telling, the tobacco leaf preparation, copper sulfate and salt they are using. And other local practices like wheat, jaggery and salt, that can be used for in order to eradicate the, fully won't be possible, but people have been trying and they have shown that much reduction was there. Apart from that, gumboots has also been advised, not only from leptospirosis, gumboots should also be worn when the farmers will go for work.
So are rodents still relevant, or now this reservoir is independent of rodents?
No, it is definitive host is still rodents.
Okay.
So if rodent control is not actually possible. So if rodents along with this intermediate host and paratenic host are there, it is still a problem. Paratenic host, previously before 2015, monitor lizards were consumed. Even if it is against law, because it is a Schedule 1 animal under the wildlife reserve, still we were consuming the liver of these without even informing. So 7-year imprisonment is there if you possess that animal. So in spite that, people were consuming that. Now because of the awareness, because infection will happen, because eosinophilic meningitis can happen, now it has shifted. Now there is a changing trend from shifting from this paratenic host to the intermediate host, which can cause the infection. So earlier it was an infection of the adult. Now irrespective of adult or child, all of them are equally affected because the main intermediate host, that is the giant slug, even the slimy secretion itself can have maximum number of parasites. Yes, ma'am.
All these methods you suggested were to kill when you see that thing, right?
Yes,
but there is a method to attract that.
Yes, ma'am.
Some fruity things or something, then you put metaldehyde in that.
Yes, ma'am.
Keep it somewhere, anywhere, it will come and eat and die.
Yes, ma'am.
That is the best
that kind
thing.
of, yes, ma'am. Sure, ma'am.
Otherwise, you have to find out where it is. This one you can keep in the night somewhere with mixed with some fruits or beans leaves, papaya,
cabbage,
fruit.
Yeah.
Then you make a paste, put some metaldehyde inside and keep. Metaldehyde is the best solution. It will come and eat and die. It's very easy to kill than other snails.
Yeah, in this initiative in Kottayam, when they started, they had advised the farmers to do that also. But it seems for that cabbage, most of the farmers were not that attractive. It actually, it will look very small, but in your family, in your hospital, in your, where you live, their premises, these snails are there. 6 inches long snails with a cone-shaped shell. Those are giant African snails. And any of your family member is having the symptom, obviously go for and consult, and maybe you will find out patient is having eosinophilic meningitis. 7 days is the minimum incubation period to present, and maximum it can go till 28 or 1 month, 28 days or 1 month.
Thank you, Dr. Nipah. I request the next presenters to present a little bit faster because we are running short of time. May I call the next presenter, OP number 11, Devika SR from Rajiv Gandhi Center for Biotechnology. Judges, please note OP11, Devika SR.
Good afternoon all. I'm Devika Essa, PhD student working under the guidance of Dr. John B. Johnson at Rajiv Gandhi Center for Biotechnology. I'll be talking about my research which aims at understanding the interaction of human complement system with the rabies virus. So, complement system, being a part of innate immune system, is a major roadblock faced by all pathogens, including viruses. So, the interaction of this system with viruses is a very complex phenomenon and can have two major outcomes. Either the system can neutralize or eliminate the pathogen by various mechanisms like aggregation, opsonization, lysis, phagocytosis, etc., or the pathogen can escape the complement-mediated assault by virtue of various evasion strategies adopted by them in due course of evolution. This interaction of viruses with the system is also very unique and can vary even among members belonging to the same family. For example, as you can see, vesiculostomatitis virus and Chandipura virus, despite belonging to the same family of Rhabdoviridae, strikingly differ in their mechanism of complement-mediated neutralization. Therefore, considering the uniqueness of this interaction and rabies being a clinically relevant pathogen of this family, our research aims to decipher the nature and outcome of rabies virus interaction with the human complement system. To address, as we all know, rabies get transmitted upon the bite or scratch of an infected animal to a susceptible host. Upon entering into a host, the virus takes transneuronal route to reach its target organ, which is the central nervous system. Therefore, at this bite site, en route CNS and in CNS, the virus get exposed to various effectors of the immune system, including complement. So, a major question of our study was to see whether this interaction results in the activation of complement system, and if activation is C, we wanted to study which pathway of the complement is activated by rabies virus. To study this, we initially performed a virus concentration-dependent complement activation assay, wherein purified virus was incubated with normal human serum for 10 minutes, and the level of complement activation markers C3A, C4A generated were assessed using Western blot. We could observe that with increase in concentration of the purified virus, there was increase in the level of both C3A and C4A activation marker, suggesting that rabies virus activate the system in a concentration-dependent manner. A similar experiment performed using heat inactivated NHS served as a negative control, as complement is a heat labile component. In order to check whether the time of incubation with serum had a role in this process, we performed a time course activation assay wherein the purified virus was incubated with serum for varying time points ranging from 30 seconds till 5 minutes, and the level of activation markers were assessed. We could see that with increasing time of incubation with the serum, there was increase in the level of both C3A and C4A, suggesting that the virus activates the system in a time-dependent manner. Having seen that the virus rabies can activate complement in a concentration and time dependent manner, we then went ahead to check which pathway of the system is activated by this virus. To study this, we performed a series of activation assays using commercial sera, each of which is depleted of a particular complement protein. So the assay was performed by incubating gradient purified virus either with normal human serum or depleted serum, or the depleted serum which is reconstituted with a physiological concentration of the respective depleted protein, and the level of C3A generated was assessed. Initially, the assay was performed using a C4 depleted serum which have only alternative pathway intact. Both classical and lectin pathway of complement were impaired due to the absence of C4 protein. And as you can see, when virus was incubated with a C4 depleted serum, no activation was seen, but when C4 was reconstituted to the depleted serum, marked activation was observed, indicating that upon activation, system might proceed either through classical or lectin pathway. Further, to check the role of classical pathway, we performed this assay using C1q depleted serum, which had both lectin and alternative pathway intact, but classical pathway is impaired due to the absence of C1q. Here we observed that without C1q, virus failed to activate complement. However, when C1q was reconstituted, C3a could be observed, indicating that C1q is essential for complement to activate, C1q is essential for rabies virus to activate complement, and it proceeds via classical pathway. Further, we also checked to eliminate the role of alternative pathway, factor B depleted serum was utilized, and we observed that even in the absence of an intact alternative pathway, the activation virus was able to activate system, suggesting that alternative pathway do not contribute to this process. This was eventually confirmed by performing using a C1q factor D depleted serum, where we observed activation only when C1q was reconstituted system. When the serum did not have C1q or factor D, no activation was observed, indicating lectin pathway also do not contribute. Taken together, this suggests that rabies virus requires C1q for its activation, and upon activation, system proceeds via classical pathway. We also wanted to check whether the rabies virus infected cell could activate complement, and we could find that infected cell treated with serum had marked deposition of both C3 and C4 components when compared to uninfected cell treated with serum, suggesting that like purified virus, the infected cell could also activate complement. So in conclusion, the virus activates the complement system upon coming in contact with it, and the activation proceeds via the classical pathway. Thank you.
Over to the judges for the question and answer session.
So, Devika, is this specific to Chandipura virus, like different viruses use different pathway when you do it in vitro like this?
Yes, sir. Like there has been studies like this is a unique interaction. So the activation is more or less many pathogens, because the system is non-specific, and most of the pathogens actually activate the system. But the pathway it uses to activate it is different for each pathogen, and also the response to it, whether it resists the activation or whether it succumb to it, also like even within the members of same family, it is very different.
Because I would assume this would all be mediated by G protein. It's not really virus infection doing something, right? It is virus particle you incubate with serum and look for activation. So it's essentially whatever is there on the surface of the virus.
Yes, sir. The rabies, like any viral protein, of course, can activate. But that's why we were looking, even the infected cells could also do this. That was also, in context of infection also, this activation is there. We could observe that.
Okay. Thank you.
Thank you, Devika. Next presenter, OP number 12, Shiva Prasad from Veterinary Dispensary, Srikaryam, Trivandrum. Judges, please note, OP number 12, Shiva Prasad.
Hello. A very good afternoon to all the respected dignitaries and my dear friends. I am here to present on the topic, the first report of seromolecular detection and risk factor assessment of Bartonella Hanselae infection in dogs, cats, wild felines and veterinarians in India. Coming to the etiology, Bartonella are under the class alpha proteobacteriae under the family Bartonellaceae. They are gram-negative facultative intracellular hemotropic organism. Out of the 45 species detected, 11 are zoonotic, of which Bartonella Hanselae is the most predominant one. Bartonella Hanselae infection in cats is otherwise known as cat scratch fever. The main vector is cat flea. They are clinically underdiagnosed emerging bacterial disease with thousands of cases reported annually in Europe and USA. The seropositivity against Bartonella Hanselae in peoples are more in warmer areas compared to northern latitude. Here comes the importance of India in harboring this disease. Clinical signs. Usually, in immunocompetent individual, the disease is self-limiting within 2 to 4 weeks, but in immunocompromised individual, this can potentially lead to fatal outcomes like peleosis hepatis, valvular endocarditis, and neuroretinitis. Here, 28% of blood culture negative endocarditis is attributed to Bartonella species, of which 24% is of zoonotic Bartonella henselae. The CFR ranges from 7 to 27%, and the reason for high mortality indicate delayed diagnosis and delay in the cardiac surgery. In India, very few studies has been conducted. The first study was from General Hospital, Chennai, and other 2 studies are from AIIMS, New Delhi. So, the critical gaps that led to our study was the actual status of Bartonella henselae infection in cats, dogs, and human contacts are unknown, and there are no published reports of zoonotic risk of the Bartonella henselae infection, and there are only scarce diagnostic facility in India to diagnose this disease. And there is a lack of awareness among the disease among pet owners and veterinarians in India. So, our objective was to screen dogs, cats, wild felines, and their human contact for Bartonella henselae infection by serological and molecular assay and to identify the risk factor. The research work was carried out in Division of Veterinary Public Health, ICAR, Indian Veterinary Research Institute. We have selected Uttar Pradesh, Madhya Pradesh, and Kerala for screening, of which we were able to screen 835 dog sample, 162 cat sample, 532 human sample, and 85 wild feline sample. By using conventional PCR, we targeted the RIPC gene of the pathogen, which has the capability of detecting 10 raised to -4 nanogram. And for serological assay, we have used the IgG IFAT, which is considered as gold standard for the detection, and which has a sensitivity and specificity of over 95%. The risk factor associated with the Bartonellosis in all species has been analyzed based on the feedback from pet owners and high-risk human through a self-designed questionnaire. These are the results. By molecular assay, a PCR positivity of 3.09% in dogs, 1.23% in cats, and 7.48% in humans was detected, and a seropositivity of 29.87% in dogs, 69.13% in cats, and 12.58% in humans was detected. Among humans, veterinarians were at higher risk of obtaining this disease with 24.28% positivity in both PCR and IFAT compared to the general public. This is the geographical distribution from our study. Here you can see in Palakkad district of Kerala, we were able to screen stray dogs also, which resulted in a positivity of 3.9 in PCR. Now, seropositivity in wild felines. We screened leopard, lion, and tiger, out of which 35.29% of overall positivity was observed among wild felines. And in IFAT, those samples which have shown fluorescence at 1:64 dilution of serum has been taken as a positive sample and others are taken as negative. Now the second part, risk factor analysis. In case of cats, male cats and those cats which are less than 1 year old and cats with owners engaged in agriculture and animal husbandry occupation has shown higher positivity compared to their counterparts. Earlier studies indicate that more aggressive nature of young cats and territorial behavior of male cat may be the possible reason for this positivity. In case of dogs, those dogs with elevated SGPT level and those dogs with owners engaged in agriculture and animal husbandry occupation has shown a significantly higher positivity compared to their counterparts. As you all know, in dogs, peleosis hepatis and granulomatous hepatitis has been already identified as a infection, anomaly of Bartonella henselae infection, and those engaged in, those with occupation engaged in agriculture and animal husbandry, they will accompany with the owners, and there are more chances of exposure to flea and other stray cats or stray dogs, which can attribute to the higher positivity. The next is risk factor in case of humans. Veterinarians were having 3.386 times higher positivity compared to the general public, and among veterinarians, those who had an incidence of cat scratch and tick or flea bite within less than 3 months were shown a significant positivity compared to their counterparts. Now the summary and conclusion. The overall positivity of Bartonella henselae of our study was 69.13% in cats, 19.23% in dogs, 18.70% in humans, and 35.29% in wild felines. The risk factor, I have explained it earlier. Now, the final slide, the recommendations from our study. We recommend the identification and characterization of circulating genotype in human and animal population, including wildlife in India. Development and standardization of serological tool like LAT and commercial ELISA for rapid and reliable screening in field settings. Awareness among the vets and medicos need to be created for the inclusion of Bartonella henselae in differential diagnosis of endocarditis, hepatic pilosis, and optic neuritis cases. And implementation of One Health strategy is very important to control Bartonella because fleas are not host specific, so we have to control flea, and possible transmission from wildlife also need to be studied. The observed high positivity of this hidden threat warrants realistic assessment of the prevalence and risk analysis of Bartonellosis among high-risk group in India, including pet owners, zookeepers, and animal handlers. Thank you all for your patience.
Over to the judges for the questions.
Thank you, Dr. Prasad.
Thank you, sir.
Just wondering, how severe is this disease, apart from the complications, and how frequent are the complications?
Sir, the severity is only with the immunocompromised peoples. The literature has shown that peoples who are having HIV or AIDS, pregnant ladies, small children of less than 12 years of age, and old peoples more than 65 years of age, and those who are having some complications like endocarditis or other coexisting diseases will be having the severe fatality. Otherwise, a healthy person is immunocompetent. Usually disease is self-limiting with the some lymph node inflammation or the problem in the scratch areas and all. Usually it is like that.
Okay, thank you.
Thank you, sir. Thank you very much.
Thank you, Dr. Shiva Prasad. Our next presenter, OP number 4, Anju V. Manoharan, Institute of Advanced Virology, Trivandrum. Judges, please note, OP number 4, Anju V. Manoharan.
So, good afternoon. I am Anju VM. The title of my presentation is Production and Characterization of Nanobit-based Casnophorus disease virus-like particle as an in vitro experimental model to study viral entry events under a BSL-2 setting. Let me start with an introduction to Casnophorus disease virus. KFDV is a tick-borne virus. It causes Casnophorus disease or monkey fever in humans and monkeys, and is a severe hemorrhagic illness, and the case fatality rate is around 3 to 5%, and is a high-risk BSL-4 pathogen. Structurally, KFDV is an enveloped post-season single-stranded RNA virus. Its genome encodes 3 structural proteins, that is enveloped, precursor membrane, and capsid, and 7 non-structural proteins. In our study, we focused on the 3 structural proteins to produce virus-like particles. So the major objective of our study was to generate and characterize the KFDV VLP, that nanobit-based KFDV VLP, to study the viral entry events of KFDV within a BSL-2 laboratory. We began by synthesizing codon-optimized gene blocks for KFDV structural protein CPRME and a non-structural protein NS2B, NS3. Here we adopted an epitope tagging strategy to detect each KFDV protein using tag-specific antibodies, as no commercial antibodies are available against these viral proteins. Here we synthesized 3 individual construct, that is capsid, precursor membrane, and envelope, and 2 polyprotein construct, that is CPRME single polyprotein construct and a NS2B, NS3 construct. Here the capsid was tagged with a flag, precursor membrane and the polyprotein CPRME was tagged with a high bit, and the envelope with his tag, and the NS2B, NS3 with an HA tag. After synthesizing the gene blocks and confirming their integrity, we checked the expression of KFDV viral proteins, that is E, PRM, C, and NS3 by Western blot analysis. The results demonstrated that a clear concentration dependent increase in the expression of KFDV structural protein and non-structural proteins. Then we confirm the expression of KFDV proteins in same 293T hex cells by confocal immunofluorescent analysis. In all cases, the viral protein show a clear cytoplasmic localization and no signal was observed in the mock controls. Thereby, we confirm the specific and successful expression of viral protein. Then, moving on to the VLP production phase. Here, we transfected the both HEC293T cells and Vero cells with polyprotein construct, that is the CPRME polyprotein construct. Here, the supernatants were collected at 4 different time points, 48, 72, 96 and 120 hours of post-transfection, and all the experiments carried out at 37 degrees Celsius. Here, however, across all the time points and both the cell lines, we consistently observed a low luminescence reading, which indicating that the VLP yield is very low. So, from this results, we concluded that the 37 degrees Celsius is not an ideal temperature for efficient VLP production in our system. So, to improve the VLP yield, we performed temperature dependent experiments. Here we tried 4 different temperatures, 37, 34, 31 and 28 degrees Celsius. Among these, at 28 degrees Celsius, combined with the 96 and 120 hours of post-transfection, consistently gave the highest VLP yield. Then, notably, the samples with NS2B, NS3 co-transfection show higher luminescence reading than those without, confirming their important role in efficient VLP processing. To further validate, we performed a Western blot analysis and confirmed the presence of VLP proteins, comparing samples collected at 72 hours post-transfection and 96 hours post-transfection. Then, to improve the, still the VLP yield is not sufficient for our downstream experiments. To improve the VLP yield, we perform freeze-thaw cycles to lyse the cells and recover intracellular VLPs. In post-lysis samples showed a significantly higher luminescence reading ranging from 20,000 RLU to 30,000 RLU in all the tested temperature. So, from this, we concluded that the freeze-thaw is a crucial and effective strategy to enhance total VLP recovery. Then, this slide shows the TEM images of KFDV VLP. The viral particles appeared as spherical, and we observed the particle size ranging from 40 to 100 nanometers. Then, next we assess the infectivity of KFDV VLP using 4 different cell lines: BHK21, HEC293T, Vero and CHO. And we CHO by using luminescence assay. Since our VLPs are high bit tagged, so upon successful entry into the cells, the high bit tag is detached from the VLP and bind to its complementary large bit. In the presence of substrate, it produces luminescence. This is the simple principle behind this luminescence assay. Here, Vero, BHK and 293T show a higher luminescence reading, more than 1000 RLU, which indicating that these are susceptible to viral entry, and in contrast, CHO cells exhibited very low values, which indicating that they are non-susceptible. Then, in summary, we successfully developed and optimized a nanobit-based VLP system for KFDV, and this system allows us to safely study viral entry events under a BSL-2 conditions, and our findings also shed light on the roles of temperature, freeze-thaw recovery, NS2B, NS3, protein co-expression and cell line compatibility in efficient VLP production. And this is the first report on KFDV VLP production and contributing a valuable tool for future research and vaccine development. And I would like to thank my PhD supervisor Dr. Mohanan Valivitil, and my heartfelt thanks to my lab mates, and special thanks to ANRF and IAV for funding. Thank you.
Over to the judges for the questions.
So Anju, your RLU values still have not really drastically increased.
Sir, in freestyle method, we got 20,000 RLU, 20,000 to 30,000 RLU. This is big.
In your entry assays, you're still seeing only about 1,000 or...
About 1,000.
Have you done any dose-dependent studies there to see whether it is better?
We're using only 5,000 RLU for infection.
You add only 5,000?
Only 5,000 RLU.
Okay.
Thank you, Anju. Next presenter, OP number 5, Vinitha Shaji from Center for Integrative Omics Data Science, Mangalore. Judges, please note, OP number 5, Vinitha Shaji.
So, good afternoon all. Myself Vinitha, PhD scholar. So, today I am going to present on my paper titled Phosphomotif Analysis Reveals Novel Human Upstream Protein Kinases for Nipah Viral Protein Phosphorylation. So, these are my contents I am going to present today. So, coming to protein phosphorylation. So, it is the phosphorylation. Phosphorylation is the post-translational modification mediated by kinases. So, these kinases will help to transfer phosphate group, and it will bind to the protein and it will form kinase substrate complexes. So, there are different studies which shows that human kinases can phosphorylate viral proteins. So, in many viruses it is known, but what are the host kinases that can phosphorylate these viral proteins are still unknown. So, coming to Nipah virus, this is Nipah virus is paromyxovirus family related to Hendra virus that is first emerged in Malaysia. So, this it is a negative sense single-stranded RNA virus which has a genome size approximately 18.2. It encodes 6 structural protein and 3 non-structural proteins. So, there is one kinase which is known as polo-like kinase, which has identified as a kinase that can phosphorylate Nipah virus proteins like P, V and W proteins. So, coming to the methodology, so what here we are going to did is like we have taken kinase substrate phosphomotifs from the paper by Paul et al. Then we have searched these kinase substrate phosphomotifs in Nipah virus viral protein taken from UniProt and NZBA. Then we have predicted the potential human kinases that can phosphorylate this Nipah viral proteins. We have predicted around 51 human kinases that to predict 86 viral phosphosites in 9 viral proteins, and also we have performed the potential kinases that can predict by predict to phosphorylate viral proteins by using different prediction tools like GasFOS and NetFOS. After this analysis, we have taken this predicted kinases and we have done in silico protein docking analysis, and also we have taken already existing human viral protein interactome data, and also we have performed the conservation analysis to see what are the phosphosite which is conserved across the variants of Nipah viral proteins. So, from that analysis, we got some of the kinases like EF2K, Haspin, MAPK9, which has potential to phosphorylate multiple viral proteins of Nipah. So, we have taken based on the in silico protein docking analysis And protein analysis, we got potential kinase as EF2K that can phosphorylate multiple viral proteins of Nipah. Then after that, we have checked the substrates of EF2K that is potential to interact with the human viral proteins of Nipah. So from that, we have got around 56 EF2K substrate that has an interaction with the 7 Nipah viral proteins. So this is a redundancy-based analysis where we have checked the potential kinases that can phosphorylate multiple Nipah viral proteins. So from this analysis, we can see that in most of the viral proteins, EF2K has EF2K is the kinase that can potentially phosphorylate multiple viral proteins. So this is the docking analysis in which this is the docking analysis of EF2K and fusion glycoprotein. So we have also checked how the viral protein substrate or the site is closely proximate to the kinase domain of this EF2K. So based on the interaction analysis and protein-protein docking analysis, we got that this fusion glycoprotein and EF2K, fusion glycoprotein phosphosite and EF2K kinase domain is closely related. And this is the figure 2.2 is the protein-protein docking of EF2K and viral phosphoprotein. In this also we can see that the viral phosphosite that is which is very close to the kinase domain of EF2K. And figure 2.3 is the protein-protein docking of EF2K and viral nucleoprotein. So in that figure also we can see that the viral phosphosite that is predicted to phosphorylate by EF2K kinase is very close proximate to the kinase domain of EF2K. So these are the protein-protein docking analysis. So here we can see these EF2K fusion glycoprotein, EF2K glycoprotein has better Piper score energy and Piper cluster size. These proteins has better close proximity to the kinase and the viral substrate. So this is the network which is showing the EF2K substrate that is interacting with the multiple viral proteins of Nipah. So this is the conservation analysis we have done to see how these sites are conserved across the variants of Nipah. This is the prediction analysis. We have used gas force and net force to predict the potential phosphosites of this Nipah viral proteins. We also got the similar phosphosites that we got in prediction analysis by using these two tools. So, and also we have checked the upstream kinases of the experimentally validated viral phosphosites of this Nipah viral protein. So we got some of the kinases that is predicted to phosphorylate the already known or existing experimentally validated site of Nipah viral proteins. So coming to the conclusion, this method can be used for multiple viruses to see how the host kinases can phosphorylate multiple viral proteins. And future we are going to collaborate with the Central University for the validation of this kinase substrate interaction. So these are the other multiple viruses that we are doing here. So this paper is submitted in the journal Protein Structure Function Bioinformatics, and one paper is published. Acknowledgement. Thank you IAV for selecting me for Young Scientist Travel Award. References. Thank you.
Over to the judges for the QA.
So Vinita, how many of these were experimentally validated by others? I assume somebody has published already some of this?
No, sir.
No?
Okay. Experimental validated sites are there. Means there are studies which are showing that these are the sites that can phosphorylate any kind of like phosphorylation sites of these viral proteins. But upstream kinases are not predicted for this Nipah viral proteins.
But there is no experimental validation showing EF2 kinase can
No,
phosphorylate
no, no.
this site. So it is a general phosphorylation site.
Yes, yes.
Whether that kinase or any other kinase may be phosphorylated.
Yes, yes. There are studies showing that EF2K inhibitor, that is known as rotlerin, that can inhibit Nipah viral replication. But so we can predict like EF2K might phosphorylate these viral proteins.
Okay, thank you.
Thank you, Vinitha. Here we end the podium presentations. Before going to the next scientific session, a gentle reminder to collect the duty certificate and cash receipt from the registration desk when you break for tea. Now we move on to the next scientific session on One Health in Practice, Data, Spillovers and Prevention. To chair the session, let me invite Dr. E. Srikumar, Director, Institute of Advanced Virology, Trivandrum, and Dr. Anish T.S., Professor and Nodal Officer at the Kerala One Health Center for Nipah Research and Resilience in Kozhikode. The speakers for the session, Dr. Biju Soman, Dr. Srilakshmi Mohandas, Dr. John Epstein. Over to the chairs of the session. I now invite Dr. Biju Soman to deliver the talk. Dr. Biju Soman is a professor at the Achyuta Menon Center for Health Science Studies, SCTIMST Trivandrum, and a leading public health expert with over 2 decades of experience in infectious disease epidemiology, health informatics, and geospatial analytics. Trained in community medicine and infectious disease control, he brings a systems thinking approach to public health research and policy. Dr. Soman leads several nationally funded projects at the intersection of digital health and infectious disease surveillance, including a mobile telemedicine initiative in tribal Wayanad, real-time COVID-19 monitoring using data science and geospatial analysis of tuberculosis data from India's Nikshay platform. He also heads the Regional Resource Center for Health Technology Assessment in India, contributing to evidence-based policy formulation. We invite you, sir, to the scientific session.
Biju sir, over to you.
Good evening, and first, thank you, the organizers, for giving me this platform to interact with you. Today I'll be talking on this data science for own health, a public health perspective. So I'll try to limit my presentation within 20 minutes so that actually we'll have a couple of minutes for question answer sections and all. So I'll try to cover an introduction like One Health, public health, and data science, and why these are all complementary and how can we use them. And what are the challenges of implementing One Health per se. because we have heard from the very morning from the our additional chief secretary also, like we need integrated systems. We need to have data sharing across different disciplines for One Health to be in place, and we have to get rid of this working in silos, and we have to learn to collaborate, and we should have a good interdepartmental governance mechanism. So what are these are all some of the hindrances as we are seeing now. Like One Health has a lot of potential, but we are not getting or we are not getting what we expect out of One Health. So now how can we move forward? That is the question. And here I'm trying to highlight the importance of using open source platforms, open source software, one software like R, which can be used for analysis as well as reporting, and it can be a sort of bridging across disciplines. Even this presentation I have made it in R. Actually, no, it's not using any of the proprietary softwares at all. Because it can use not only statistical analysis, but spatial analysis or time series analysis or spatio-temporal analysis or genomic analysis and all. Genomic analysis I haven't done, but it's possible. And a few case studies of our own work in this direction, like in COVID dashboard and some work on dengue outbreak prediction in Punjab, and about malaria. How can we use, how can we combine this meteorological data with routine health system data in malaria that was done in UP, and then a recap. So I come from Sri Thiruvananthapuram Institute. I'm skipping it, but let me tell you that I come from although I'm a doctor, actually I'm coming from an institute which is under the Department of Science and Technology. We have a unique structure in which we have a hospital, we have a biomedical technology wing where engineers and scientists are working, and we have a public health wing. So I'm not going to delve upon here. Actually, we covered One Health. Actually, is coming together of 3 units. Actually, like three sections. Like we have to take care of not only human health, but we have to look for what's happening in the animal kingdom, as well as in the environmental kingdom and in the plant kingdom. And so we can only live in a very conducive ecology. So that's the nutshell of One Health approach. And why in epidemiology we are more keen to look at One Health is this. Actually, you can see that the spillover, once the spillover occurs, actually there will be huge load of cases in the domestic animals or peri-domestic animal. And then humans can also get disease. Actually, and there will be lot of morbidity and mortality which can occur. But if we can, in the picture on the downside, actually you can see that if we can dictate the rising sero markers for any infections in the wild animals or in the peri-domestic animals, then we can act or we can initiate the preventive or control measures early enough so that the load of the disease, whether it is in the animal or in the livestock or in the domestic animals or in human beings, can be reduced. Actually, that's why we, from public health angle, we are more inclined to look at One Health. And One Health is an idea, actually has become an approach and a movement now, you know, and it promotes multi-sectoral and collaborative efforts, and because the whole of society approach. And I think there's a lot of commonality with the public health. And public health also, actually, we are not looking at health issues per se. Actually, a health problem is a public health problem when we feel like it can't be controlled by doctors and nurses alone. Actually, we need the entire community, almost everyone in the community, to act in a conducive way. That's when a health problem becomes a public health problem. So its guiding principle is primary health care, and you know that primary health care, actually it has 3 cardinal principles. So like equity or equitable distribution. Actually, we should not discriminate anyone, caste, class or gender or whatever, their location and all. Irrespective of that, we have to provide basic health care to everyone. And it should be done with the community participation or community engagement. We should empower the community for sustainability of that intervention. That is the second core principle of primary health care. And intersectoral coordination. Actually, we have to work together rather than we work in silos. Actually, we have to come together, but it's not very easy, friends. Actually, although we tell that you have to work together, different disciplines should come together. There are a lot of hindrance to that. Actually, the way we think, the way we use our technical words, these are all issues when we try to bring people together. And the fourth component is use of appropriate technology. It says that in primary healthcare, we have to look at equity, community participation, intersectoral coordination using appropriate technology. And what is appropriate technology? I'm not going into the details, but the technology which people wholeheartedly harness and the technology which they can sustain by themselves. So that's appropriate technology. Best example is ORS. And nowadays, probably if you take mobile phone would be another example. Actually, the sort of leapfrogging concept in informatics. So, from public health point of view, actually, why we are concerned or why we are interested in One Health is that if we wait till the exposure occurs in the animals, in the clinical manifestations, and clinical manifestations in humans, so then it will be very delayed response. Actually, if we start our control activities after human cases come up, then the cost for that control activities, whether treatment, rehabilitation, and all, will be quite high. And the overall cost could be minimized if we can detect the cases quite early, before the cases occurs in human beings, before the case occurs in the livestock and the domestic animals. If we can act, then the overall cost will be much less. That's why, from public health angle, we are more keen to harness One Health. And now, data science. Why data science? And actually, I'm trying to give you an oversimplified version of data science, mainly for the youngsters here and all. So data science is a combination of three things. One is informatics, or computer science. And second thing is our statistical analytic power. And third thing is our domain expertise. Whether you are coming from health domain or you are coming from agriculture domain or whatever domain, that domain expertise. Bringing all this together, that is data science. Actually using the computing power of the systems. Computer systems, actually we can probably use our analytic skills in a much more better way, much more faster way, much more productive way. So that's what data science is looking at. So it's a combination of informatics, statistics, and domain knowledge. So with the purpose of drawing meaningful insights from data, of course, many often large breadth of data or longitudinal data and all. And the purpose of data science is to help in decision making. And one of the data science tools, I would say, that geographic information system, and that's also in public health, we like it. Like in public health, we are interested in everything under the sun. Actually, we are not only concerned with the data coming from health department, we are concerned with the pesticide use, we are concerned with whether we have a transport network and all. So we need to collect data from varied sources and do some sort of combined analysis. But for that, actually, you know that even the presentations here, actually, they are coming from different backgrounds. It will be very difficult to bring together two types of data. No? Actually, even from an institute, actually, you will be coding your database in different ways. Actually, sex can be coded different, education categories can be coded different. So that's why it will be very difficult to bring data together. And that's happening in one discipline like health. But in public health and in One Health approach, we have to bring data from varied sources. So that's where this GIS software comes very handy. In GIS, actually, if you geomark the data or geocode the data, the latitude and longitude if you are taking, then we'll be able to do layered analysis. So data from anywhere, data from any discipline, data in any form, it could be text form, numeric form, or voice or video, all the data can be brought in so that we can do layered analysis. So, and many of the GIS software, actually, it can manage huge quantity of data. So that's another capability of GIS and all. So it helps us to analyze large amount of data quickly and predict outbreaks and disease patterns, and helps in surveillance and disease making. And that's why in healthcare, actually, we are using data. And now it's coming to zoonosis. Actually, you know that the zoonotic things actually can you, actually it's not possible now. Actually we can bring it down actually and to see that the wet market and all, like when we are looking at the disease ecology, we know that it's not only the pathogens and their virulence, even the physiography of the environment. Actually, I have pictures on that. Actually, like we know bats are one of the very notorious vectors of many of the zoonotic diseases because they're flying mammals. So they share the same viral load as human beings and all. And then the social patterns, like in many of the in the Chinese belt and all, actually they in their market this kind of wildcat and all are available, and then they eat snakes and they eat all sort of things and all, and there's a lot of mix up of this kind of foodstuffs that can lead to diseases. So if you want to control disease, if you want to have better participatory surveillance, then we have to go beyond our traditional means of surveillance. We can't just look at the routine health data and all. We have to catch data from varied places. But if you want to bring the social influence or ecological matters or environmental matters, then that means huge load of data. And how to manage that huge load of data, that's where actually we have a mechanism like our software and all. And zoonotic viruses and all, you can see that actually they were looking at how human beings share some of the zoonotic viruses. Actually, you can see that petty domestic animals and domestic animals, actually we all share the same viruses, which has the potential of coming into a zoonosis. And fortunately, nowadays, there are a lot of databases. In India also now, Government of India, they are providing quite a lot of data through the data.gov.in. Actually, a lot of data is available. And about zoonotic diseases, their symptoms, etc. and all, this Alliance group and all, they provide enough data and all. So whether we will be able to bring all those data together and use our intuition to draw meaningful conclusions. And even mapping, surveillance data and all, actually even satellite data can be used for One Health initiative or for public health purpose and all. So One Health data set and public health entities are mutually cohesive and complementary. And that's why actually if you are interested in One Health, you have to think about, you have to get skilled in some sort of computer program or computer science thing. And there I feel like R is a good starting point because it gives a sort of research pipeline. Starting from data collection and data analysis, and then using result generation, how to present the results, like you can make figures and publication ready tables and all, and then you can make this kind of presentations, you can write articles, you can write book, you can even publish dashboards. So these are all possible if you learn just one software. So you need not, there is no need to learn and buy many costly softwares. Actually, just using one software, you'll be able to do all those things. And some examples, actually, during COVID time, we at Thiruvananthapuram Center, we were keeping a live dashboard. Actually, this is also using open source software. And one of my student actually has done analysis of dengue, actually in Punjab, around 80,000 cases of dengue over 3-year period actually he has taken. And then with that actually he was able to generate a schema, algorithm with which emergence of outbreaks could be predicted. This is done in the entire open source scenario, and in his dissertation actually we have included all the codes for that, so it can be replicated for other purposes as well. And yet another thing in which malaria in Bareilly district actually in UP actually is a MBS postgraduate student actually he has done, and in this case actually he was having around 4-year data, actually around 46,000 malaria cases there and all, actually, and he could map to see which are the risk blocks there and all. But at the same time, when you are using data science, so when you are using One Health approach, there are some of the ethical questions actually. So emerging ethical issues actually you should be aware about. Actually, when we get data from varied sources and we are trying to put it in dashboards and all, we have to look at the privacy, confidentiality issues
and we should be a bit aware of that. I'm not going to dwell upon that now. And as a recap, actually, friends, I was trying to tell you that if you are really interested in One Health, just preaching and conferences will not work. Actually, we should have the knowledge, and then we should have the skills, and we should have the mentality. So the three things are needed. And mentality, I don't doubt that most of us have. And then we probably will be getting the knowledge base also. But we should have some skills to work together for transdisciplinary work and all. For that, we have to invest some of our time to learn some software which will help you there. And that's where a computer language like R will help you. And so One Health needs better data governance skills also. And our software is a promising way in this regard because it's an entry point to data science. And my advice to the youngsters, you take the lead, otherwise you will be led. Thank you.
Thank you, sir, for that thought-provoking lecture. We will go for 1 or 2 questions from audience.
Thank you, sir, for the excellent lecture as usual. So as far as India is concerned, the data fidelity is a major concern, right, sir? You talked about dengue in Punjab, but if you are looking at the IDSP, it won't be reflected. So if data is in question, how will these softwares work, sir?
Yeah, very good question. Actually, we are not using this administrative data or routine data because actually we know that there are a lot of labs on the quality of the data and all. But fortunately, if you start using the routine data, why the routine data is that much lousy? Because nobody is looking at the routine data. So if you start looking at the data and if you can start do some analysis and give feedback, slowly the quality will improve. And in data science, we have many imputational methods, statistically robust imputational methods with which we can improve the quality of data. For example, that dengue work actually, which I was telling you that around 80,000 records, but there the age will be in different columns. Actually, sex will be in different columns. And but there are mechanisms by which we can bring those in. Data mining techniques are available. So data cleaning will take a lot of time, but you can do it in a reproducible way. That's why actually I'm advising you to, especially youngsters, to get into R or that kind of software which work with codes. So once you write the code, then the same code can be reused. So next time when you're interested with such a work, you'll do a better job. So that's why. So routine data, of course, the quality is suspect, but now routine data analysis schema are there. Actually, we can start using that. That way, in the long run, our data will get improved.
Thank you, sir.
Thank you.
Next, we will move to the online session by Jonathan Epstein. He's a global leader. He worked both in context of Hendra virus and Nipah. So I just, sir, over to the counter.
Hello, hi, can you hear me?
Yeah, we can hear you, Epstein.
Excellent. Well, thank you very much. Good afternoon,
I invite
everybody.
Dr. John Epstein to the scientific session. Let me introduce Dr. Jonathan Epstein. Dr. Jonathan Epstein is a veterinarian and epidemiologist specializing in the ecology and spillover of zoonotic viruses from wildlife to humans, with a focus on bat-associated pathogens such as Nipah virus, Ebola, and coronaviruses. He is the founder of One Health Science, a research and policy consultancy that collaborates with global health and wildlife agencies, including WHO, WOAH, FAO, and Africa CDC, to strengthen zoonotic disease surveillance systems. Dr. Epstein holds adjunct faculty appointments at Tufts Cummings School of Veterinary Medicine, Harvard University, and Columbia's Mailman School of Public Health. He has served as Chief Scientific Advisor for the Smithsonian exhibit Outbreak: Epidemics in a Connected World, and currently co-hosts the YouTube series Thermometer, focused on infectious disease news. We welcome you, Dr. Jonathan Epstein, to the scientific session.
Thank you so much. Thank you.
Over to
Good
the chairs
afternoon.
of the session.
Hi.
Hi,
Thank
Dr.
you.
Epstein. You may please start.
Okay, thank you. Yeah, no, thank you very much for having me. I just wanted to extend my gratitude to Dr. Kumar and the organizers of the conference for inviting me to be here today. It's a pleasure, and greetings from Chicago, which is where I found myself this morning. Um, can you tell me tell me if you can see my slides, please?
Yeah, it is visible. Thank you.
Great. So I wanted to spend some time today sharing some insights with you about what we understand about the ecology of Nipah virus, something that I know has been very important locally in Kerala and in India in general, and something from which we've learned a great deal from work in South Asia region. And so I'm going to share some insights from work that I've done in Bangladesh next door, but something that will be very relevant to understanding the ecology and spillover of Nipah and related viruses. And I just wanted to begin with the point that I may interchangeably discuss Nipah virus and Nipah viruses together because I've begun to really broaden the way that I think about this as not a single virus, but rather as a group of related viruses, because we still have only yet to scratch the surface of understanding the genetic spectrum, the diversity of Nipah and related viruses that could potentially spill over and emerge in people. And so I think it's to our benefit, and it is where the scientific community is really moving in terms of thinking about viral groups rather than prototypical single viruses as we prepare to develop countermeasures for prevention of spillover and dealing with outbreaks. So we've probably heard a lot about Nipah virus today, and I know you had an excellent lecture this morning from my colleague, Dr. Gurley, about Nipah's epidemiology. But I wanted to begin by emphasizing the point here again why Nipah viruses largely are of concern. And it isn't simply because they've shown to have a high case fatality rate when they get into people, but really what Nipah virus represents is an emerging zoonotic virus that has a very broad host range, meaning that the bats that carry it occur very commonly across South and Southeast Asia and into Australasia and the Pacific Islands. And so the potential for related viruses to emerge is very broad. And we've already seen Nipah virus has the ability to infect many different species. And so this is a zoonotic virus literally knocking on the door. Every time there's a spillover event, every time we see a human case, this is an opportunity for a high consequence virus to adapt to human transmission. And so and in terms of countermeasures, though they are in production, in development, we don't yet really have an effective treatment for Nipah virus other than supportive care in a hospital. Vaccines are being developed, and so that will become an important tool. But right now, our strongest strategy is to prevent spillover from happening in the first place. And every time that it does, we really worry about either the virus adapting to people or that a strain already exists within bat reservoirs that will show the ability to efficiently spread from person to person. We haven't seen that yet, but it is something we think very much about. Our other challenge is that across the spectrum of where henipaviruses occur, we have generally poor surveillance and health infrastructure. So it's probably true that we don't recognize the majority of spillover events and outbreaks that occur simply because we don't have the right surveillance systems in place. And as I mentioned just in the opening, henipavirus genetic diversity generally is very poorly understood, as is the relationship between the genetics of the virus and the phenotype, the clinical presentation, the epidemiological profile. So we assume that we understand how Nipah will spread when it gets into livestock or people, but we've only had very few examples over history. So, we still have a lot to learn about that. So focusing now in on the region, we have very good evidence and a very good understanding that a species of bat called Pteropus medius is the primary natural reservoir. This is the large frugivorous bat that you see commonly roosting in villages and sometimes even in urban centers in large trees. They feed on foods like figs, mango, guava, lychee, those types of fruits. And they're just very abundant across the region in South Asia. And we know from an abundance of studies now that have been done that Nipah virus circulates pretty broadly in these bats throughout India and Bangladesh. And I'll get into the specifics of how common it is to have an infected bat, but we know from plenty of evidence that this is the primary natural reservoir. We can assume that wherever these bats occur, they likely carry Nipah or a related virus. And our experience with human outbreaks, although it's becoming more frequent because our surveillance systems are better and we're detecting them much more efficiently, most of our experience comes from Bangladesh and now India. In Bangladesh, we see annual seasonal outbreaks in people, and it's been very well characterized that spillover occurs primarily through the consumption of raw date palm sap. In India, the story is a little bit different. We've seen outbreaks in the northeastern part of India in 2001 and 2007, but lately most of the cases have been identified here in Kerala, and they tend to be sporadic cases, a few clusters. We've seen some hospital transmission, but to this date, spillover remains uncharacterized. We don't exactly know how people are getting exposed to Nipah virus in southern India, and that is something that we very much need to understand. So I'll tell you a little bit about the ecology in general of Pteropus medius, and Pteropus is one member of a genus of bats that it includes about 60 different species. And again, these are pretty common throughout South and Southeast Asia. These are tree roosting bats. They're the largest species of bats and the largest flying mammals in the world. And they are relatively common, relatively abundant, particularly Pteropus medius. It does very well in humanized environments. It does very well in fragmented forests, living among people. In fact, we did a study and found that they prefer to roost in fragmented forests, clumps of trees, kind of like what you see in this picture from a rural village in Bangladesh, but this could be a scene in India as well, where there are clumps of hardwood trees nestled amongst a grouping of houses, maybe with some fruit trees nearby, and it wouldn't be uncommon to see a group of 100 or 200, maybe 800 or 1,000 of these bats roosting in a series of trees very close with people. And these bats are generalists in their diet. So they may fly up to 50 or 60 kilometers a night foraging for fruit. The kind of fruit they prefer naturally would be figs, but in a more humanized environment, they would do very well with the same kinds of fruits that we would cultivate and eat, namely things like mango and guava and lychee, in addition to figs that might grow within a community. And so we have a lot of shared food resources with these bats as well as with our livestock. And so, and other bats as well that eat fruit will commingle with Pteropus. And so there really is quite an opportunity for not only overlap, but for indirect contact through the contamination of food like fruit. As I mentioned, in Bangladesh, the situation is pretty well characterized. What we know is that date palm sap, which is cultivated and harvested locally. It's a cottage industry, but it's very widely consumed, particularly in the western part of the country, by people carving the bark off date palm trees, allowing the sap to flow into these clay collection pots. And as you can see from these infrared images, these bats have learned to exploit this as a food resource. So because these bats, are attracted to sweet fruits, date palm sap is also sugary and sweet, and they have learned to use it as a food resource. And I want to make the point here that date palm sap is completely a human provided food resource for these bats that they have learned to exploit. These bats in no way naturally have the ability to access date palm sap. They can't strip the bark off trees. And so this is a food resource that they have learned is available in the winter months when perhaps other fruit is much less available to them, which is part of the reason it amplifies the risk of Nipah spillover, is that it attracts Pteropus medius in the winter months. And if bats happen to be shedding Nipah virus at the time, they're contaminating sap with saliva, urine, or feces. That is when sap may be contaminated. And if that bat that does contaminate the pot happens to be shedding virus, then people who consume that batch of date palm sap become exposed. And so this is a very clear pathway, and it is a human-created pathway. And so this concept of wildlife provisioning becomes very important when we think about zoonotic disease spillover. And so a lot of what we understand about the ecology of Nipah virus comes from a study that I was involved in, that I led between 2006 and 12, and has been ongoing actually, understanding the seasonality and the distribution of Nipah virus in bats and spillover into people. And it started with trying to understand simply how common an infection Nipah virus is in Pteropus medius. And so the study back in 2006 was set up to compare the area of Bangladesh where human cases tended to occur, which was the Nipah belt, the western and central part of the country, with Nipah virus in bats outside of this area where human cases had not been reported and to this day still are not reported, interestingly. And so we had a cross-sectional study comparing the frequency of Nipah infection within the area of human cases and outside the area, just to see if the pattern we saw in people could be explained by what was going on in the bats, as opposed to simply the availability and timing of date palm sap consumption. A second component to this study was a longitudinal study, and this is becoming more and more essential in wildlife studies of zoonoses. We're finding more and more that many of the viruses we're concerned about, Ebola, Nipah virus, Hendra virus, these are sporadic and acute infections in bats. And so a one-time study to understand which bats are infected can often lead to very low detection of virus because the virus doesn't actually occur at high frequency. It's a fairly low incidence virus in bats. And so if you're not there at the right time, you might miss it. You might not detect it. So repeated sampling over time or a longitudinal study is actually much more informative in terms of understanding the patterns and the dynamics of infection within a wildlife population. And so our second aim in this study was to understand what the temporal patterns were, the timing of infection within a bat population. And we chose a colony that was in an area where there had been multiple spillover events, multiple human outbreaks, and that was in Faridpur, Bangladesh. And the study was set up to sample 100 bats every 3 months, so quarterly. And we did this over a period of 6 years. And so the kinds of samples we would collect, and here you can see we're using personal protective equipment to handle these bats. We capture them using mist nets. We anesthetize the bats, mostly for their safety, to help the bats relax. They're not aggressive animals, but they can be stressed out because they're prey animals. They're eaten by a lot of other things, including humans sometimes, but typically raptors like eagles or pythons. And so we anesthetize the bats. It's also to protect us when we're handling them so we don't get bitten. We collect blood, oral swabs, urine, feces. We take bodily measurements. And then, because we're doing a longitudinal study, we'll use a microchip, a small RFID chip that we insert under the skin between the shoulder blades so that we can identify individual bats in our study should we recapture them in the future. In addition to sampling individual bats, we collected environmental samples. And over time, this has been shown for us to be probably the most productive way to identify Nipah virus in a colony of bats, is to lay out tarps and to collect urine that drops underneath the colony. It doesn't allow us to identify individual bats that are infected, but it's useful for understanding the genetics of a virus that might be shed at a given time. By collecting a larger volume of pooled urine, we're more likely to detect the virus and then be able to characterize it genetically. And on the right here, we've rigged some falcon tubes to pillowcases, so while bats are waiting to be sampled individually, we're able to get a very good urine specimen. They just urinate into the tubes, and that's been useful for getting a higher volume specimen. So I'll share with you some data briefly about what we learned from this 6-year study. It was very informative. The first one was the cross-sectional study where we simply compared the frequency of infection in bats within the Nipah belt and outside the Nipah belt. And what you see here is serologic data that's broken out by location and by age class of the bats, adults and juveniles. And the bottom line was that everywhere we looked, we found bats with antibodies against Nipah virus. So that told us that this virus circulates very widely in these bats. It wasn't restricted to any geographic area. The incidence was actually pretty low. We only found about between 1% and 3% of bats were shedding virus at the time that we sampled them. And this was consistent with data we had from Malaysia from a prior study. So Nipah virus is an acute infection that lasts about 7 to 10 days in bats before their body clears it. So that's when they're shedding. And it is pretty rare. I mean, it occurs at low frequency. So one of our questions was, how does a virus maintain itself in a wildlife population at 1 to 3%? And I'll get to that in a minute. But really, though we saw differences based on location in terms of the seroprevalence and the frequency of shedding, there was no pattern about inside or outside the Nipah belt, west or eastern Bangladesh. Bats could be infected anywhere based on what we saw in the serology. Now, the longitudinal study was incredibly informative. This was the repeated sampling every 3 months of 100 bats, plus we were microchipping them. And what we learned is that these bats use a wide area in land. Okay, so we might catch bats in one location, we were putting microchips on them. When we came back to that same field site, we might not catch the same bats, but if we were catching, 10 kilometers down the road, we might pick up a bat that we had microchipped elsewhere. And so we started to be able to assemble a picture of this area of about 80 square kilometers that the same bats would shift around and use different roost sites. And why that was important was it kind of validated that our representative sample of the bat population could be obtained by sampling in a larger area. If we showed up at a site and there were no bats there and we had to move 10 Ks down the road, we didn't worry that these were a different population of bats. It's really the same population that mingles and intermixes. And so these bats are really quite mobile and do shift around. Although they generally tend to stay roosting in one area over their lifetime, unless that area gets disturbed, whether trees are cut down or something like that. The other thing we learned from the repeated recaptures, although recaptures weren't that common, only about 2.4%, is for the first time in wild bats, we saw the phenomena of seroconversion, meaning bats that we initially caught that had no detectable antibodies against Nipah virus. Months later, we would recapture those individuals and they would have antibodies. And so that demonstrated that there was probably an outbreak within that bat population in the interim period. Maybe even more interesting to me was that we saw seroreversions, where bats we initially captured that were seropositive would subsequently, some months later, be seronegative. And that was the first evidence we had in a wild free-ranging population that immunity was waning. There was a hypothesis early on that once bats were infected, they retained immunity for life and they couldn't be reinfected. And that was what informed our thinking about how Nipah virus moved through bat populations, that once bats were immune and once a population had a high enough herd immunity, they couldn't get reinfected with Nipah. And now we see that that's not the case, that adult bats do lose immunity over time and would theoretically be susceptible to reinfection. So that was really important from the longitudinal study. And here's what we learned by looking at and modeling the data. This is data that was applied to a mechanistic SIR model where we included life history traits of the bats, their age, the mortality rate naturally, the birth rate, things like that, population count size. And over the 6-year period, just wanted to really highlight a few things. What you see on the top there is the seroprevalence in adults over time. Those dots are the data points over each quarterly period. On the x-axis, we have predicted PCR, predicted viral detection, meaning that based on the serology, where we would expect outbreaks to be occurring within the bats of Nipah virus. And it is indeed in real life where we got detections of Nipah virus. And then on the bottom is the juvenile serodynamics. So this is the pattern of IgG antibody detection in juvenile bats, which are defined as bats that were less than 14 months of age from birth. And so what we see is that in the juveniles, where bats give birth at the same time every year, these are seasonal breeders, and they tend to give birth between roughly March into late May and early June every year. We see a pattern of juveniles born with antibodies that are probably maternal, and then that immunity wanes in the population over about a 6-month period, which is the loss of maternal antibodies. And then the next year, a new cohort is born, and so we see a spike in immunity at the juvenile population level that is consistent with bats being born with maternal antibodies and losing them without real transmission going on in the juvenile bats. But when we look at the adult bats, this is where we really saw something interesting, was that the transmission seems to be occurring in adult bats, that about every 2 years, we're seeing a significant increase in the percentage of bats with antibodies against Nipah virus, suggesting that there's an outbreak of Nipah occurring in this population roughly every 2 years, and that adults do lose immunity over time. So as the population immunity drops, that population is susceptible to introduction of virus, either through immigration of an infected bat or through the process of recrudescence, which we have seen in bats, where they can be negative for Nipah virus, and then they can recrudesce a viral infection and become active again. And so these are two different ways that the virus can be introduced into a susceptible population. And if the seroprevalence is low, below some threshold, which might be around 50% or so, they are susceptible again to a new infection. So adults, based on the model, adults are driving Nipah virus circulation. It is related to the decline or the waning of immunity in the adult population. And then there's a stochastic element to it as to how the virus is reintroduced into that population. And so although our data came from one single population of bats, we hypothesized that these kind of dynamics occur everywhere, but they may not be synchronized. So different populations may have different timing of outbreaks of Nipah virus, but it is a sort of periodic outbreak within bats. We also learned a lot from the molecular analysis we did of the genetics of Nipah virus. And really what I'm showing here with this phylogeny is two things. One, that in our spatial study where we tested bats from around Bangladesh, we saw slight differences in the virus genetically, very slight. This is a pretty stable virus that doesn't mutate very much normally, but we did see differences looking in the L gene region, the polymerase region of this virus. However, in the population in Faridpur that we were testing repeatedly, we saw virtually no difference in the polymerase gene over a 6-year period. Very little change at the nucleotide level, again, suggesting this is pretty stable. And then when we compare the bat sequences, which are shown in blue in this figure, to the green human sequences, we see that there's consistency, that where the human outbreaks have occurred across Bangladesh, there are differences, slight differences in the virus that we assume is reflective of the strain circulating locally in those bats. And we see spatial differences there. And that's been consistent with the Kerala experience where NIV Pune has done sampling of bats concurrently with some of the human cases. And we see that there's consistency between the strain circulating locally in Pteropus bats and the strain that infects people at the time. The second thing we found that was in eastern Bangladesh, we found a strain of Nipah virus in bats that was more closely related to the Malaysia genotype or the Malaysia clade of Nipah virus than it was to the Bangladesh and India group of Nipah viruses. And that was really interesting because, you know, it was the same bat species, but it suggests that there were broadly different strains of Nipah virus circulating just within Bangladesh. And that's probably indicative of the historical connectivity among bat populations, not only within India and Bangladesh, but into Myanmar and down into Southeast Asia as Pteropus media starts to interact with other species like Pteropus lylii, which is in Thailand and up into Myanmar. Now, this is a little off topic, but it's kind of new data that we have, and I wanted to share it with you because it emphasizes the point about understanding, you know, viral dynamics and also prevention strategies. And that is that we took the same serology samples that I just showed you, where we analyzed Nipah, and we tested them for filovirus antibodies because, you know, we know that bats can carry, that there are Asiatic filoviruses out there. And we found that Pteropus also had antibodies against an Ebola-like filovirus. Now, at the time, the analysis we had, the proteins we were using were for Ebola Zaire, and we're seeing strong reaction here. I don't believe that there's Zaire Ebola virus in Bangladesh at all, or in these bats. However, we've now seen that related bats in parts of Asia carry filoviruses that could be eliciting this kind of immune response, just simple cross-reactivity. So we haven't detected a filovirus in Pteropus medius by PCR, so I can't tell you exactly what kind of virus is causing this, but I would hypothesize it's related to viruses found in a related bat called Rosetus leishmanii, and that it's probably one of the, you know, various mangaloviruses or you know, other Asiatic filoviruses. Nonetheless, we see consistent antibody circulation. In this, we see different dynamics than Nipah virus. So just really briefly, in the adults, we see annual transmission patterns, and in the juveniles. And so unlike Nipah virus, with this filovirus, juveniles do seem to be involved in transmission patterns among juveniles and transmission to adults. And this may also be being caused by multiple different antigenically related viruses. So we don't know. There haven't been any reports of human exposure to filoviruses in the area, but also that type of surveillance isn't happening. So I don't believe there's currently testing for filoviruses in human patients that show up with acute febrile illness or if there's any hemorrhagic fever, if filovirus are being tested for, but it is something that we might consider based on the fact that the same bats carrying Nipah virus may also carry a filovirus that may be able to be transmitted to people. So to get at the question of how is a virus maintained at such low frequency in a bat population, we wanted to understand how bats move and how they relate to each other. And so we did a telemetry study looking at using satellites to look at long-range bat movements. And we satellite collared 14 bats in Bangladesh, 8 males, 6 females. Some of the females were pregnant. We collared some in Faridpur and we collared some in Cox's Bazar, which is down by the Myanmar border. And essentially what we saw is that these bats are capable of long-range flight. We had a couple of instances where bats were tracked up to the India border. You know, we assume these bats freely cross borders. That's not a surprise. But we did see these kind of long 100, 120-kilometer movements. But the majority of locations we got from the satellite data were within about 10 kilometers of the roost site where these bats were. So they move between Faridpur, they move into Dhaka, back to Faridpur, but they tend to stay around where they roost, which is really interesting. And that kind of localization of these bat colonies suggests that they have roosting and food resources nearby. They don't have to migrate to find food resources. And there may be kind of minimal communication long range, say between bats and Faridpur and Cox's Bazar. We didn't see that kind of connectivity, but we assume there's local connectivity and that these bats form a meta population, that there are roosts nearby where bats would intermingle and intersperse. And through this meta population structure, which we see elsewhere with Pteropus bats, that is how viral sharing occurs across a broader area. As I mentioned at the outset, we know that these bats prefer degraded forest and humanized environments. And we know that because we did a comparative study where we looked at bat roosts across the country and we looked at forest cover, and we found that Pteropus roosts were more likely to occur in fragmented forests near human populations. And that, of course, is very interesting in terms of zoonotic disease transmission, because it just, again, suggests that these bats are very comfortable using food that we provide. They feed on cultivated fruit that we grow, and it allows opportunities for perhaps transmission of viruses like Nipah virus because we live in such close proximity. And I don't want to forget a discussion of livestock, because if we remember, in the original emergence of Nipah virus in Malaysia, pigs were how Nipah virus emerged in a very large pig farm. And though we haven't seen livestock be involved in transmission yet in Bangladesh, or to our knowledge in India, we did do some surveillance of these nomadic pig herds in Bangladesh that are small pig herds that are raised by villagers and moved from village to village to be sold. And in this photo that I'm showing you, this pig herd is right next to, just off camera to the right, is a schoolyard with a large Pteropus colony, a large bat colony. And one could imagine these pigs foraging for food, rooting around underneath trees where bats are living, and they could be exposed to excreta that has been dropped onto the ground as these pigs are rooting around for food. And so it's very plausible to think that pigs could be exposed to henipaviruses from these bats. And indeed, when we tested these pigs, although they didn't have a history of disease consistent with Nipah virus, we found that about 45% of the pigs had antibodies, non-neutralizing antibodies against Nipah virus or something related. And we also found a small percentage of cattle and goats also had antibodies. So clearly, livestock are being exposed to henipaviruses. And again, they haven't necessarily featured in human transmission so far, although some early outbreaks in Bangladesh in 2003 suggested that people who got infected with Nipah had contact with a sick cow. That cow was never tested. We have no evidence that that cow had a Nipah virus. Nonetheless, there was an association with cases. So we have to keep our eye on livestock in India and Bangladesh just because we know that it's a possibility. We also know that in Bangladesh, when we spoke to farmers, it was very common for them to feed their livestock dropped fruit. That's fruit that was bitten by an animal, dropped on the ground that they couldn't otherwise sell. They'd allow their animals to eat it. And so again, this is a plausible route of exposure if that dropped fruit was bitten by bats and has contamination with saliva, and that bat would happen to be infected with Nipah virus. So what we're doing to follow up these data I'm presenting with you is we've undertaken a secondary study between 2020 and 2024. And this time we expanded the study. We wanted to ask questions about how come we don't see human cases in parts of Bangladesh? Is it simply because they're not drinking as much date palm sap, or are there other reasons that the virus is only spilling over and emerging in one area? And this may be relevant as well to the India situation, where we see repeated outbreaks in some parts, like in Kerala, and maybe not in other parts where there might also be surveillance. We have to be careful that this is, very dependent on surveillance and ability to detect cases. Nonetheless, in Bangladesh, there's a clear pattern. So we set up sites where we tested healthy people in 6 locations, in 4 locations, 600 people per site. This figure shows 2 extra sites, sorry. And we're in the process of testing those samples just to see if people are getting exposed to Henipaviruses, but maybe in the East, they're not getting as sick. It's a different strain perhaps, or they're, not reporting to hospital. I don't know, but we wanted to see what the background exposure rate is. And we've expanded the longitudinal study. We're testing bats every 2 months over a 2-year period. We've collected those samples as well. So the study's been done and we're in the process of testing. So hopefully next time we speak, I'll be able to share some data with you about what we find in exposure rates in people and in these longitudinal studies of other bat populations to see if we're seeing similar patterns as what I described before. And then we're also collecting environmental urine to look at the genetics of Nipah virus and get a better understanding of viral diversity. So now just to wrap up here, but really to zoom out, why we have to pay attention to Nipah virus and Henipaviruses in general is this is the distribution of the bat hosts and associated Henipaviruses that we're aware of. And notice that it is, they've been detected in bats throughout South and Southeast Asia, and there are African species of bats that we know carry Henipaviruses. And so the area of potential spillover is much greater than what we have seen so far, which is really only 4 countries, the Philippines and Malaysia, Bangladesh and India. That's really where we've seen human spillover, and not counting Hendra virus, but that's in Australia. So the potential is much greater, and we simply don't have adequate surveillance right now to understand whether spillover is happening in parts of Africa, whether there's outbreaks of acute encephalitis that we're simply not aware of. And going back to my opening comments, the reason this is so important is that if we're not paying attention and a version of Nipah virus spills over into people that is more transmissible, we will be way too late to be able to try to contain something like this. And this is a virus reminder that has a case fatality right now on average of about 70 to 75%. So this is the one that we really have to keep our eyes on. And we have seen evidence of spillover in other places. In Africa, there have been studies that have found Henipavirus antibodies in pigs, like in Ghana. We know that in Eastern India and Nagaland, people have antibodies against Henipaviruses and filoviruses who harvest bats. So there are hunting communities in Cameroon that have been found to have antibodies against Nipah virus. So spillover is happening, and we're just not simply paying enough attention. And so what do we understand drives spillover? What are the things that really facilitate it? So it isn't simply having bats that puts us at risk, having bats in your backyard. Okay, that's not the only thing. We have to have a route of transmission. We have to have some interface that puts us into contact with bats. And in this case, it's bat excretia. It is not direct contact. People don't get Nipah virus from being bitten by these bats, or probably not from handling these bats, but really from most likely consuming something that is contaminated with urine or saliva or feces that has Nipah virus on it. And so, as I mentioned, wildlife provisioning is a big thing. These bats feed on the fruit that we do. Date palm sap clearly has been a human-provided food source that leads to transmission. Livestock production without adequate biosecurity, so where we graze our animals, feeding them dropped fruit, creates risk of exposure to Nipah virus in livestock that could then get infected and infect humans. Deforestation is a driver of Nipah virus spillover because we know that the bats that carry Nipah prefer to live in fragmented forests around people. So as we move into more naturally forested areas and start to cut down forest, we're creating an edge where bats are going to be attracted to roosting. And there's a question of climate change. There's starting to be some data to look at, the correlation between climate and temperature and outbreaks in Bangladesh. And there's some evidence that cooler and drier months have been associated with more spillover events. In Australia, we've seen Hendra virus spillover in horses spike during El Nino events when there's times when there's a food shortage for bats and bats are nutritionally stressed. They tend to shed virus more frequently. And so climate change can precipitate that. And a really interesting study that was done by Colin Carlson projected using climate models about mammalian host intermingling and what would happen under different climate change scenarios. So this is a map that shows the diversity of hosts for zoonotic viruses and where sharing tends to happen. This is where wildlife hosts tend to intermingle with each other and viral exchange occurs. This is current. And when we project out with climate change, what we see is that animals are going to move under climate scenarios, 50 years into the future as temperatures get warmer, as food resources shift, and where we project the highest intensity of viral sharing among hosts is going to coincide with some of the most populous places on Earth, like India and Bangladesh and Southeast Asia and parts of Africa and parts of the Americas, where you're going to have amplified host sharing. You're going to have new host sharing, meaning animals are moving location based on climate change, coming into contact with other mammals they don't normally come into contact with. And this is going to drive viral evolution. So this isn't specific to Nipah virus, but this is saying that as climate change is occurring, it's going to change the landscape of zoonotic virus hosts and force viral evolution as new sharing occurs. And that's going to happen. That's going to coincide with where human population centers are. So we expect to continue to see an increase in spillover events. And so just lastly here, I wanted to highlight how we think about approaching Nipah virus surveillance in the region. And this was a strategy put out by WHO just a few years ago that is a regional strategy for countries in the Southeast Asia region to think about Nipah virus. And it talks about countries like India and Bangladesh that have had human cases and know that Nipah is in the bats there, and countries that know they have the bats but haven't had human cases, and how countries should perform risk assessments. So I would encourage everybody to look at this document, which is available online. But the key insights and recommendations are that although Nipah has only been reported in 4 countries in humans, we know, as I showed you, that it occurs much more widely in different bat species and throughout South and Southeast Asia. So it is something we have to be aware that is present. This is not a situation where Nipah is going to move from one country to another. It's already there. It's already in the bats, and we have to recognize that and perform risk assessments to see whether we think there are interfaces where spillover may occur. And it's vitally important that we understand how spillover occurs. So particularly in the Kerala context, this is something we really have to get at, because to really develop a prevention strategy, you have to understand what the main routes of transmission are. So setting up a risk assessment and focusing on how spillover does occur or may occur is important. Increasing One Health system capacity is a big recommendation. This is recognizing that Nipah is a prime example, an exemplar really, of a virus that involves wildlife, livestock, and people, and really requires a One Health approach systemically for detection, early warning, and response to outbreaks. And so getting that coordination going, which I know is happening in Kerala, and I know is happening, more broadly in the government and in Bangladesh, certainly. So this is good, but it has to continue to happen in the region to strengthen these One Health systems. Investing in reducing Nipah spillover, that is key, because we're still just developing medical countermeasures like monoclonal antibodies and vaccines, but our best bet right now is to figure out how to reduce the risk of spillover. And then we can worry about containing cases and clusters once they happen and reduce illness and death. The studies of Nipah virus as part of a One Health strategy should include socio-ecological studies. And I know that this is happening, but really understanding behaviors that put people in contact with bats and how they might get exposed through different food and dietary habits as well. Strengthening surveillance that includes people and animals, and especially wildlife, not just livestock, through interagency coordination, strengthening lab systems for detection. And I know that there's very good laboratories in India, but again, this is general guidance for the region. Co-creating behavioral change and risk reduction interventions. So real emphasis on including communities in the process of developing strategies so that there'll be good compliance, because they're strategies that allow people to, develop them in the local cultural context within a location. And then in advance, develop strategies for implementing medical countermeasures like monoclonal antibodies and vaccines as they become available. And the very last thing I wanted to bring your attention to is a new initiative by WHO, which is called the Collaborative Open Research Consortium. And this is an effort for every viral family, so in this case, paramyxoviruses, to bring together experts from around the world to openly share data, to try to coordinate research in a better way to improve efficiency. And the paramyxovirus work is led by ICMR, by NIV Pune, Dr. Nivedita Gupta here. And so this is really, India taking the lead on bringing together the global experts around paramyxoviruses. And there are subgroups looking at basic research, looking at models for paramyxovirus in animals. And so it's not just Nipah, but it's other viruses that, may or may not be known to be zoonotic yet, although Nipah is the prototypical one that we're focusing on, developing countermeasures, surveillance and epidemiology, ecological studies of bats, and behavioral research. So these are some of the efforts currently happening regionally, but wanted to highlight it because of India's leadership. So in conclusion, I hope I've convinced you that Henipaviruses are really worth focusing on and paying attention to as an important group of emerging viruses, so not just Nipah, but related viruses too. Understanding their distribution in natural bat reservoirs and understanding spillover is important for preventing outbreaks and emergence, particularly of more transmissible strains that could cause larger clusters and outbreaks. We need a One Health approach to address spillover prevention, first and foremost, but also surveillance and response to outbreaks and risk reduction strategies. And lastly, vaccines, monoclonal antibodies, and antivirals, all in various stages of development or availability, but this would be an important tool also for controlling virus outbreaks. So with that, I want to thank you very much for your attention, and if we have time, I'm happy to take questions.
Thank you, John, for a wonderful presentation. Like maybe we can take one question in the interest of the time. It was very exhaustive, and you made an excellent overview of the activities that is being done at Bangladesh. So, any questions from the audience?
I threw a lot of information at you, so.
Yeah. So can I ask you one question? So you somewhere mentioned that you are detecting non-neutralizing antibodies in domestic animals. Any particular significance for that non-neutralizing?
Well, it's a good question. This was these were tests done on a Luminex assay using purified glycoproteins from Henipaviruses, and we saw reactivity. So the significance is that these animals are reacting to exposure to something, but whether it's Nipah virus or something related, we don't know, and they don't appear to be neutralizing. But we have to do neutralizing assays, and that's something that wasn't done. And so just functionally, it's possible that these animals also had neutralizing antibodies. And I will say there was no history of severe disease in those pigs. And so whether that means it's a less pathogenic strain or it's a different Henipavirus that's not pathogenic, we don't know. So we have to continue to do surveillance in livestock and see if they're being exposed and to what.
Okay, thank you. Let me ask you one more question. So can you explain the waning immunity with the seasonality something?
Yes, so waning immunity in bats is important because as an adult bat gets infected with Nipah virus and develops antibodies, those antibodies protect from reinfection. And when there's a herd immunity, when the population of bats has a seroprevalence of, let's say, 70 or 80%, it's unlikely that there will be a Nipah virus outbreak in that colony until the population level immunity declines and drops below a protective threshold. So why that's important is, let's say you go out to a bat colony and you do surveillance and you test blood for antibodies and 80% of those bats have antibodies. I wouldn't worry that there's going to be a spillover event in that location in the near term. Maybe 1 or 2 years, if immunity drops, then I'd pay attention. Versus if I go out and I test a bat colony and I find that 20% of the bats have antibodies, that means 80% of the bats are susceptible to infection. And that could be ripe for an outbreak. And I would pay attention to interfaces and people around that bat colony because that's more likely that an outbreak will occur, which is when spillover occurs. So that's the importance of waning immunity. And it means that bats can get reinfected. And so it's not like we're going to see outbreaks in a location once and never again. It's why we see repeated outbreaks in places around Kerala or around Faridpur, Bangladesh, because bats can be reinfected.
Yeah, I have one more question from my colleague here.
Hello, good evening. This is Sri Lakshmi. Hi. That was an excellent talk. I just had one question. Like, we have an observation that there are bats which are viral RNA positive. They do also show antibody positivity. So, like, do you have any idea, like, why it could be?
Yes, that's
as you said earlier.
Yeah, thank you for that. So, can bats have antibodies and still be infected? Yes, and it's interesting because we don't know to what degree a titer is protective in bats. And so we might detect, say on an ELISA, that a bat has antibodies, but that's a binary response. And so those antibody levels might be very low in that individual animal. And that would allow for virus to replicate, and perhaps the bat's innate immune system hasn't cleared the virus yet. Alternatively, it's possible that you can detect fragments of virus on PCR, but the bat is not actively infected. So perhaps the bat was infected a week or two ago. There's a titer, so you're detecting antibodies, and the PCR test, which is very sensitive, is picking up PCR remnants of viral RNA, much like with COVID, where you could test positive on a COVID test weeks and weeks after you're actually actively infected. So that's another explanation for why you might see both PCR positive and antibodies.
Thank you, John, for that excellent talk. So, see you sometime in Kerala whenever you visit India. So, we welcome you to visit our state also sometime.
Thank you so much. I would look forward to that, and hope you all have a very productive rest of the conference. Good evening.
Thank you. Thank you. Good evening.
We next move on to the next speaker of the session, Dr. Srilakshmi Mohandas. Dr. Srilakshmi Mohandas, scientist at the Maximum Containment Facility of the ICMR National Institute of Virology, Pune, works extensively with high-risk viral pathogens including Nipah virus. Trained in high containment laboratory operations, her research focuses on viral pathogenesis, development of animal models, and medical countermeasures for priority pathogens. She has been an integral part of India's Nipah outbreak response teams and has led bat surveillance studies across the country. Her work contributes to understanding zoonotic spillovers and strengthening national preparedness. Dr. Mohandas is a recipient of the prestigious NAS Associateship from the National Academy of Agricultural Sciences. We invite you, Dr. Srilakshmi, to the scientific session.
Do you have pen drive? Shall I begin? Okay. Good evening, everyone. I thank all the organizers for giving me the opportunity to present the work. My work is like mostly the content of this presentation has been presented throughout today, and also like that is why I think this will be like a refresher for all of you. And my this talk will be focusing more on the ICMR initiatives or the work which has been done by ICMR like for adding up the information regarding Nipah in India. So as a brief introduction, you all know that what Nipah is and what it has caused in our country. So mainly this virus, like the main concern is the reservoir host, that is the Pteropus species bats. So how you can get infection from Pteropus bat, the cycle of transmission has been proven in case of Malaysia as well as in Bangladesh. Also in Philippines, there was a report of Nipah virus infection, and it was thought to be due to contact with sick horses. So in Malaysia, it was through the infected pigs, which served as an amplifying host, transmitting it to humans, whereas in case of Bangladesh, it was by consumption of the contaminated date palm sap. And all these South Asian as well as Southeast Asian countries, they comes under the high disease risk transmission for Nipah, especially because of the ecological characteristics as well as the presence of this reservoir host, which is persistently infected with Nipah virus. If you look into the Nipah virus outbreaks which has occurred in India in the past, we can see that the outbreaks has concentrated to two different geographical locations. One is the eastern part of the India, that is the region more close to the Nipah belt of Bangladesh, the West Bengal state, and all the outbreaks have concentrated to the southern part of the country, that is in Kerala. From 2018, we have seen multiple outbreaks, and even today we are facing Nipah virus outbreak. And I can take you back to all these outbreaks which have occurred in India in the past, and the relevance of discussing about the spillover in those contexts. So the first outbreak which occurred in Siliguri in West Bengal, that time there were more than 60 cases during that outbreak. In the outbreak, it was outbreak occurred as a febrile illness associated with altered sensorium, and that the point to be noted is that the source of infection was unknown during that outbreak, and during that outbreak there was no diagnostic facility available in India, and the outbreak was undiagnosed. Later, with the help of CDC, we could confirm that this outbreak was due to Nipah virus. And after 6 years, again in 2007, another outbreak occurred in the same state but in a different district called Nadia. And this outbreak also, it occurred as a sporadic outbreak within a family. 5 cases were there, and there was 100% case fatality rate. Here also the source of infection was not identified. But one important thing is that by that time at India, we could develop the suitable infrastructure for diagnosis, and the outbreak could be diagnosed very faster, and with the establishment of a BSL-3 facility at ICMR NIV Pune. If we look after this for many, this outbreak also we couldn't find the source of infection. So coming to the reservoir host, till that time there were no reports of the presence of virus in the reservoir host in India. So after this two outbreaks, ICMR NIV has taken initiatives to conduct surveillance in the affected state, that is in the northeastern region of India. So in 2009 there was surveillance in multiple species of bats, fruit bats. All these bats. The bats, species, fruit bats which were surveyed during that time are like mentioned here, the Pteropus medius, Rausetus species, Megaderma lyra, Cynopterus sphinx, all are the fruit bats which are present in our country. And during that survey, we could find that Nipah viral RNA and IgG positivity in the Pteropus medius fruit bats, but not in other bats. And this survey occurred in 2009. After that, and from this bat also we could sequence the genome of the Nipah virus, and it was found closely matching to the Nipah virus Bangladesh isolates which were prevalent during that time. And again, another survey was conducted by ICMR NIV in 2014-15 time, and this was also focused on a northeastern region, the Jalpaiguri and Dhubri district of Assam. These are the areas which are very close to Bangladesh, and from these two sites, both from Dhubri as well as from the Jalpaiguri, we could detect both viral RNA as well as antibody positivity in Pteropus species bats. Again, we tried to understand whether the other intermediate host which was reported for Nipah during that time, that is a pig. So more than 1,700 serum samples of pigs were also tested for antibody positivity, and we could not find any antibody presence in the pig serum samples which were collected from the Mizoram as well as Assam state during that time. So the Nipah remained a mystery after this. But surprisingly, after 10 years, we found Nipah virus infection coming to a very different location, that in the southern part of India, that is in Kerala. That time also the source of infection was a mystery, and that time NIV has undertaken a survey in the Perambra region where the report was, the first outbreak was reported, and that time surprisingly we could find that 25% of bats which were sampled during that outbreak had viral RNA in their throat swab as well as rectal swab samples. So these bats were actively shedding the virus during that outbreak. And again in 2019, the second outbreak occurred, and this time the outbreak was in a different geographical location. That is in the patient was from Ernakulam, and he had travel history to Idukki. That is why these two region was surveyed by the NIV team, and we could find that antibody positivity as well as rectal swab RNA positivity from the bat samples which were tested during that time. Subsequently in 2021, again the outbreak resurfaced in Kozhikode, again in another district called Chathamangalam. Then in 2023, again in Kozhikode, and in 2024 in Malappuram. And NIV consistently tried to understand the presence of the virus in the reservoir host, that is the Pteropus medius bats. As during these surveys, we could also sample some different fruit bats like Raucetus species which are prevalent in India, but we couldn't find any neutralizing antibodies in Raucetus species, but we could find non-neutralizing antibodies, as the previous speaker said, in the Raucetus species. But Pteropus species bats were consistently showing viral RNA or antibody positivities during all these screening. If we break down this sampling again in terms of the outbreak period as well as non-outbreak period, during outbreak period we could consistently see viral RNA positivity during the months between May and September. We can see the outbreaks were occurring between the months of May and September. So in the month of May, June, July, we could see the viral RNA positivity in bats as well as we could see the antibody positivity. But during the non-outbreak season sampling, we could not find any viral RNA positivity. That is the one observation we had. Again, one question came that we can see the outbreaks in the eastern part of the country as well as southern part of the country. But the Pteropus species is a bat species which is prevalent throughout our country. Throughout the Indian subcontinent, Pteropus species bats are present. So we had undertaken a study, that is a cross-sectional survey throughout the country, and it started in 2019, and unfortunately we couldn't do the sampling in 2020 as well as 2021 during the COVID pandemic. This study was stopped. After that, we again restarted the study in 2022, late 2022 up to 2024. And during the survey, we could sample more than 17 states and 1 union territory, and around 30 different sites were surveyed during this sampling from different geographical locations of the country. And from 4 different states, that is in Kerala, Uttar Pradesh, Bihar, as well as the West Bengal, we could see the viral RNA positivity in bats. And again, when we checked for the seropositivity, the rate of seropositivity was more, that the entire belt of states in the Western Ghats, like Goa, Karnataka, Kerala, and in parts of Tamil Nadu, Pondicherry, Maharashtra was also seen seropositive, and also the other belt, that is from Uttar Pradesh, Bihar, and the northeastern states, 3 northeastern states, all these states were showing seropositivity, and we had tried to understand whether they are neutralizing antibodies also by the live virus neutralization assays, and we could find that these are neutralizing antibodies which are neutralizing live Nipah virus from India. So another study we tried to look at was a cross-sectional survey in the Kerala state, and during the 2023 we had done the study, and the idea was that the outbreaks used to always cluster between between the months of May to September, but there was always a speculation that there is seasonality in the virus shedding, but for such understanding we require longitudinal studies sampling the bats consistently for longer period. But this, as a pilot study, we try to understand 3 different months, that is in the February, July and September months. More than 250 bats were sampled for this study, and this sampling was done from 7 different sites in the Kozhikode. Here you can see the red marked are the locations where the outbreaks occurred in Kozhikode, and the other blue marked symbols as well as the red symbols are the sites of the bat sampling. And these were the 7 different routes from which we sampled the bats, and all these routes came within the 60-kilometer radius of the outbreak location. And we could find that out of these 7 sites, 2 sites showed viral RNA positivity, but those were in the July and September months, not in the February month. Also, we could see that the seropositivity in bats during the July and September months, these were higher compared to the February month. So, if I summarize all these different outbreaks which have happened in Kerala, consistently from 2018 to 2024, we had seen the reservoir host, that is the Pteropus species bats within the vicinity of the index case house or the nearby the outbreak region, and we had found the Nipah virus positivity either in the form of RNA or antibody in the reservoir host. But the one mystery is that how this gets transmitted from bats to humans. That link is not established. One thing which supports that this virus comes from bats, one more thing is that the genomic analysis. So we over the period of time from 2007 to 2023, all the bat sequences which we had observed where we analyzed, we could find that in 2007, the West Bengal sequence of the human patient, it was closely similar to the West Bengal isolate sequences from Bangladesh, and and also it was similar to the bat sequences which we could obtain during the 2009 sampling from the Jalpaiguri West Bengal region. In 2018 Kerala, the sequences showed the sequences which we obtained from the bat samples as well as the sequences from the human patients. They were showing more than 99.7% similarity. This also points to that the virus which is being present in the bats and which has infected the humans were same. And all in the subsequent years also we had done sequencing of the bat viral the viral RNA sequences which we could obtain from the bats. All of this were showing very close homology to the Bangladesh genotype, and within the Bangladesh genotype, our Indian sequences, especially the sequences which we obtained from the Kerala, they were forming a subclade. And here you can see at the right hand side and the third cluster, that is the Indian sequences. From the Kerala, all these sequences, they mostly cluster as a subcluster within inside the Bangladesh. And if you check the genomic change within them, it is more than 97% similar to the Bangladesh sequences, but it is different from the Malaysian sequence. So all these points to that there is the virus which is present in the bat is getting transmitted to humans somehow. So how it get transmitted? I have taken some references which is available in the public domain, where we can, some hypothesis of transmission, which unfortunately during every Nipah outbreak, the index case history, that remains always unknown. Most of the cases, the index case succumbs to the infection or the proper history of like exposure is not available. That always limits the understanding of how the spillover happened. So one paper describes the Nipah virus infection in humans in Kerala in India, hypothesis of airborne transmission. The authors were like of the opinion that like intense bat density at some places and the secretion or the excretions of the bats in higher amounts getting excreted at high density by a high density population and the humans passing by getting infected through airborne route. This was one hypothesis by them. The other thing is the human behavior. We all know that like in any Keralite will be knowing that every our house will be having a lot of fruit trees in the backyard. So the chance of getting getting contact by a contaminated fruit and the human being is very common. Also there are a few crops like cashew crops, cashew where the cashew, I'm not, sorry, not cashew crop, the cashew plantations where a lot of cashew fruit will be there, and in such cases, in such plantations there will be large number of workers going to gather such fruits because of its commercial value. So in such context there will be large chance of interaction of the human and bat in such plantations. So that was one hypothesis. One more thing is that we have seen there is a lot of climate change which is happening in all over the world nowadays, and because of that, impact of the climate change can also affect the bat habitat. Many of the times due to the after 2018 we have gone to the Kozhikode and the nearby areas for bat sampling multiple times. So one of our observation is that many of the times there we can see that bat colonies migrating from one region to other. Sometimes people cutting down the bat roost. Sometimes they are bursting crackers and trying to remove the bats because of the fear. All these things can create bat migrating from one region to the other. That can also pose a threat that the migration of bats to a newer region where the bats, positive bat colonies are not available. That can cause. One more thing is that nowadays there are a lot of cultivated food resources. A lot of people are coming up with fruit plantations. So these can attract bats to come and interact more closer to human. All these cultivated food resources, they also pose a threat of spillover if we look into. So the other one hypothesis, what are the other hosts which can be involved? In Malaysia, we have seen that pig act as an intermediate host, amplifying host. But such a host is there in our country, is the presence of such a host is not yet studied. And we don't have much studies on such intermediate host, and we don't have any history of such intermediate host during our previous outbreaks. So such surveillance has not been done. So we don't know yet, is there any other host involved for the transmission other than this direct transmission from bats to humans. So that is one thing. And in the last picture, you can see that cats. This is one observation from Bangladesh where they have seen that cats were found to be positive of antibodies for bats because there are reports that cats can eat bats because of their predatory behavior. They can eat bats, and because of that contact with bats, they can also have the antibodies. And there is one experimental study which have shown that Nipah virus can replicate in bats. So such domestic animals has not been tested in our country. So we don't know about the possibility of other hosts also. So these are some of the hypotheses of probable routes of spillover which can occur from bats to humans. So considering all these, with the collaboration or with the collaboration with multiple different stakeholders from Kerala state, one study was initiated last year. This is ongoing study to understand various spillover risk factors in the Kozhikode, Kerala. Under this study, we were planning to screen different probable risk factors like fruit materials, toady samples, and bat samples from the vicinity of Kozhikode where the Nipah outbreak has been reported. And we have done sampling 2 times during the non-outbreak season, that is during the November as well as during the February months, we have done sampling. We had collected more than 250 bat-bitten fruits as well as toady samples. And all these samples, when they screened for the viral RNA by PCR, we could find that all of them were negative. But then outbreak season sampling we have not done. Also, we are planning to undertake an epidemiological study to understand the spillover risk factors by interviewing people, how they are, like, what is their level of exposure with these kind of materials. And one more thing, if we compare to the Bangladesh and India regarding this palm sap consumption, Bangladesh mostly it is the palm sap, and it is all you might have seen in the earlier video the pot which is used for collecting palm sap is exposed like this. But in our cases, mostly the coconut palm sap collection, the pots are like in an inverted pattern. So this also hinders the entry of bat into that. But in case of this other usual palm sap, the pot is hanged in a manner that bat can easily enter. So because of the ample availability of the fruits, the bats may not access these kind of food resources. In Bangladesh, during the winter time, because of the shortage of fruits, mainly bats go and feed on these type of resources. So in our state, there are no reports of observation of bats feeding onto palm sap or the coconut sap. And also there is a common thing we can see that in every backyard in most of the places you must have seen that bats coming and drinking the honey of the plantain or the banana plant. So this type of interactions, like bats are normally they go and roost in very tall trees or very tall, they eat fruits from very tall trees. But these type of small trees, when they come and frequent, they are at very more easy interaction of the bats and humans can occur in case of such kind of feeding. So all these things like all my previous speakers said, that a One Health approach is very important in case of Nipah virus prevention. And we, in the past many years, we have seen that we don't have a treatment for this particular infection. So there should be more development of developments in that direction, like there should be antivirals or there should be vaccines to prevent the infection. So for that, multi-sectoral collaboration or foreign collaborations are involved. And also the other approaches like early detection of the case and containment, that in that aspect Kerala has excelled very well during the past many outbreaks. But in case of surveillance, we don't have a proper human surveillance, or after the 2018 outbreak, syndromic surveillance like AES surveillance has been strengthened in our state. But such kind of surveillance is not present throughout the country. And our countrywide survey has shown that many parts of our country is at the risk of spillover. A broader region is under spillover, at the risk of spillover. But we don't have such kind of even syndromic surveillance in other parts. And ICMR has taken up some initiatives to start syndromic surveillance in the Kerala as well as in the West Bengal region of the country as part of their VRD, as part of the VRDL network. But in other parts, such surveillance is not there. And one good thing about the Bangladesh is that they have a running active as well as passive surveillance system in place, so that cases can be detected very early. But in case of our country, we don't have such any active or even passive surveillance systems existing. So such kind of surveillance systems should come in place. It should not only be restricted to human surveillance, it should include both animal surveillance, human surveillance, the reservoirs. We should look into other reservoirs for infection to solve the mystery of how this spillover happens. And also the risk factor dissemination, how we communicate the public regarding the risk factors. All these things are very important. For all these, multiple sectoral involvement is important. And there are ecological drivers of transmission also, how bats come into our backyard. So all these things has to be studied in different point of view. To study bat ecology and all, we need ecological experts. To understand climatic change, we need such experts. So different stakeholders has to be involved to understand the whole situation. So that is why this kind of approach is very much important. In the past outbreaks, our state has excelled in in a very good way in early detection of the cases as well as the containment of the Nipah outbreaks. So even if some outbreak occurs, all these multiple stakeholders have involved in outbreak management, community support, source identification, and developing suitable guidelines. So this kind of approach has to be put into other sectors also, like identifying the spillover mechanisms and involving other agency to understand the other mysteries which are not resolved in case of Nipah virus. And so after the COVID-19 pandemic in 2022, the government of India has come up with this national One Health mission. Morning, Dr. Simi madam was also saying about this. So this idea was also in the similar concept of a One Health approach. And this main goal of this national One Health mission is pandemic preparedness, integrated disease surveillance, joint outbreak response, strengthening routine prevention programs. For this involves multiple ministries, government organizations, and as well as national and international partners. And this is being coordinated by the Office of the PSA, Government of India. So this kind of approach will give chance for every department and to put into their strengths in solving mysteries like this. And this National Joint Outbreak Response Team, which is investigating the outbreaks currently in case of Nipah also, that also is formulated by the National One Health Mission. So this National One Health Mission has also have come up with some projects like strengthening the diagnostic capacities and strengthening the containment facility network within our country for pandemic preparedness, and they have trained more than 13 BSL 3 level labs for preparation of pandemic throughout the country. So such kind of initiatives are coming up in our country. So we have to in Kerala also we have a National One Health Center for Nipah. All these initiatives always focus on for intersectoral collaboration. So more such collaboration should come, and they should try to solve this kind of situations which are happening frequently in our country. So I would like to summarize what are the key knowledge gaps which I have identified and which we can use the One Health approach to solve it. One thing is that there should be more epidemiological studies to identify consistent risk factors which are causing the Nipah virus transmission from bats to humans. Then one thing which is lacking in our country is the studies on bat ecology, their behavior, what kind of resources they are foraging on, their migration mechanisms, etc. Because Pteropus medes bats are prevalent throughout our country, and the presence of virus has also been detected from many parts of our country. So understanding all these things is a very critical thing for understanding the Nipah virus spillover. We have to adopt active surveillance and strengthen the passive human surveillance strategies across the country, not only in Kerala or in Bangladesh, across the country to identify and detect and for early detection of the Nipah virus cases. Surveillance in other domestic animal species. This can give us some idea about is there any probable intermediate host or any amplifying host for Nipah in the country other than the reservoir host. And we have all these things can be, data can be integrated to understand or do some modeling studies to predict the disease hotspots or the early outbreaks. Also long-term studies to integrate, to investigate whether this land use or climate change is driving greater overlap of bats and people and driving greater stress and viral shedding from the bats. So these are the few points I would like to highlight, and these are some knowledge gaps where we can put into this One Health approach, and that will help us in enhancing the knowledge about Nipah virus transmission or Nipah virus outbreak in our country. So with this, I would like to acknowledge the work which I presented. This has a lot of different stakeholders, including the ICMR, the Kerala Public Health Hospitals, NIV Pune, Maximum Containment Facility from where I'm coming, and all the funders for our work. And I would like to thank everyone. Thank you.
Thank you, Sri Lakshmi, for a wonderful presentation. So if there are any very pressing questions, we will go for it. Otherwise, we need to end the session. So any very pressing questions from anyone? So since you happen to be the last presenter and most of these topics were covered, maybe they don't have any more questions to be, or questions or clarifications. So thank you for the presentation.
I now invite the chairs of the session, Dr. E. Srikumar and Dr. Anish T.S., to hand over a small memento to Dr. Sri Lakshmi for her talk on Nipah viral spillovers, and Dr. Biju Soman for the enlightening talk that he gave on One Health, data science and our software. We have come to the end of the one-day seminar on Nipah and other zoonotic spillovers. As we move to the valedictory function, I express my sincere gratitude to all the delegates, invitees, and participants who joined us till this hour. A little more to go. We have the much-awaited prize distributions for the podium and poster presentations. To distribute the prizes for the podium presentations, let me invite Dr. E. Srikumar, Dr. Aravind R. and Dr. Anish T.S. to the dais. I request the participants to come up on the stage to receive your cash award as I call up the names. For the podium presentations, first prize, Anna Kurian, OP number 3. Second prize goes to Dr. Shiva Prasad, OP number 12. We have third prize shared by 3 participants. Anju V. Manoharan, OP number 4, Vinitha Shaji, OP number 5, and Dr. Nida TR, OP number 9. Please come up on the stage to receive the cash award. Dr. Nita TR. Dr. Nita TR. Vinitha Shaji. Thank you, Dr. Anish, for joining us in the prize distribution. Next, let me invite Dr. Mohanan Villavital and Dr. Sri Lakshmi Mohandas, also with Dr. E. Srikumar, to the dais to distribute the prizes for the poster presentations. First prize is shared by 2, Anuja S. Nair, Poster presentation number 1 and Amog OT poster presentation 4. Second prize goes to Kartika Rajivan, poster presentation number 7. Third prize, Dr. Ashwati Ravindran, poster presentation number 10. Congratulations to all the winners and the participants. Thank you, Dr. E. Srikumar, Dr. Mohanan Velivital, and Dr. Sri Lakshmi Mohandas for joining us in the prize distribution ceremony. Now let me invite Dr. Priya, Scientist C, Institute of Advanced Virology, to formally thank the gathering.
Good evening all. I am very much delighted to extend vote of thanks to this August gathering. First of all, I would like to thank our director, Dr. E. Srikumar, for sharing such an idea and for his constant support and guidance throughout the execution of the program. And next, I want to thank Professor K.P. Sudhir. Due to his busy schedule, he couldn't make it here in the morning, but he was constantly supporting us throughout the event. So I thank him. And now we had Dr. Rajan N. Khopragade, IAS, ACS, Health and Family Welfare, Government of Kerala. He came here in person and delivered an excellent speech, and we were so excited to hear about his ambitious speech about IAV. So we thank him in person. And then we had Dr. Simi Tiwari, who was Joint Director and Head, Center for One Health, National Center for Disease Control, for coming here, for accepting our invitation and coming here and gave us an excellent talk. And now I want to thank all the other speakers, including Dr. Guruprasad R. Medigeshi, Dr. Shobha Maman, Dr. Umar Karadan, Dr. Sheen Job, Dr. Biju Soman, Dr. Sri Lakshmi M, and Dr. John Epstein, Dr. Emily Gurley, and Dr. Vidya Rangley to join us in offline. And I want to thank Mr. Manoj, our administrative officer, for his constant support and guidance throughout the program, and all the team, including the administration team, finance team, and the technical team for supporting us throughout the program. And then we had our senior faculties, my fellow faculties, and all the members of Team IAV for putting up a great show. And I want to thank all the participants who joined us online and offline for this program and made this a very productive one. Thank you. All of you, please stay back for a group photo.